I now request Mr. Gautam Khanna to give a 2-minute opening remarks for the day, for the conference.
Thank you and good morning, everyone. So I can see that people are still, we had a very foggy morning today, so people are still trickling in, but nevertheless. So let me just first thank all of you for the third day today of the FICCI HEAL conference. So we've had exciting days, day before yesterday and yesterday. And let me first tell you that today we are happy that along with Niti Aayog, we have the logo support of the Ministry of Health and Family Welfare, Government of India for this conference. So as you know that the masterclass on Monday was a great success. Yesterday we had wonderful deliberations throughout the session, and it was a privilege to meet and hear Honorable Vice President of India, Shri Jagdeep Dhankar ji, and he emphasized, as some of you have seen in the tweets which has come, that healthcare is one of the most important pillars of nation building, impacting not just the economy but productivity, well-being and happiness of citizens. And I can't remember exactly what he said in Hindi, the phrase, but essentially what he said was, "Pehle nirogi kaya, uske baad maya." So health first and then wealth. And
Gautam, somebody is here who you want to, she wants to stop that.
Sir, he said, "Pehla sukh nirogi kaya, duja sukh maya." So healthy body and then the healthy wealth. Thank you, sir.
And we also had Dr. V.K. Paul from Niti Aayog and Dr. Sunil Kumar from Johns Hopkins with their noble and innovative thoughts for transforming the healthcare sector, along with two knowledge papers we released, one with KPMG and one with ENY. And the KPMG paper which we released, we will have some discussion relating to that today now. And we also had a discussion on the primary healthcare, the smart health and wellness centers, as well as the evolving diagnostic and medtech space, which was very, very interesting. The evening was a fun evening yesterday with the FICCI Healthcare Excellence Award ceremony at the Hotel Lalit with the Honorable Cabinet Minister Mrs. Smriti Irani, who, as you heard, was speaking very eloquently about the need for partnership. And she gave us examples of how in her constituency in Amethi, 21 doctors handled 44,000 pregnant women during COVID crisis and examples like that. So today we have an interesting day and a full day ahead with more panel discussions, and now starting with the workforce strengthening. Then we have on oncocare, medical value travel, Heal by India, and importance of cost quality balance, and lastly the digital health sessions. And also I saw there was a lot of networking happening, which is a great thing in the sector. We are all meeting after many years. I think it's a great opportunity for all of us. So with that, let me hand over to Mr. Lalit Mistry, who is the partner and co-head for healthcare sector for KPMG India, who has championed this report which was released yesterday. He will lead the panel discussion and introduce the speakers on strengthening the healthcare workforce. Lalit, over to you.
Thank you, Gautam, and very good morning, everyone, and very warm welcome to our very own, very good friend, Dr. Manor Agnani, sir, Additional Secretary, Ministry of Health. He's been in this field for a pretty long time, working both from a medical fraternity perspective and also from the policy reforms and the implementation of some of the initiatives from the government side, both at a state level and a central level. So very warm welcome, sir. It's a privilege to have you here, and we are looking forward to hear some of the interesting work that government is currently doing and how government thinks about the future roadmap for strengthening the healthcare workforce of this country, which is the agenda of today's panel discussion. The agenda is the strengthening the healthcare workforce for this country and putting a roadmap for the next 25 years, looking forward that how the healthcare workforce, which cuts across both public, private sector, urban and rural, across the streams, and what are the initiatives that we need to do, what are the engagement that we need to put forward, and how can we leverage all the stakeholders going forward, putting up a roadmap for achieving this target, the gaps that we have. And what we intend to do is not only to bridge the gap today we have in the Indian health system, but also to become an export house for the healthcare workforce to the entire world. Where we are already a export house or a pharmacy of this world, and the way we are, I think India has the potential to become export house for providing doctors, nurses, and the healthcare workforce to the entire world. With this, let me introduce the panel here today. We have Dr. Manor Agnani. He's an IS officer, Additional Secretary, Ministry of Health and Family Welfare. He's also a chairperson of Interim Commission for Allied and Healthcare Professions, which is mainly focusing on the allied healthcare professions and putting up a roadmap, putting a governing structure to it, and he will share more details on this. He joined the Indian Administrative Services in 1993, and thereafter he has worked in the capacity of the Government of Madhya Pradesh and Government of India at different levels. He is a medical doctor with a master's degree in international health from the University of Copenhagen, Denmark, and it's a privilege to have you, sir. And we have taken a lot of guidance and working together during the COVID times. He had played a very important role there. Yeah. We also have today our other esteemed panelists. We have Professor Meenu Vajpayee, Honorary Executive Director, National Board for Education Management in Medical Sciences and Head of Department of Pediatric Surgery, AIIMS, New Delhi. We have Dr. Sanjeev Singh, Medical Director, Amrita Institute of Medical Science and Research Center. We have Professor Mahesh Verma, Chairman NABH and Vice Chancellor Guru Gobind Singh Indraprastha University. We also have Dr. Narottam Puri, Principal Advisor, Quality Council of India, and also an advisor to medical on Fortis Healthcare and advisor to the Healthcare Services FICCI. We have Dr. Santosh Shetty, CEO and ED Kokilaben Dhirubhai Ambani Hospital, and I also have my colleague Mr. Michael Allen, Global Lead for Future Workforce in Healthcare from KPMG International, hopefully joining us online. He will join us online for this to bring us a global perspective on the healthcare workforce from across the globe and practices that we have to share here. With this, let me invite Dr. Manor Agnani for his starting note for this session and to share the perspective about what the government is doing and how the public and private sector could work together on this agenda.
Thank you, Lalit. Good morning. I am privileged to be here because this is something very important which we are going to discuss in next couple of hours. So, as was introduced, I am Additional Secretary in the Ministry of Health and Family Welfare, and recently I was appointed as Chairperson for the Interim Commission for Allied and Health Professions, which is the subject which we will be discussing in detail today. I have gone through the excellent report which was released yesterday by Honorable Vice President of India, and Lalit, being a good old friend, I thought that I should read it word by word before coming to this meeting. It's an excellent report, and I must say that healthcare sector is so fast evolving. So many things are happening, not only in India but around the globe, so rapidly that's very difficult for somebody to actually sync with on day-to-day developments. So I will try to bridge that gap which is missing on the recent developments on this healthcare workforce. I will be restricted to 4 to 5 minutes, Lalit, and will try not to duplicate the things which I am expecting Dr. V.K. Paul and others would have said yesterday. So friends, you are aware of the importance of healthcare workforce, and I was saying that we are the youngest country in the world if you see the demography of the country, if you see the population pyramid of the country, we are one of the youngest nations. So that window of opportunity is with us, window of opportunity to serve the global community. So that's why keeping that thing, and we have the excellent service providers, excellent hospitals, both in public and private hospitals in the country. So we can provide that medical value travel, which Love will be coming to address and discuss in separate session. So keeping these two things in mind, we came out with the concepts of Heal in India and Heal by India. So there were detailed discussions happening. I will restrict to Heal by India part of it, and I am told that that's also a separate session, but part related to workforce of Heal by India. So way back in February this year, Honorable Minister Health and Family Welfare called all the stakeholders. So I remember all the regulatory commissions were there: National Medical Commission, Indian Dental Council, Indian Nursing Council, Pharmacy Council of India, and of course the allied health professionals were there. We had private sector, we had public sector, we had Niti Aayog, we had all the prestigious institutions representing there, we had people who understand HR. And the discussion was that how should we serve to the global community, taking the advantage of we being the youngest nation. And the basic thing which was agreed upon was that we need to work with the quality. So if we really want to serve the global community, it has to be quality driven, for which these medical colleges, nursing colleges, allied health professional colleges, pharmacy and others, they need to be given that mandate and support to provide the quality education around that. And many decisions were taken in that meeting which normally restrict these things to happen. I have many examples to quote, but then just an example of National Medical Commission restricting others schools to be in the same campus was could be good example. So the many decisions were taken, and it was resolved that all the recommendations of that 2 days Chintan Shivir Heal by India will be actually taken to the monitoring framework, and Dr. V.K. Paul, who is the member Niti Aayog, was given this responsibility of seeing what is the update on that. And I must say that many things have happened since that Chintan Shivir, which was done in February. So that's why I said that this is an excellent recommendations, and I could see some more recommendations which are reflected here, which we could not think. And most exciting was actually seeing a future where when all the regulatory commissions are together. So what to talk about bringing National Medical Commission and National Board of Examination together, but it talks about all the regulatory commissions to be together. So then excellent report. On human resources for health, you know that now the country is actually moving from the global community is moving from medical centric care to the patient centric care. So the importance of interdisciplinary approach is very, very critical and very, very vital. So that's where the Heal by India emerges, and we actually want all the regulatory commissions to work together and bring quality into the medical teaching as well. Need not to say that lot has happened in the recent past. If you see, the number of medical colleges have went up by 67%. I don't have the numbers to my memory, but significant progress in UG seats, which are almost 70%, 80% increase, and also the PG seats. And much credit goes to Dr. Vinu Vajpayee and team, because DNV courses have gone significantly, have been increased in the recent past, and we have a plan for increasing them further in the future also. Most important thing would be that not only we focus on the medical education, but also the nursing education and allied health education. So the concepts of task shifting and task sharing also emerged during that Chintan Shivir. So we must be very clear who is supposed to do what, and can we delegate those tasks which are suited to that profession. We should not see, for example, nursing doing anything, everything, around the hospitals. If you have 56 called allied professions, and how do we bring those allied health professions into the systems, not only in the public hospitals but also the private hospitals, and we create positions for them to be recruited, and then that health workforce which is trained together in that medical college atmosphere. So a vision is, can you see a doctor, a nurse, a dentist, a pharmacist, and dietitian, a physiotherapist, OT technician, occupational therapist, or data manager, all they are getting trained under one roof, under one campus. How it will help in making our resources optimized, and how the integrity of these professions, interlinkages of these professions and the learnings together will help in better understanding, and that can be an approach of task shifting and task sharing concepts can be introduced. So lot much is happening. I know that there is much is required to be done, not only in the public sector but also in the private sector. If we really want to serve the global community, we must also understand what are the norms for, say, doctor population ratio or doctor nurse ratio. We must revisit and see that our ratios are much more refined. So if suppose it says that you have to have one doctor for 1,000 population, we should think that we should have one doctor for 666 population. So out of 3 doctors we train, one can serve to the global community. And if it says that there has to be 1 nurse, 2 nurse for each doctor, why not to think about 3 nurses for each doctor? So 1 nurse we can spare to serve to the global community. And we are excited. We are getting some such proposals, which Love would be talking in details probably in the afternoon. I give you just one example to conclude, that the global Western world is actually aging. So their requirements of the workforce is something which is they are in need, and we can serve them and provide opportunities to our people. Case in example is the Japan. They asked for getting our nurses. The only condition they thought that if we can have them trained on Japanese language. So other courses which can be taught to these medical professions, not only for bringing the integrated learning, also some bit of administration, some bit of finance, some bit of languages also, while they are trained in the regular manner which is being thought of. So I will conclude here because we have a rich panel and they will be giving much more insight into this, and I hope that this session will be participatory. You will have so many questions to ask. Hopefully we will be try to do justice to this session. Thank you very much. Namaskar.
Thank you, Dr. Manohar Agnani, for this keynote and opening the session for us and giving an insight at what is happening right now with the government, what you intend. And we really are happy on behalf of FICCI and the entire team of who has written this paper that you have liked some of our suggestions, and we look forward to have interaction with you and be part of some of the, in putting up a roadmap and implementing that. Before we proceed on a panel discussion, we have a small presentation having a glance at what the key recommendations of this report are there. Can we have the presentation? Yeah. So, looking at the healthcare workforce challenges, the challenge is not unique to the India, but it's a global challenge. The Indian health system or any health system across the world, the biggest core and the crux of a health system is that you have a healthcare workforce to implement and run the health system. And that is what we came to know during the COVID times, that how our healthcare workforce was not only the most important resources, but also became one of the most vulnerable resources during that time for any country to sustain and put up a fight against healthcare crisis that we saw during the COVID time. As per the WHO, there is an estimated shortage that has been projected of 15 million healthcare workforce by 2030, mostly in low and lower middle income countries. And India there is no difference from this. India currently has a shortage of almost 1.5 billion healthcare resources, mainly covering of the doctors, nurses, and midwives. That's the biggest challenge. India has made a significant progress in the last 1 decade, where almost 83% of the medical institutions have doubled in last decade. 123% increase in the number of seats in undergraduates. There is a significant increase in the number of the DNB seats and the postgraduate seats, and there is a way forward on the nurses and allied healthcare workforce reforms that are underway with the government. But going forward, one of the biggest thing that India will have to look forward is that we need to bridge the availability of the healthcare workforce of almost 44.5 resources, which includes doctors, nurses, and midwives per 10,000 population. And at this moment, we are currently at 33.5 HRH, which consists of doctors, nurses, and midwives per 10,000 population. So there's a long way for us to bridge the existing gap. But that's not the only thing that we're facing. We also have a huge populations going forward in the coming decades to address to, and mainly the aged population that we will be looking forward and have to start preparing ahead. If we do not start preparing 1 or 2 decades ahead of it, I think we will be facing some of the challenges that some of the other countries are facing in the Western world. As Dr. Manohar Agnani has mentioned, that we will have to address not only the India's challenges, but we also have to play a role in addressing the aged population and healthcare needs of the global. Going forward, as per our estimate, if we continue to go forward and keep adding the number of doctors, nurses, midwives, based on the number of institutes that we have so far, by far we will be able to reach only this target by 2040, somewhere around 2040, which is almost a decade late than what we should ideally achieve by 2030. Having said that, definitely this all can be can be bridged faster with more of adding load of infrastructure, having a public and private sector participation, working in cohesive way to address this challenge, not in isolation, and in fact not in isolation, in fact as a doctor, nurses or thing, but overall healthcare workforce transformation. So that's one thing that I think is a glaring output of this report, is that we need to think ahead and we need to ensure that how do we bridge this a decade that we are going to lose in bridging this healthcare workforce challenges. Not only this challenge, India has the biggest challenge is the geographical distribution and the geographical, the diversities that we have, and that reflects on our healthcare workforce availability across the country. Some of the states we have a significant number of availability of the doctors, nurses, medical institutions, but at the same time there are many states in the country where we do not have adequate number of the doctors, nurses, but above all we don't even have the infrastructure or education institute through which you can generate the healthcare workforce. So that's the biggest challenge, that how do you address this challenge. Although in the medical side, undergraduate and postgraduate, there has been significant progress. Almost 90% or 85% of the nursing institutes are in the private sector and mainly located in 5 or 6 states in the country. Now, having a geographical diversifications and the demand which is across this country, having a concentration of those institutes in certain states will require a challenging efforts to increase those seats in other states. That's the biggest thing that we need to focus on. Definitely there is a dual challenge that we need to start working on. There's a dual disease burden and increasing population. By approximately around 2035 and 2040, we will have almost 13% of our population with aged group, which is almost 65 plus age group. We'll be in line with with what Japan is facing today. We have to start preparing ahead of the time, and this is one of the challenge that we have to face. Also, there is a migration of healthcare workforce, especially nurses. There's significant migration of the the healthcare workforce going to the abroad. How do you not only bring some of them back, but also create that conducive environment here and infrastructure and other resources here, which will enable us to retain the talent in India. And the challenge is not only to retain, but also how to create excess number of healthcare workforce that you can supply to the global world. Going forward, as I said, there is a significant efforts that is made on the undergraduate and postgraduate medical education. We really appreciate the efforts of the government and the private sector in this effort, and which was very much witnessed during the COVID time, where the government and the private sector really worked together. It was a first time that we saw that the public and private sector could come up with innovative partnerships, putting aside the challenges of the trust different in the objective of what they service to the citizens, but above all, they were all working together towards a common cause that this country was facing. So having said that, really appreciate the entire public and private sector's efforts in bridging these efforts. However, there has been reforms in the last 1 decade, whether it is regarding the policies, land, requirement, faculty, and a lot of other efforts. This something has helped us to increase the number of education institutes and PG seats in the country. But having said that, we still have a lot of efforts to make, and going forward, there may be a collective effort that can help us to bridge this faster. Well, apart from that, I think one of the other areas where we should focus, and we have started focusing lately, is allied healthcare workforce. Most of the allied healthcare workforce is informal on-job training workforce that was created in this country. Most of the OT technicians, dialysis technicians, dental technicians, and the workforce is mainly on-job training and trained by the hospitals and healthcare facilities, both in public, private sector. There is a very limited education institutes, structured programs to provide the training, certification, and recognition of this. But there is an effort that has been made by the government to recognize this allied healthcare workforce, reforms, and the structure program. I think that's something I'll ask at some point Dr. Agnani sir to share more details on it. But there is definitely efforts that need to be made on. They are going to be an important element of the care provider to this country. So that's one entire focus element that we should keep in mind, that not only the doctor, nurses, but allied healthcare workforce is going to be a very important element of what we are looking forward for 25 years vision for this country. I'm summing up the 20 recommendations that collectively came from the industry, from speaking to the both public and private sector stakeholders and our global counterparts there, and the learning from across the globe that reflects on the challenges that India is facing in terms of it. I think very important element, I can structure this into 6 buckets. The first is embedding the governance and mechanism framework. That's very important element. If we have to achieve what we are trying to achieve in the next 25 years, and with bridging a gap of a decade to achieve the number of doctors and nurses that we want. I think very important element is to set up an empowered group for a national healthcare workforce. That's a very important element. We have learning from Brazil, Australia, and a lot of other places. We need to have a collective efforts to bring this together. Let's bring all the regulatory bodies together, government stakeholders together, all the development sector partners and who are the relevant to it. In fact, have a representation from the healthcare workforce fraternity as well as a part of it. And to bring this empowered workforce, they work towards putting up a roadmap, working together, and how they work collectively towards solving this problem. Second is definitely there are some challenges and in terms of regulatory reforms that are required in terms of the infrastructure, capital investment that we need, requirements and so on. I think government has done a significant efforts on those. There might be some more efforts that we could help, especially when we are looking at to bridge the gap of the healthcare availability in the next 1 decade itself. There are certain reforms that might have to be exceptionally handled, maybe less of input driven, more of an output driven approach that this country might need. National Healthcare Professional Registry already started with National Health Authority and National Digital Health Mission. It's a good effort that is going on. It will at least bring a recognized and structured way of recognizing healthcare workforce in this country. Going forward, at some point, I think when we are focusing more on output driven and exit program or exit education or examination perspective, I think at some point the accreditation system for healthcare workforce could be a good efforts in training and skilling and putting a credentialing system to its place. Need for a focused campaign to attract talent. I think some of the reports that I was looking on the postgraduate and undergraduate and nursing seats going vacant in the country, they have significantly increased. With more and more alternative career options that are available to the younger generations, I don't know how many of us or our younger generation will prefer to work alternatively in a healthcare workforce or work in a rural area or certain other places compared to what is available in data analytics, artificial intelligence, and there are very glaring new career options that are emerging. The idea is that it's not that whether they will be interested in serving the humanity and doing servicing the citizen of this country, but the idea is whether they are aware about the healthcare importance, what is the important and the value they create, and are we making enough efforts to ensure that the younger generations pursue these careers and look at perspective on what are the options that are available and how all the stakeholders are engaging with the younger generations to engage with them. That's going to be an effort in coming times. We're going to have in next 25 years significant number of career alternative options available. Organizing a national workforce planning conclave, so that's what we spoke about. I think maybe not possible every quarterly, but every 6 months, the government and private sector comes together, a representation of it, exchanging the ideas, progress that is happening, and sharing the initiatives, and also hearing all the counterparts will help us to put up a very comprehensive roadmap for the next years. Developing standard treatment guideline, I think there are efforts already being made on this. This will streamline the quality aspect in this country. Very important element is about how do you foster and monetize the existing healthcare educational infrastructure that you have, which means that how you the capital investment that is required for medical college and hospital, how do you breach that? How do you leverage the CSR fund for healthcare training, skilling and scholarships? So hospitals who have in a CSR bracket and all, can they use them for training the their own workforce or additional workforce, and leveraging that in the healthcare workforce creation and the skilling program? Leveraging the existing hospitals for training. We have a lot of hospitals. Maybe we can't have a 25 bed or 50 bed or something, but at some point they might train allied healthcare or nursing, or maybe there's something that to be thought about. How do we leverage the healthcare infrastructure that is available? Also, upskilling of healthcare workforce is very important. That's going to be a challenge for the country on the quality aspect. There are a lot of efforts that we need to meet. But I think one thing that I would like to bring here is the National Healthcare Skilling Platform is required. We need to have a national skilling platform where a government and private sector can come together. Healthcare workforce can access a free courses, skilling program, and credentialing system in place, and that could be funded through both public, private sector, and self-sustaining model that we can create. Incentivizing and social safeguard for healthcare workforce is important. What is the incentive for anyone becoming a healthcare workforce today compared to what alternatively options are available? Also the benefits and also safeguarding from the social security and protecting them from any kind of physical violence or other aspect. I think there's a lot of efforts been made, but we need to address that. And definitely there is a huge opportunity available on the digital. How do you in coming decades leverage the digital universities and digital institutes, not for the formal but maybe for a skilling program and other programs that could be leveraged? National digital literacy, health literacy library is something that Niti Aayog is already working on. And lastly, there is definitely huge potential to use the emerging technologies. Simulation labs, we will not have enough number of healthcare infrastructure, number of beds and patients where you can experiment or you can train your thing. Maybe in going forward, the simulation labs is going to be there. That's how the pilots and military and a lot of other professionals are trained. Maybe at some point we'll use it in a greater leverage for this sector. And also the metaverse and the virtual reality and can be leveraged in terms of the training programs. Okay, there is already metaverse is being used for assisted surgery and a lot of other efforts in some of the hospitals. Going forward, maybe we can use them. A student can be part of a surgery or in a hospital virtually can be part of it to learn and see it, and there can be a mix of that. Having said that, there are many more efforts that is required beyond this, but it's important that we start working at some point, and we start early is more better for this country, I guess. Let me invite my my panelists here today to start with this and take their views. They have contributed a lot in this, putting up this report, and they will share more details about in some of the recommendations. Let me start with Professor Minu Vajpayee. There has been a significant progress on the undergraduate and postgraduate education in this country. Number of colleges have doubled, almost 83%. Seats have almost been 123% there. DNB has made a great progress in terms of considering accommodating both in terms of rationalizing the infrastructure requirements and so on. But there is a lot more effort still required. Yeah. What is your take in terms of what has been done so far? And what are the other efforts that are required collectively to be done from the government and the private sector that will help us to bridge not only the doctors' challenges in the country, but overall HRH or human healthcare workforce challenges in this country, sir?
Thank you, Dr. Agnani, my fellow panelists here, and members of this esteemed gathering. I am very privileged to represent National Board of Examination in Medical Sciences, and on my behalf of the President, Dr. Abhijat Sheth, I bring greetings to all of you. As Lalit has just mentioned, the mandate of the National Board is to conduct postgraduate courses. In brief, I must tell you that in the last 6 years alone, we have ramped up our postgraduate seats from 4,000 to 12,500. It has happened because we, as our Memorandum of Understanding and association which is there, is very flexible. And many of you who interact with us realize this. Our mandate is to work with private hospitals. And that is our strength actually. Some of the questions and queries and concerns which Lalit just mentioned, it looked like that he's addressing to me. And actually, we have many answers. Dr. Agnani actually pointed it out right in the beginning that what we have been working has encouraged the Niti Aayog to ask us to ramp up, to double up the postgraduate program that we do. So as I said, that statistics very clearly indicate that in the last 6 years, we have increased the seats to 200%. Now, looking at the statistics which we get from reliable sources, some statements in the Lok Sabha and some government documents, in 2020, consensus showed that there are about 70,000 private hospitals. Now, we work with 1,100 and we have 12,000 seats. If you work with 20% private hospitals, you can imagine that we have 14,000 hospitals to work with, which will be 6 times more. We would have 1.5 lakh of postgraduate being produced. It is not something which is unthinkable. It is possible. The Niti Aayog and the ministry has expectations. They have seen our work ethics and the results that we have produced, and we know our strengths. We know that we can reach out to you. In point, I would come to how we can seek FICCI's help to enable this happening. Now, it brings some challenges because it suddenly gives you an alarm that you are going to ramp up the number of seats to so many in multiples in such a short time. The concerns are genuine. We have to keep the standards up and we have to keep the uniformity of education all across the country. Because if we have a cardiology postgraduate in one part of the country, the SOPs and the standard treatment workflow should be common. Because now we have moved to digital health mission where a patient may go from anywhere to anywhere, and therefore the data should also seamlessly transmit. If the SOPs and the other methods of imaging transmission not uniform and standardized, obviously we all know it will be difficult. We have already proved this. We have ramped up our the webinars which we conduct from our headquarters at the National Board in Dwarka. We have doubled up and now tripling up the lines which will transmit them. These courses are around there. We have 100 specialty boards, and these boards, they cater to the broad DNB courses, the super specialty courses, the fellowship programs, and to add to the healthcare workers, we have outreached to the district hospital. We have created diploma jobs, and Rajasthan is a very strong example where we have actually almost saturated the district hospital, and obviously we'll keep on doing it. Recently, the health secretary, Rajesh Bhushan ji, had spoken to all the principal secretaries of the states to enable National Board to reach out to the district hospital so that we can start our diploma program. So you can imagine that the blueprint is very clear. We have started working on it. Now, we can easily say that we would have another 14,000 hospitals to work with. But often there are difficulties, and while interacting with Mr. Khanna earlier and many of you, I've come to realize, and even Devi Shetty recently in Coimbatore, the concern was that when we deploy a doctor, obviously we have to give him a stipend. And can the government help to it, and is it necessary? Let me tell you, government has gone through a difficult phase recently. Even then, the Niti Aayog is working very hard on it for incentivization. You don't really need incentivization. So I dug up some figures about it. And one resident contributes to the 37% of productivity, which all of you know very well. So you can imagine the contribution a resident does in the hospital setup. So giving him a paltry amount vis-a-vis the productivity with 3 residents together can work like a full faculty should not be an unthinkable scenario. But I'm not harping upon it. I mean, I'm sure. So how do we get those 14,000 hospitals be accredited? They are working as private enterprises without any qualms on thinking about contributing to postgraduate education. Now, so we thought about situations which might bring difficulties to enabling it. We looked at a program. A very simple example is obstetrics and gynecology. Now, we find obstetrics is very heavy in public hospital as far as the workload is concerned. And the gynae is very heavy in the private sector. In general, this is the standalone, they can't be eligible and accredited for a postgraduate program in obs gynae. The case mix is extremely important. So this case mix could be had together if we encourage group accreditation. So we introduce group accreditations to 2 or more hospitals can complement their deficits and become enabled to stand up to us. Well, could be accredited. So the number of beds, the case mix which a specialty requires, like I gave an example in obs-gynae, there are many more examples in each specialty, and obviously the teacher eligibility criteria. All these together by group accreditation can actually complement each other and reach the figure of 14,000 that we are trying to reach out. And there'll be many methods which I would discuss with all of you whenever the time comes, as to how we reach out to those hospitals which are totally unaware of what the potential which they had. And Mr. Mistry very rarely said that, how do we do it? So a lot of people feel, how can they do it? We can tell them they can do it. And that's how our outreach is going to be. Now, another point which the bigger corporate hospitals can handle is that consortium formation. Consortium formation is an important thing. Now, if you look at the finer print, we have mid-segment hospitals which are greatly benefited by the PMJ scheme and the Ayushman Bharat scheme. A lot of hospitals have been able to meet their overhead cost with this input from the government of India. These overheads are not sufficient for corporate hospital, where they are technology heavy, there are huge investments. It is unrealistic to expect they would chip in the same way. But a consortium will have a win-win for both. So hospital beds are always a premium. They are always short. And in the major cities know about it, the minor cities do not know about it. And therefore, each hospital segment has its strengths and weaknesses. If a consortium is formed, it will be a staggered approach of patient referral. It will help the teaching part, so the resident can, through an externship program, can rotate between hospital. So you know that the clientele with the corporate hospital are individual clinician specific. They can't have their hands-on of the residents. We are frank about it, we know it. And therefore, our externship policy with group accreditation and consortium formation would help extremely well and work out very well. Whomever I have spoken to one-to-one, they are very encouraged about it, and I think there is a plan there. Now, as I said very clearly, that the challenges and concerns which all of you may have and we had was to ramp up how we improve the standards and bring uniformity, for which we have taken many steps which are visible to many of you. I can simply tell you that we have included in our curriculum transmission case-based scenarios, complex case discussions, interactive sessions, procedure videos, etc. So you can imagine that we are able to reach out to the resident, and we are increasing that. For monitoring, we are creating an app-based system which a formative assessment of residents as they take rounds with you all, they would have record on their hand that the monitoring of the teacher as they are teaching, as well as the curriculum which is being imparted can be had. Skilling is very important, we realize that. So initially we thought that creating a world-class center would take some time. So simultaneously we thought that we'll engage with about 25 to 30 bigger centers which are actually dealing with skill imparting. The NMC has come up for the MBBS courses also, and we are also coming up with a 45,000 square feet skill center of a national level, and it won't be before the year end. It will happen by that time. We have also identified specialties which are likely to be required in the next few years, and these are emergency medicine, critical care, family medicine, and infectious diseases. Now, I'll just suddenly jump a little bit to say that infectious diseases actually are a threat. Zoonotic diseases, in which between species the disease is spread, as we saw COVID recently, there are a huge number of conditions: rabies, blastomycosis, psittacosis, etc., and intestinal illnesses. I don't have to give a long list. And these are now biosecurity hazards, bioterrorism hazards, and therefore we have subcategorized the conditions, and accordingly our course curriculum is likely to have them very soon. Our programs on fellowship infectious diseases will come up, so that we know that what is likely to happen, and we are preparing ourselves with that also. Now, this was the deployability, the requirement. Our population is expanding at both ends, and we have got a younger population, almost 28% below 14 years of age, 40% below 18 years of age, And our elderly population beyond 65 years has increased from 3.8% in 1990 to 6.6% now. So you imagine both ends, and the requirements of both ends are different. And a good thing is, it's a silver lining thing, which you can say that COVID has actually brought focus to preventive care. We have all realized that there is a cultural and change in political thinking. In India, the political thinking had changed a few years ago. The Ayushman Bharat and PMJ schemes are actually the wellness approached. But with COVID, the world has just sat up and think about it. And Mr. Mistry mentioned about 2040, the global economy will be $12 trillion. And these statistics were published in May itself in a journal from abroad. And they have gone into great detail as to what is the projection. Now, where would the workforce come from? If you have a $12 trillion economy, even if you say that there is type 1 and type 2 healthcare resources, like type 1 would be where there are insurance schemes and there are out-of-pocket expenditure and there are hospital, there are other outliers like the devices and other arrangements, which is type 2 market. So where would the health workers come? Currently, as Dr. Agnani mentioned, that 20% of our actually health care workers go abroad. They go abroad. You can't stop it. This would increase if we are simultaneously not producing and matching up the numbers. They will go and we'll suddenly find a huge void. That's where it is important that we target each brick of what we were discussing right now, creating consortia, tapping the private hospital, increasing the number of courses, and Dr. Agnani mentioned very eloquently about the co-location of campuses to bring out the best of the working environment. So now Indian health and the statistics which KPMG might endorse are that the Indian hospital market stood at $66.77 billion in 2021, and it is expected to go to $120 billion in the next 2 years. So obviously something is happening, and we have to keep on addressing it at faster pace as much as possible. Now, I have mentioned about the good health of a population is also translated into economy. And I think all of you know more about it than I would have to tell, and I think Dr. Agnani also referred to that. We have also encouraged international fellowships. So we launched it in 2019, but unfortunately, because of the COVID, the traffic had stopped completely. But here I would like to approach to you. All the hospitals have websites. You should further enhance, beef it up so that they are visible from abroad to residents who want to come for training to a country which they have never visited. They should see what is the infrastructure, which city is it in, what is the climate like, what are the various courses are being sort of introduced there, how many have they trained already, what is the faculty like then training. And Dr. Agnani is a regular feature of almost every meeting which I have attended in the Ministry of Health. I am sure he is there everywhere. And we discussed this part also, that the government is creating a portal where all these hospitals should be hosted, the website, because a doctor or individual coming to a country, he would be more confident if the hospitals are backed in the ministry's site, because they feel that it is backed by the government rather than going to a private hospital or somewhere where a training is going, and he feels insecure. So that part is very much in the pipeline. I have attended meetings, and I think the work is already going to be on floor very soon on health, not only health in India, heal in India, heal by India. So Dr. Agnani mentioned about the registry which is being created, which is a doctor platform for registry, where each doctor, either working individually or in a setup, would be having an ID, and this doctor digital ID would be tabbed and will be encouraging them to keep protected. We'll see if they go abroad, which they would, they are not taken head by. So I told about international fellowship programs, which are many of them, and this would enable and strengthen the traffic to this side also. Now, the FICCI can help in ensuring all hospitals would have their infrastructure details available, and all these initiatives and government norms which could be catered to. One thing more, during our foundation day early in March in National Board, the Honorable Minister Dr. Mansukh Mandaviya ji had come. We suggested that the postgraduate courses are a numerator. The denominator remains the MBBS courses. And we, and in the private hospital, definitely have the wherewithal to also run MBBS courses. And so the Honorable Minister was very encouraged. In fact, within a week he called a meeting of hospitals in the country which had 400 plus beds, and we addressed them and we told them what we can do. Private hospitals usually are clinically oriented setups. They don't have pre and paraclinical services which are part of an MBBS course. We offered that the national board has pre and paraclinical courses also. We can increase those seats. We will have a collision with a collaboration with the medical colleges, whether they are private medical college or they are government medical colleges, for these pre and paraclinical courses. And with this kind of arrangement, the clinical part can be done there. We can elaborate. There's a whole document on this, but I'm just touching this particular point. And this is happening for years together in the United States. People, they send their children because of the high cost in America, in North America itself. They send their children to Caribbean. They do 2 years of college or 3 years of college there. They come to American hospitals for clinical training. They become doctors, but they have to take the ACFMG. I have come to know, I won't name the hospital, 1 or 2 hospitals in India are dabbling into this. They are telling our boys that we'll take you to America, which is actually South America, and they have to take the ACFMG and everything. So what I'm saying is, we have plenty. We should not underestimate our strength. It is all there. It's in the pipeline. Government is working round the clock, and National Board has a very clear plan. We would approach you in very structured way as to how you can help out actually to each other, to the people of India, that we can enable what we are aiming to. Thank you very much.
For your insight and sharing, what efforts has been made, especially in the super specialty and the DNB courses. Very rightly mentioned that we do have hospitals and the capacity both in public private sector that is under or I would say not leverage for the healthcare workforce training in India. Having said that, definitely there is a available capacity, human resources and faculty to some extent to train and leverage the existing infrastructure and facilities. But at the same time, the bigger question is how you continue to inspire and have the younger generations to join the healthcare workforce stream as a career option. And looking at some of the recent figures in PG seats and the nurses and the undergraduate program, the challenge is how do you keep attracting and create that awareness and acceptance among the younger generation to join healthcare workforce as a profession. And let me invite Dr. Sanjeev Singh, Chief Medical Superintendent, Amrita Hospital, Ghaziabad. Dr. Sanjeev, bigger question is that we have a capacity today, we have the intent, we have the reforms going on in undertaking all these efforts, and we have a vision and we are looking at collective efforts. The bigger challenge is how do you bring and attract the younger generations who have a lot more option than what we had around 20 years or 30 years or 50 years back, where engineering and medical education was the only mainstream options that was inspired for any youngster who was coming out of a 10th or 12th standard and they would aspire to become this. Now they have a significant number of career options available. What's your take on that and advice on that? How do we should attract the younger generation in as a healthcare workforce profession?
Thank you, Lalitji and Dr. Agnani and all the dignitaries on the dais. I think it is an important question. You mentioned and the report which you submitted was phenomenal. I think you have demonstrated the shortfall which is existing, and it is increasing unfortunately every year. And you mentioned that close to 13.7 lakh of nursing shortfall exists, and we are not able to meet year after year. We keep comparing ourselves to the WHO requirements, and the ratios are never been met. So we are still at 1.7:1, and there are shortfalls with the medical, nursing and digital. So to attract younger generations, I think it is important to reach out, and the skewed distribution which has been mainly on the urban focus towards healthcare force, both for medical, nursing and allied health sciences, needs to basically change. We did that in a very small manner in our institute, where we have a tribal hospital, and we pick a tribal group of 12th pass students, and they come in, or those who are underprivileged, they have they were unable to afford. So when they come in and they get into either a nursing curriculum or an allied health sciences curriculum, we run close to 28 allied health sciences courses, and we have seen some phenomenal results. And this group of cath lab technicians and the perfusionist and allied the dialysis technician, so they have done phenomenally well, so much so that for the last 20 years, there are close to 133 of these group of people who are underprivileged have gone abroad, and they have been representing our country, and many of them have also become faculty, and they also train well. Going digital is another very quick way to attract this particular workforce. I think Honorable Prime Minister brought in this concept of digital universities and basically looking at online educations and keeping the spread towards this and reaching out. But we need to basically develop that kind of an infrastructure to be able to reach out and create more, as Dr. Adnani also was mentioning, quality being a focus. And we have seen this in all assessments, whether it is medical, nursing, allied health science, whatever assessment happens, it is still very structure based, and process and outcomes are never evaluated. We see this with our medical, that we don't interview or assess the medical student, nursing student or allied health sciences student whether they have learned. We unfortunately are still looking at the clinical materials, and we are looking at the square feet areas, and we are looking at the adequate faculty and things like that. So it's very structure based. So to attract younger generations, we need to incentivize, and I think your report demonstrates that. We need to go digital. I think that is extremely important. We need to get into other geographies, which is extremely important. We need to reach out, as was mentioning, to smaller healthcare institutions, because there are many of them. And in totality, I think creating that kind of a workforce environment, and you mentioned about the library and the registry, would be critical.
Thank you, Dr. Sanjeev. Important element is definitely, how do you make the healthcare education more attractive, futuristic, and imbibing the recent technologies and what is happening parallelly in the other professions or the career options that are available to those students today. People get very excited in AI, using data analytics, a lot of other aspects. How do you bring that element to it? If younger generations, have to look for an option, they get very much excited about doing something with the metaverse, AI, and other career alternative options. And if you bring those elements and newness to this, maybe in healthcare education, some point, maybe there is a revival of this thing too. Could happen. Very important element, but this would only happen if you have a collective efforts and a program to do it. The way I used to remember when I passed out 12th standard, I used to get very much inspired to join the army and the air force. The reason was the army, air force, they used to run such a comprehensive program, and attracting the younger talent and putting that ambitious and vision to them that they should serve the country and become part of it. And I still remember the first form that I filled for applying for anything or in a course was Air Force, and applying for that. I think that's kind of an effort is why should somebody become an healthcare force profession today? I think that's something will be a question, bigger thing. Creating infrastructure and all will come together at later stage. Very important element. I'll go to Professor Mahesh Verma. Professor Mahesh, very important element. One more stream, that is a dentist, are important, but often are not aligned with the larger healthcare workforce to greater extent. Whether we talk about the ratio of the doctor, nurses, healthcare workforce that are created, and also the allied healthcare workforce, which was very much unrecognized to a greater extent. There is an efforts been made on these two areas significantly, but I still believe there are more opportunities available, bringing collective efforts and bringing them together. Over to you. I wanted your insight on that. How do you
thank you, Lalit. Thank you. It's such a privilege to be part of this panel. I somehow, when I look around, I see very high-profile medical colleagues here, but dental is a lone voice. And although I represent NABH here, but I have been a core dental professional. I was Dean of Maulana Azad Institute of Dental Sciences and was instrumental in bringing it up. So I will talk about dental. Somehow dental gets a backseat, it gets neglected, it gets ignored, and everybody needs the dental care, and me included. And also, we've been talking about HEAL in India, and medical value travel has a huge component of a dental treatment. So, if you look at the planning, if you look at the report today, this report, it only mentions dental at one point, just the numbers. It doesn't say anything else. And the dental scenario is altogether different. I just give me 5 minutes. I promise you I won't take more than that, but I must steal this opportunity to talk about some woes about dental. See, dentist manpower is available. It is different scenario as compared to medical. We have 300,000 dentists already available in the country, looking for jobs, looking for opportunities, but there are no openings for them. So scenario is different. Another thing, of course, our para-dental force, which is dental hygienist, dental mechanic, dental assistant, that's very minuscule, very, very small. So the problem is there. So another thing is, whatever manpower is available, as in medical, it's very skewed. There is an urban-rural divide, and I know youngsters are now going to tier 2, tier 3 cities, and the 75% of the workforce are women, and many of them are not very active. You see, that also we must confess. So there are no jobs. So here there is a skilled opportunity, skilled manpower available, but for want of jobs, they are going into other areas. They are leaving dentistry. So we are losing skills, losing manpower. No dental services directorate. I must say that I want to ask you one question. My fight has always been is that you have a medical services. In a hospital, you need 300 medical officers. Why do you need just one dental surgeon? Everybody has a 32 teeth. You need if not as many dental surgeons, but you need a substantial amount of dental manpower. Everybody needs a dental care, isn't it? So, and also, till today, the Bohr Committee 1946 said there has to be a dentist at least at a PHC. The wellness center, even today, except in a couple of states, there is no dental surgeon. And you think dental surgeon is just a primary care. Dentistry has 9 super specialities. A dentist, a primary dental care dentist cannot do crown or bridge, cannot do orthodontics, cannot do maxillofacial surgery, cannot do pediatric dentistry. So we need specialized services also. At a district level. Have we made any referral? Never. So we need a parallel directorate of dental services in all the states with the equal amount of manpower, if not equal, a substantial amount of manpower. We have a national oral health policy. I was instrumental in framing it, and in fact, it had so many avatars, but it's still pending. The National Health Policy 2017 has a very little mention of oral health. Oral health always gets neglected. So, and as I told you that we need to set up specialized dental services, at least at the district level. And we can have an integration from the PHCs and CSCs so that primary care can be done there, and for the advanced care, specialized care, they can go to dental. I also want to tell you another woe, that Ayushman Bharat, PMJ, has only 9 procedures of dental as a part of PMJ, and that also only surgical procedures. And also it has to be indoor. They have to be inpatients. So if you include dental services also in ABPMJ, then I think a large segment can also be taken care of. So, and oral cancer is another issue. It's one of the dental, and we know that can also be because we have 3 cancers, cervical and oral, and I think breast. But, for that, cervical and breast, you need a proper facilities to examine patient. For oral, you can do it right way in any dental place, any clinic, anywhere, with a torch and light. So also the quality of services is also huge problem in dental, because a lot of these private schools are in far-flung areas. The clinical exposure, patient exposure is less, So that's another issue, that even though we have a manpower available, but that manpower is not skilled enough to take care of many dental procedures. So I think we need to increase number of jobs in government sector, jobs in the sense that we need to create positions so that we utilize. Here the situation is different, that we have a manpower, but we are not utilizing them. So that needs to be done. And I think we've been talking about incentivizing all those things, which is applicable everywhere, including dental services in PMJ, preventive program, because most of our, the best part of dental ailments is that they can be, 90% of them can be preventive. So if the government can do a massive motivation, sensitization, education, awareness, I think so much can be done. So much, so that the burden of disease at the end of it is not much. And I think government and private sector, they have to come together, because the burden of the disease is humongous. Everyone in this room will have some kind of a oral disease. I'm not, I'm not, meaning anything else. But and I think because I am taking this opportunity because additional secretary health is here. Instead of opening new dental colleges, open dental hospitals. Have you seen a government dental hospital? Why dental hospital? Only a part of a dental college. We need standalone dental hospital where people can go and get their advanced dental care. There need not be a BDS or MDS or such programs there. They just serve the dental needs. And also, you're looking for a manpower, dental, and you're talking interdisciplinary. We can use dental manpower, which is abundantly available, to do so many allied things in healthcare, because they learn medicine, they learn surgery, they learn pathology, they learn bacteriology, anatomy, physiology. They study all that, then they study dentistry. Dentistry was a part of medicine. It got separated. So still it is also a field of medicine, so we can utilize. So I don't want to take much of time because we are running behind schedule, but I think I have taken this opportunity to sensitize the issues was our profession is facing at the moment. Thank you so much. Thank you.
Thank you, Professor Mahesh Verma. Thank you for your insight. I think we all definitely don't often pay much attention to our oral health and oral health hygiene. But it's very important that oral health, the way it can prevent many other diseases in our personal life, and it can help in the wellness and the better health management. I guess it's also important to think the integrated approach to this entire health system, which is not only cutting across the public-private sector, but I think it's interdisciplinary and leveraging. I think what important point you mentioned is about there's already a skilled healthcare workforce that is available and medically skilled. How do you leverage it? We are trying to cross leverage, creating robots and simulations and all that. I think there's one area I think I'll request my team to take it up there the next time, is an integrated health system approach to this, where we have a larger approach. But there is also a miss from our side to some extent. I think we take a note of it, and it's good for us going forward. I think. But I take a note is around 3 decades or 5 decades back, when the India was post-independence, the entire thing started. We started leveraging a lot of the compounders and a lot of other stream who was not recognized and all that, and you gave them training and all that. I think that we are in second juncture of that we need to have a relook at it. What is available? How could you leverage those resources and healthcare workforce and make a collective larger workforce and look forward for the next 25 years? I think that's a juncture that we are. Let's bring in Dr. Narottam Puri, who has a more experience than even my age now. I respect him a lot, and his insight. And he always emphasized a lot. One point that I have taken a note in this paper is it's not the quantity only thing that we have to address. It's quality that is going to be the biggest challenge that this country is going to face. And the quality is not only about the what education you provide to the students, but also very important is who is providing that education. Do you have the right faculties and emphasis on doing that? I think and other areas of intervention that he has to share with us. Dr. Narottam, if you can share some insight. Do we have time? But we really want to hear you and a lot of insights from your side.
Thank you, Lalit, and good morning, everyone. I have no woes, just a few suggestions. First of all, the point about quality, it has been referred to earlier as well by Dr. Manohar Agnani. We kind of are consumed by talking about quantity. A nation of 130 billion, this much number of beds, this much number deficient, this much number of medical colleges. But what is the output? Don obedience theory says structure plus process is equal to outcome. What matters particularly in the medical field is what is the outcome. Who's bothered about how you did it, but your patient should go back home. That's the fundamental premise. Now, unfortunately, in our country, most of the medical colleges that exist, there are about 612 of them as of date, and by the time I'm speaking, a new one would have opened. How many of them are NAC accredited? Hardly any. How many medical colleges, hospitals are accredited? 2% of all accredited hospitals in this country are government hospitals. 2%. So there is no focus at all on quality. We are completely consumed by quantity. And in healthcare, quantity alone will give deleterious results to the generations to come. That's point number one. Point number two I'd like to say is that if we continue on this path of just creating a large pool of doctors, we'll go just the way Dr. Mahesh Verma pointed out. Now you have dental colleges closing down, converted into guest house or hotel. You have seen what has happened. Gautam can contribute to that thought process by saying how many engineering colleges have shut down. Statistics point out that 7% of engineers who actually graduate, Raj and Gautam are engineers, 7% of engineering graduates are actually employable, can do engineering jobs. Do you want the same thing to happen in medicine? That only 7% of the doctors that you go to know how to treat you? So let's not just ignore the qualitative part of the healthcare delivery system. Don't just focus on quantity because we are 130 billion. Of course we need more medical colleges. When I was a medical student starting in the 60s, we were 8 students on a dead body to start dissecting. By the time you graduated, perhaps you were 16. How many are there now? 250 students per batch in major medical colleges, but there is not a single skill lab. So how do they learn anatomy? Technology hasn't been leveraged to use the medical college. We are again only thinking of numbers. Itne ban jaye. But what will they deliver? I don't know. So are we producing qualified quacks at the end of 20 or 30 years? That is a question each one of us must, do an introspection about. The second thing is, because doctors are not available, you are utilizing non-qualified doctors for modern medical treatment. How justified is that? What is the definition of quackery? If I am an Ayush doctor who has learnt homeopathy, why am I posted in the critical care? But many states are allowing this because resident doctors are not available. So if we are going to do this, then we are doing nothing else which is an illegal activity. And you are actually affecting the qualitative result of what the patient is likely to get. We keep talking about antibiotic resistance. My friend and colleague Sanjeev, whom I respect a lot in the field of infectious diseases, will keep on harping about the problems that this country has about antibiotic resistance. Who are the largest prescribers of antibiotics? They are rarely specialists. They will be the so-called old RMPs. Do you know medical representatives go to BAMS and BIMS practitioners the most? Because the largest number of antibiotics and the largest number of steroids are prescribed from them. Nobody comes to Alok Roy. Nobody comes to Vishnu Panigai or to people like us. Because we will ask questions. So let's not forget that for the patient, for India's future, we need to be cognizant of the dangers that only numbers produce or the lack of numbers which result in us being forced to do steps which border on the illegality as per constitution. The third point I wish to say is that if we think completely and continue to think from the box, you are not going to find a solution for it. Repeatedly from FICCI we have sent papers. The last one was in conjunction with Nat Health. If we have to learn from some countries abroad, I think one thing which will solve a lot of problems is the systemic use and institutionalization of the system of physician assistants which exist all over Europe, all over America, and nurse practitioners. They will give you three things. One, the nurses will get a leg up because they will see a future. Two, the physician assistant and nurse practitioners will be able to do a majority of the work that the doctor does. Therefore, you will have more doctors available to do it. The problem is some sporadic attempts were made by 2 or 3 institutions to start physician assistant programs. But they fizzled out because there is no government recognition. The other issue is that everything need not be passed by government. Government is a regulator. So if a course conforms to the regulations that exist, that's fine. Otherwise, it's not necessary for course to be stopped. Maybe it's time for regulations to change. If you don't think out of the box, we will continue to have this problem, doctor nahi hai, wo gaon mein nahi jate, and issues of this nature. Please create a cadre of physician assistant, nurse practitioner, EMT technicians, grade 1 to 5, and those who are allowed to prescribe emergency medicines. The third point that I wish to bring to the attention of this August gathering is why don't private institutions, we heard Dr. Vinod Paul yesterday mentioned that you guys have done nothing. But we heard Professor Bajpai say today we've done a lot. So somewhere I think the reality lies somewhere in between. The fact is that out of the 6 lakh hospital beds in the private sector, only 2% of the private hospitals are 200 beds or more. How can you do DNB in a 30-bedded hospital? So having DNB programs, again without quality, is no solution. So if you need to have DNB, and we need definitely to involve the private sector in an increasing way, but you need to talk to the private sector. Why don't they get into it? If, let us say, an Apollo, a Fortis, or a Max, or a Manipal, or any of the major hospital groups, Gautam's or Alok's groups have 100 DNB seats, why should they not increase it to 200 is the question Dr. Paul asked. Have you talked to them? Why don't they increase from 100 to 200? They will tell you the real answer. So communication, I think, is the way forward. I think what we've got to stop thinking is the government or the public health sector is India and the private health sector is Pakistan. So unfortunate but true. The issue is if the two have to meet, and we have met many a times, is to find a common ground. Public-private partnership is a concept that we have been talking about since 1990s. Give me 5 examples of good public-private hospital institutions that have worked. You will be hard-pressed to name 5. Why? So this why is where science teaches us to keep asking, and why is where by communicating we'll find the answer. I could go on and on, but my humble request is that when we are talking about numbers, we must also realize that this year alone, 800 seats of DNB went a-begging. Nobody has applied. So there is something wrong with our system, and we can't keep thinking, oh, I'm doing a very good job. We have to be introspective and say, this is a problem, let's solve it. We need to have a solution. We cannot be critical. The government is doing a great job in trying to promote and invest in healthcare. But private sector is not lagging behind. Private sector has walked the talk. Look at the example of COVID. From vaccine to vaccination, from reservation of beds, most private hospitals are not making money. If that were so, why are the major players like Birla, Ambani's, Adani's of the world investing in healthcare in India? Why are most of the corporate hospital chains owned by actually money coming from abroad? So it's not as lucrative as it's imagined to be. So my point is, whilst we discuss these things, and in these panels we feel afraid of hurting somebody's ego, the basic person that we are hurting is an Indian. My humble request is, let's stop being critical for the sake of criticism, but let's not stop being introspective of what really needs to be done. And where the problems lie, we all know. The problem is we are not focusing on solutions. And the solutions are difficult to find. That's why we don't focus on them. But my humble request will continue to remain that we focus on the issue of getting these two, I call it a boat in the river, the public and the private. And if the two oars are not synchronized, the boat won't move. So we need more such gatherings, such institutions to play the role of the agent provocateur, so to say, to do the job that this country needs. So I just end by saying that one other suggestion for probably the government and the regulators to think about is the involvement of the associations of various medical professionals. For example, Dr. Meenu Bajpayee is a pediatric surgeon. The Pediatric Association will know how many pediatricians are needed 3 years from now, 5 years from now. In the United States, many of us who have trained there would know that the residency programs vary. So every year, probably there will be three dermatopathologists in Mass General, but the next year there will be only 2. Because the association and the authorities that regulate are in regular touch. There is no consensus as yet on how many postgraduates do we need in which specialty. Where is that data? Who has collected that data? If that data is available, has it been analyzed? If it has been analyzed, what has been the data put to use for? My guess is, at least I have never seen this data. So associations usually know. Involve them. Nobody talks to the associations. So if you involve the associations and create a projection of this much number of seats will be needed, then you fill those seats. This time hospitals, nobody is applying for MCH in cardiac surgery. Seats are lying vacant. Forget about fellowships in pediatric cardiac surgery. 0 takers. So, how many do we need? Do you know? I don't know. Nobody knows. But the same number of seats will continue year after year for MD, MS, and this thing. It will take 7 years before a minor change is done because 2 medical colleges have come. Last point I'll leave it with, and one of my friends, Muzaffar, told me yesterday, and I'm told that the National Medical Council has stopped the inspection which used to occur after 2 or 3 years so that you know whether you're ready from preclinical, paraclinical to go to clinical. If this is true, this is a death knell for quality of medical education. Thank you.
Great. Thank you, Dr. Puri, for your insight, and you've been always being an advocate for putting a quality first in the healthcare. And I believe that at some point we need to start thinking about the quality in the healthcare services. How do you bring in forefront, especially in the healthcare workforce and all the healthcare delivery we do? In fact, 10 years back, I don't know how many of us could even choose a restaurant based on the quality and the ratings. What you could do today, I think there's a great learning that we have. The e-commerce that you see, the online phones that you buy and products that you buy, even the smallest restaurant and the home delivery things that you do. I think at some point there is a informal, non-governed structure that need to be bring from the consumer perspective, that how the quality is a very important element. Today, when you choose a doctor, when you choose a hospital, whether it's the public or private sector, how much you can recognize the confidence that you get that, and going forward, the challenge that we mentioned is around is, are we really producing the skilled and the right healthcare workforce for this country? That's going to be the biggest challenge in doing this. I think the skilling and the quality is going to be the most important element. Before I bring my colleague Michael Allen, let me bring Dr. Santosh Shetty in. Dr. Santosh, your experience and your point of view on how the private sector, not only as a hospitals, but overall as a private sector, could be leveraged in the entire skilling effort and focusing on the quality aspect, and how this can play a role in bridging the gap that we have in the skilling, and also bridging the gap in urban and rural, the availability of healthcare workforce that we have. How can private sector play an important role in that?
Thank you, Lalit, for having me as part of this panel, and it's a pleasure to be here. At the outset, I'd like to compliment FICCI and KPMG for putting together this wonderful report, and recognizing that there is a looming crisis. We've been talking about it for a while, and as Dr. Puri very rightly alluded to it, that at the time of crisis somehow we seem to get the oars together, moving in the right direction. So hopefully this is one area where I'm sure with public and private we will move in the right direction. Dr. Angnani very categorically mentioned about how we are a very young population, and at the same time we know that healthcare gives some of the largest employment opportunities. So if you look at it from that point of view, we are in a sweet spot. But despite that, you have seats going vacant, you don't have too many takers for postgraduate education. And overall, if you look at the involvement of private sector, the private sector involvement has been primarily towards postgraduate education. And if you look at the number of DNB seats today, over 65% of seats today are coming from the private sector. And these are again coming from larger hospitals. So there is, I would say, another category of hospitals, which would be, say, the middle rung hospitals, which can definitely get involved with providing this postgraduate education. And I think the regulatory framework is now becoming dynamic in terms of the consortium aspect, the combined accreditation. These are all opportunities for the private sector to get together to participate in postgraduate education, to give quality postgraduate education. Since we have some wonderful faculty on the private side, again, we need to see how we can use this faculty to impart education, because shortage of faculty is again a very big challenge both in public and private sector, and we need to see how we can collaborate to ensure that good quality faculty is able to give and impart this training to people. On the nursing side, I would say 90% of the nursing colleges are in the private sector, and we can, as private hospitals, continue to contribute in that direction. One other aspect which is very, very important is in terms of continuous skill upgradation. I think that's a piece that private sector can play a very critical role, that how do we make sure that whether it is doctors, whether it is nurses, continuous skill upgradation programs, whether short term or maybe a year or two programs can be set up. For example, a hospital like ours has got 3 robotic systems, or it's got a state-of-the-art rehab center. So we can have nurses or technicians from other places come, do 6 months to 1 year courses, and then go back into their respective setups and create some of these programs. The other very important aspect is the paramedical training aspect. very few hospitals in the private sector today are running paramedical courses. So therein lies a huge opportunity. A large hospital like ours took 5 to 6 years to set up a paramedical training program, because somehow you're not sure that, how do you go about doing it, and are these recognized, are there structured programs, what are the employment opportunities. And today, just last month, we closed with about 100 odd students applying for 10 courses that we are running. And Dr. Agnani mentioned that there are about 56 such allied healthcare courses. So I'm sure each one of us in the private sector can get together and start some of these paramedical courses, so that we are able to create the paramedical workforce, which is also going to be very, very critical in terms of delivering quality healthcare. The other important part where private sector can participate is in terms of creating simulation labs, skill labs, again in partnership with the government. So as hospitals, I think private sector and government sector can come together, maybe co-invest, so that staff from both public and private sector can participate in this and ensure that there is a skilled workforce available on both sides. I'd not like to repeat any of the things that my colleagues have spoken. I think they have touched on most of the critical aspects. But like what COVID showed us, that at the time of crisis, public and private sector can come together to really do a wonderful job. And I see no reason why we can't do it as far as skilling and strengthening the healthcare workforce goes. Thank you very much.
Great. Thanks, Dr. Santosh, for your insight. And definitely, there is a huge infrastructure capacity and the knowledge that resides with private sector that can help us to train and create a skilled workforce in the public sector and also the new workforce. I'm sure going forward in the next decade, we are not very far away where we'll have a global campuses in this country, which will be set up on a B2G or government-to-government partnerships, where internationally some of the countries from Africa, Middle East, and a lot of countries will set up the foreign campuses in India in partnership with the private player or a government to train the doctors in a partnerships where you have sharing of the seats, you have a co-investment mechanism in place, and maybe become a hub for creating a global healthcare workforce. That could be a future. I'm not saying it's happening immediately, but you never know what's happening at the pace which the changes are happening across the sector. That's very important element for us to look at in the coming time. Do we have Michael Allen online?
Yeah, Lalit, hello, good morning.
Hi, Michael. Michael Allen is my colleague, and he's a global lead for future workforce in healthcare, KPMG International, a vast experience in implementing a future workforce in healthcare, and it's a very apt word for this, I think, for India also, that how do we create the future workforce, healthcare workforce for this country. I bring him from sharing a perspective of, Alan, from your experience, you would have heard the challenges that we have, which are not very unique. They are the universal challenges that every country is grappling with. And I'm sure you would have witnessed them in many of your counters when you're working with various countries. Your key takeaways or insight that you want to provide us, the learning from the global and working with various countries on some of the work that India can take it up, as a top 5 priorities going forward, and some of the challenges that we have just talked about in this session.
Yeah, good. So thank you, Lalit. And first of all, let me congratulate you and everyone else who was involved in pulling together the report. I agree with the other panel members. I think it's an excellent piece of work. And you're absolutely right. This is not a problem or challenge unique to India. It's a global challenge. Many of you will have read my colleague Mark Britnell's book, Human, which was published in 2018. Which is estimated at that time that the global workforce crisis or shortage was 30 million. So 30 million deficit of doctors, nurses and allied health professions. I think our estimate now is that's grown significantly as a result of COVID and the changes that we've seen globally over the course of the last few years. And our latest estimates are that shortage is more close to 50 million. So this is a huge problem. So let me just offer a couple of provocations and suggestions on things that you might consider going forward. And certainly this is very much drawn on my own experience of working with 44 different countries looking at these challenges. The first is, there's been lots of talk this morning about increasing doctor numbers, and of course that's absolutely critical, but that takes time. So there are some interventions you need to think about in the short term. We have a very simple model that we use when we're speaking to our clients across the world, which says there are only 6 things you can do to increase your workforce in the short term, and each one of them begins with the letter B. So you can build more, you can bolster, you can bind, i.e. you can keep people in the workforce for longer, you can bot, use technology, although the potential for that is still reasonably limited. You can borrow, or you can buy. And they're the only 6 things you can do. Now, when you start thinking about those in detail, one very quickly concludes that actually there are only 2 that you can really do with any material impact, and that is to build and to bolster. So what do I mean by that? We know from global surveys of healthcare professionals, doctors, nurses in particular, right across the last 10 years, that they report spending about 80% of their time doing activities for which they're overqualified. So think about that latent capacity, that expertise which exists in the workforce, which isn't being used to greatest impact. By bringing in lower qualified staff, new people into professions, and I think one of you, I think it was Dr. Puri earlier, was talking about physicians' assistants, nurse associates, etc., but also bringing in entry grade people who can take work off other healthcare professions, can make a huge impact, we believe. If you look at the way in which various nations responded to the COVID pandemic, whether it was changing the ratios of nurses in intensive care units, whether it was the way in which vaccine programs were rolled out, etc., they all used building and bolstering as a kind of key enabler or underpinning part of their approach. So my first provocation suggestion is that you really think about how you build and bolster and how you release some of that latent expertise and capacity that exists in the professions. The second area that we see, I think, starting to sort of emerge globally then, and this links to my previous point, is around micro-credentialing. So what is there to stop as giving individual professionals specific training to undertake certain procedures at volume and whilst maintaining quality? So if you look at the way in which this has been done in other countries, nurses doing endoscopy, etc., is maybe one example of that. But there is lots of opportunity to get individual practitioners doing particular procedures by giving them specific training, regulating them to do that procedure. So micro-credentialing is an important part of the short-term approach. And of course, to do that, your approach to professional regulation has to evolve a little as well. 2 final points I'd make, so I'm just conscious of the time, Elite. In the medium and long term, I think there's a number of other people have already alluded to, our ability to forecast future workforce requirements is generally quite poor. In particular, our ability to forecast future workforce requirements based upon service demand and emerging service models. So if we think about the way in which care is changing, the models of care are changing, the pace of that change is accelerating rapidly. So what that means practically is that we have to have quite sophisticated modelling capability to be able to anticipate and forecast the future requirement for different professions, but also for different subspecialties. I think there's others, again, have alluded to earlier today. This is something we've started doing in the UK. We're seeing the Canadian healthcare system starting to get very interested in this, and a number of other nations. So building that kind of capability and capacity to do sophisticated, what we call integrated workforce planning, so integrated with service planning and demand planning, is a really critical thing, because if we don't know how many doctors, nurses, therapists we need in 10 to 15 years' time, it's pretty likely that we're not going to have them. And then the final point I would make, and this is something which I think is often overlooked when we tend to look particularly at the clinical professions, is how do we build digital capability and expertise in the healthcare sector? So there's a school of thought, one personally that I subscribe to, which is that in 5 to 7 years' time, outcomes for cancer care will be as dependent on your ability to attract data scientists as it will be your ability to attract oncologists. And yet very few providers or healthcare systems are creating the pipeline of experts in digital technology and in data science to enable that. Now, knowing what I know, knowing the little I know about India and the capability you have in your universities and education sector, I think you're brilliantly placed, not just to become the university of the world in terms of providing doctors, nurses, and other allied health professionals, but also to respond to that global challenge shortage of digital healthcare experts and data scientists that can work in this sector. Thank you.
Thank you, Alan, and really appreciate your efforts. It's around 5:30 a.m. in your country, and you really took this time. I think one valuable takeaway that I have for this is it's not only the going forward, the future workforce in healthcare is going to be only the healthcare workforce or the traditional healthcare, but it's also going to be the new addition, new skill sets that would be required. And do we have an understanding or identification of those skill sets that would be required for us to building the future healthcare workforce for this country? I think that's very important to it. Looking at a lot of things that we have outlined in the report, the thoughts that we had from you, I think very one simple. I think the government and we all have been working towards the one health, one nation. I think at some point we have to start thinking about one health, one plan and collective efforts. Without this, we won't be able to reach where we are planning to reach. Having said that, let me have last few closing remark and words from Dr. Agnani, and before we proceed on the closure.
Thank you. There was one question. I must allow that question to ask. Yeah.
Thank you, sir. And it's my privilege to ask questions in just big people like you. So as Mahesh sir mentioned that the future of dentist, and I am also a dentist who left dentistry because of very few MDS seat and very few job opportunities. So I would like to ask you that as PMJ and Ayushman Bharat scheme launch in India, it covers the insurance scheme. So why not dental insurance come and boost the dental career in India? As we can see, many of the developed countries like US and UK, their dentists are actually paid more and people pay more attention to their dental treatment because dental treatment is covered under dental insurance. So I would like to ask you that will dental insurance in India, when emphasized, will bring boost to this industry, and what will ministry will do to boost dental industry?
Thank you. That question is directed to me. Okay. So I will try to respond to that indirectly when I conclude, yeah, because I am not a authority on subject of question which you have asked. Rather, I have a different opinion on that subject actually. So to conclude, it was a beautiful discussion, and I will take just 2-3 minutes. It's a lot of learning for us also in the ministry. Just wanted to say that we are also creating health registry, professional registry, which was referred to, and suggestion which was said by Lalit is that National Digital Health Mission is actually creating Aadhaar IDs for individuals. It's called Ayushman Bharat Health account. Then for the doctors and other allied health professions also, we are trying to create through their respective regulatory bodies their respective IDs, and so is for the institutions, and that we think is the basic thing. If you really want to bring in ICT, and reference was made to artificial intelligence into the future of those things, these are the basic things. We'll need your support on that. On Dr. Binu Vajpayee's thing, you heard him, and I have many questions actually, but this is a limited time. So we will need to think out of box also. A case in reference was made by case mix for the group accreditation, and a good example was given that the private hospitals are dealing with the gynae patients and OBS patients are being dealt by the public hospital. So the out of box thinking, I am not suggesting, could be that think about the policies. Do we have some policy which needs correction, like institution of the Janani Suraksha Yojana, which was actually brought in to increase the institutional deliveries? Have we reached to that goal, and can we rethink about it? So out of box thinking on that. Curriculum improvement and the examination, of course, examination also, you are aware that NMC is now thinking of the national exit test, how shortly it is to be introduced. That will bring in quality aspects. On the issue of Dr. Sanjeev, I totally agree that it's not the healthcare professionals we are not able to attract them, but it's largely because of the skewed distribution which he referred to, and we need to incentivize through digital things, and just don't link it to the postgraduate seats which are being vacant by concluding that we are not able to attract them. That's a very, very different thing, and that's only doctor centric and postgraduate centric, because we know the college is wanting certain seats and NMC is along those seats, so we don't have the numbers. As Dr. Narottam Puri said, that we don't have the forecast of the future requirements. We need to work on that. But totally agree that we need to do more work in the areas which have the skewed distribution and digital incentives to bring in. Dr. Mahesh Verma, yes, you are right. We have lot many people, dentists working for us. They actually do their post-graduation in public health, and I have seen most of colleagues with there. But I refer to thinking going on of task shifting. So why not the dental surgeons can do those surgeries which are related to this, and oral health program becoming a larger, looking to the prevalence of oral cancers and also need of the communitization of that aspect. But we need to create, as you said, the referral linkages from the PSC to secondary and the tertiary level cares, and quality of services will be very, very important. I take your point of doing more with the dedicated medical or dental hospitals rather than creating more dental colleges. So we'll send you a reference to the Dental Council of India. Dr. Narottam Puri, we can't agree more than what he has said. Absolutely, I totally agree, and we need to focus on quality. That's the mandate. We don't want quality quacks to be there. And sir, the nurse practitioners and the physician assistants, that's something which is happening. And the nurse practitioners, how much to allow them and how much there are pharmacists who are D-Pharma. They also are given some prescription rights in the various countries. So we are in dialogue with the National Medical Commission, how much of the, like we have a nurse practitioner critical care, so can they not deal with the patients independently in the critical care blocks? Answer could be yes, answer within the institution, but answer could be no. Can they allow them to work independently, but for the midwifery cadre, there could be answer that we allow them to work in differently. But yes, so the point here is that all the regulatory commissions also think in unity, and communication is the way forward, sir. I have taken your point. Dr. Santosh's point on skill, yes, but I have a suggestion now. So from today we can make a resolve. Let's not call these paramedicals, and we stick to the term allied and healthcare professionals, so that we can invite all those 56 professions to begin with and introduce those courses which are very critical and vital. On the last point of Ellen on forecast future requirement, yes, we need to have our own model, because if a country in the Western world is doing the forecast future requirement, will be just limiting to their requirement, but we need to do the requirement how much we need within the country and how much we can serve to the global community, and that will be that needs to be titrated according to the disease profile, the disease burden, and the demographic profile of those countries and the requirements they are meeting. So that so that's a very important challenge. On the last, yes, ma'am. So. Dental insurance, a case was referred that under the Ayushman Bharat PMJ we have less number of procedures outlined, but will that be the answer? I don't think is something which we need to think beyond of taking help of these dental professions, a rich resource we have available in the country in healthcare provisioning, not only in the country but outside. I thank you all for joining this session. I wish we had some more questions to ask and it could have been more participatory, but I am taking a lot of lessons here. And let me also acknowledge the role of the private sector. So it is not, sir, in between of Dr. VK Paul and Dr. Vinu Vajpayee, I totally agree that private sector has played an important role. I can say because I was the in charge nodal officer for National COVID vaccination program from day one. So I have seen how private sector has played its role. It can't be, as you said, in a boat where both public and private sector, if we can't work in tandem, we can't see a future for this country. Thank you very much for joining. Namaskar.
Thank you. I think we have very limited time, so Dr. Lal, over to you, and then ma'am to you for a very quick question. But panelists are going to be around, so you can always ask them a question and meet them during the tea break.
Morning, sir. I'm Brigadier Dr. Arvind Lal, Chairman of Dr. Lal Path Labs. I would just like to sensitize you that there are not 56 other allied professionals, there are 57. The last one is a phlebotomist, which the government of India has not recognized. And he is the guy who's put his, life on the block, and 10,000 home visits he has done every day. So our humble request is to recognize the existence of this gentleman, and we are training them by thousands. And also this will be probably the largest workforce, from the healthcare point of view. And there, for every one technician, MLT, you need 10 phlebotomists. So that is the other thing. And so, and to Dr. Meenu Bajpayee, sir, our case with you, sir, is long pending, and that is standalone lab. We are the highest testers of histopathology biopsies in the world, 1400 per day, and our case has been rejected on a non-conformity that we are not attached to a hospital. It is, when you go for quality, Dr. Narottam Puri is there, it is NCs we call them. One are compoundable and one are non-compoundable. Ours is highly non-compoundable, so please look into it. Thank you, sir.
Thank you, sir, and thank you to all the eminent panelists here. We request you all to stand up once for a group photograph.
Yeah, I've got one comment. First of all, I'm Dr. Sunila Garg. I'm chair of NIHFW Program Advisory Committee. I wanted to say that India requires a generalist approach. By and large, we are all very clear, and then the specialist approach. So it is important that we do have skill labs. Only thing is we are not aware of. We started with Maulana Azad Medical College, and recommendations went to Medical Council of India. The need is to do the situation analysis. How many medical colleges do not have, and those who have, how many are utilizing? Because the wonderful lab at Azad Medical College, wherever I have gone, Noida Institute of we do have. Idea is to know what is existing. So that is where another thing to Dr. Meenu, my approach is that when I was heading community medicine, I realized a couple of hospitals approached us that, madam, we need teaching for our DNB candidates. So that is where, and we came together. We taught the students, we guided them in thesis and all that. So this was an example of private-public partnership. Again, Dr. Mahesh, for you, I went to many states, and let me tell you the other way around. It's the dental graduates and postgraduates who are employed in National Health Mission for the job for what they are not meant for. So it is also the other way around. Right person for the right job is the need of the hour. That is important. And another thing is that, Dr. Narottam, sir, my question not only by my real hardcore experience, when I was framing national program for prevention and control of deafness for the country, and I never knew about ABCD, about ENT, and I went through all of that, and I realized that a problem with 7% prevalence of moderate to severe hearing loss out of 100 people. We are so much of shortage of audiologists and audiological assistant. Aish Maisir is there, or Aliawar Jang is there. Problem is of retention. But then we realized that at every district level, we'll create a post for audiologist and audiological assistant. And if we want, we can do everything. In a year, we set up 6 satellite centers along with Aish Mysore, so that we can have rapid. So this is one thing which is very, very important. So thank you so much.
Thank you, ma'am. Sorry, we are running very late today. Thank you, everyone on the panel.
We'll have a very quick health break for 5 minutes. In the meantime, I would request the panelists of the next session to kindly come closer to the dais.
making quality cancer care more accessible and affordable in the country. We are joined here today by a very celebrated panel. We have Mr. Raj Kore, Co-Chair FICCI Task Force on Cancer Care and the CEO of Healthcare Global Enterprises Limited. We have Dr. Rajendra Badwe joining us virtually. He's the Director of Tata Memorial Hospital. We have Dr. Harit Chaturvedi, the Chairperson, Max Institute of Cancer Care. We have Mr. Vineet Gupta, Director Medical Affairs, Ovarian Medical Systems. Dr. Kaushal Kalra, HOD Oncology, Safdarjung Hospital. Dr. Mandeep Kumar, VP and GM, Intuitive Surgicals. And Mr. R. Venkatraman, Founder and CEO, Karkinos Healthcare. And I would like to now hand over the discussion to Raj to start off with the keynote speech.
Thank you, Shrimai. Good morning, everyone, and welcome to the panel discussion session on making quality cancer care more accessible and affordable in India. The surge in incidence of various types of cancers, coupled with suboptimal mortality to incidence ratio, low affordability of treatment, and poor quality of a survivor's life in the country is taking a gradual shape of an impending health crisis, and the time is prime for taking concerted and collaborative effort to contain and control the imminent cancer epidemic. Perhaps no other disease is comparable in its devastating impact on the life of patients and families, with a recent survey of about 150 patients revealing more than 60% patients associate words such as tough, bad, stress, pain to describe their quality of life during the treatment, and 20% patients continue to associate words such as not normal and weak even when they are cured or under remission. To address the dual challenge of rising incidence and suboptimal mortality to incidence ratio, it is imperative that the country focuses on large-scale awareness campaigns on risk factors, symptoms, screening and treatment options, effective prevention by modifying exposure to the key risk factors such as tobacco, alcohol, obesity, and targeted and improved screening coverage as the primary response while avoiding the unnecessary stigma attached to cancer. Following that, the key is to manage the disease in the right way the first time, and at the last mile, which can only be enabled through a comprehensive approach, keeping the patient at the core with strategy and policy measures that are resource stratified, enabled through multi-stakeholder partnerships, powered by frugal innovations by the providers and underpinned by technology, which truly makes cancer care delivery predictive, personalized, and precise. To make cancer care more effective and affordable for the entire population, we must improve workflow efficiency and treatment outcomes. Using its trademark ingenuity and frugality, India has an opportunity to find innovative solutions to bridge the existing care gaps for her citizens and to guide other developing and developed nations. Serious efforts are required to ensure larger population of the country can afford cancer care going forward, and for this, insurance, whether government-sponsored or retail, will play a key role. Given this backdrop, the report by FICCI Task Force on Cancer Care Infrastructure, in collaboration with EY, on call for action, making quality cancer care more accessible and affordable in India, is a timely initiative to highlight the need for more effective policy measures aimed at proactive cancer prevention and treatments. We thank all stakeholders, including policymakers, oncologists, private providers, health insurance companies, and NGOs who gave us time to deliberate on various aspects of this report and share their valuable views, insights, and experiences, which has positively shaped the form and content of this report. Thank you.
Before we start off with the panel discussion, we'd like to have a short presentation summarizing the key points and highlights from the report. If you could just have the presentation on the screen, please. And I would just like to, as Raj mentioned, I would like to thank all of the various stakeholders who have collaborated with us in contributing their insights onto the report. And we've also taken the opportunity to actually reach out to about 150 patients and taken their direct insight and their pain points and how they would want to look at the landscape of cancer care changing going forward, and use some of those inputs to guide the recommendations which we are coming up with as part of this report. So if you could just move on to the next page, please. The page after this. Very quickly, we'll summarize on the cancer burden, the disease burden, to set the context, and then we'll talk about the maturity of the India cancer control landscape, about what are the current challenges which we face today, and emanating out of that, the key recommendations we'll quickly summarize on coming out as a part of this report. If you can, going forward, if you can move on. On the cancer disease burden, I think all of us are aware about the increasing disease burden in the country. Currently, it is estimated to be about 19 to 20 lakhs, and it is growing at a fast rate as well, of almost 6 to 7%. And if we look at the ranking of India, it ranks third after China and US in terms of the new cancer cases being reported. While we do see this disease burden increasing, and the burden is significantly skewed towards certain types of organ like the head and neck, the ovarian cancers, prostate cancers and breast cancers, which are growing much faster than the average growth rate of incidence. There is also a specific characteristic of the disease burden, which is in terms of late stage detection. And we don't find more than 30% of our cases being detected in stage 1 and stage 2, which further aggravates the problem of the disease in the country. And there is a duality of challenge which we are facing at this point of time, that not only is the disease burden increasing, there is also a significant issue with respect to the outcomes, specifically if we look at the mortality to incidence ratio, which is higher compared to most of the, in most of our organs compared to countries such as the US, the UK and the China. And we are almost seeing about 8 to 9 lakh deaths being caused by cancer, making it one of the top 5 diseases causing deaths in the country. A very important point which I would like to highlight here is that if we were to quantify the impact of all these of the economic loss, which is likely because of this disease burden, it would turn out to be almost 0.5% of the GDP of the country. Moving ahead, if you could move on please to the next slide. What we have tried to do is look at a holistic way of understanding the current state of cancer control in the country, which keeps the patient's quality of life at core and is focused on various important metrics, which is to do with reducing the overall incidence, reducing the mortality and improving the survivorship. And for achieving this, the various levers which are key, if you look at the primary side, it is of course on the awareness and the prevention element. Following that, there has to be a significant focus on screening as well as detection. Thereafter, we need to move on to ensuring that there is access to the right quality of treatment and there is affordability along with that to avail that treatment. And all of this needs to be actually empowered with data and technology, which actually helps us capture information about the disease burden, the patient profiles in the country, and inform the policy decisions as well as the actions to be taken by the different stakeholders. If you can move on, please. Very quickly, I'll just highlight a couple of very important key points to talk about the challenges which we face across these various levers. On the awareness side, significant focus has been there on tobacco-related awareness in the country, whereas a lot of the other cancers where we see a huge amount of disease burden, whether it is cervical or breast, the focus on awareness creation has definitely been on the lower side. Although there are a lot of policy measures which have been taken to improve prevention, but we do still see almost a 28% prevalence of tobacco consumption, which is higher than the global average. We do see still that the HPV vaccination is not a part of our universal vaccination program. Almost 1 in 4 Indians are obese, obesity also being a key risk factor for cancer. And almost 1 in 5 men in the country consume alcohol. So significant measures are still required to improve the prevention landscape of the country. Following that, what is very critical as another element of primary response is to improve the screening coverage and uptake, which is less than 5% in the country at this point of time, and it's very low when we specifically look at certain organs like the oral cancer. And for this, of course, a lot of intervention at the health and wellness center side, equipping them with the right trained manpower, improving the awareness levels as well as the training of manpower at these centers, as well as having a very, very strong referral mechanism which links up the identified cases with the higher tertiary care centers for treatment is very critical to make this a success. If you move on. Coming on to the access side, another very, very important pillar for cancer care, and there are a lot of gaps or areas of improvement which we see at this point of time here. Comprehensive cancer care, which specifically looks at providing all modalities of treatment, medical, surgical, and radiation. We see that only 30% of the districts in our country actually have access to a comprehensive cancer center. And almost 60% of our radiation equipments are located in urban areas, whereas the rural population is residing elsewhere. And the overall penetration of RT equipments is about 0.4 per million, much lower than the WHO norm of 1 per million. The similar issues persist in the case of PET CTs, which is a very, very critical diagnostic tool and a very important instrument today in deciding the staging and the right kind of personalized treatment which can be offered to patients. On the doctor side, we do see on medical oncologists and radiation oncologists significant gap which needs to be filled in to cater to the current incidence. And palliative care, which is another critical pillar of the entire treatment pathway, we see only 1 to 2% of the population having access to that against the global trend of about 14% access. Now, to make all of the access possible, there is of course the need for making this care affordable. And with growing insurance in the country, whether it is being provided by the government or by the private sector, there is need for uniform standard protocols which guides the comprehensive care plans and helps standardize the various reimbursement tariffs which we have across these schemes and provide more comprehensive coverage, which is a little bit more flexible depending upon the type of cancer, the stage of detection. And of course, another very important point wanted to highlight here is that a lot of these programs today, or the schemes, the insurance policies today do not cover some of the advanced therapies which are critical in improving outcomes, whether it's PET CT, genomics, or targeted therapy and immunotherapy. If you move on, please. Just wanted to summarize some of the challenges here which we've talked about with a key set of data points which we collected through the patient survey, and some of the, while there are a host of data points which we have collected across 7 different themes, but what stands out as key is the elements around the delay in access to care, which they have talked about, where 58% of the patients actually do their diagnosis only based on symptoms and it's not based on a health check or a screening. Almost 49% of our patients actually have their initial diagnosis done with a GP. More than 50% of patients actually take more than 5 tests and more than 1 consult to conclude on the diagnosis. And 46% patients who have taken second opinion actually do so because they lack confidence on the initial treatment and diagnosis. So very, very key points to highlight about the challenges which patients are actually facing, which are the real challenges in terms of access to care. And on the affordability side also wanted to highlight aspects around the fact that more than 50% of patients actually spend more than 5 lakhs for a complete treatment, course of treatment across modalities, and a lot of them actually have to travel almost more than 10 kilometers to avail treatment. So again, grappling with issues both on the access as well as the affordability side, impacting the ability of patients to avail care at the last mile. If we have to summarize, please move on. If we had to summarize some of the recommendations which is coming ahead, you can move on to the next slide, please. Yeah, before we get on to the recommendations, just wanted to summarize this aspect around the growing disease burden by highlighting that if we were to look at the aging population, the growing population, the intensification of all the risk factors which we talked about, as well as if screening was to improve going forward, and more than 50-60% of our cases were to get reported at stage 1 and 2, we would see a 9 to 10% growth in the disease burden over the next 7 to 8 years, and almost a 40-45 lakh new reported cases coming ahead. And there is need for preparation both on the infrastructure as well as the medical fraternity side to be able to cater to this growing demand ahead. And some of the recommendations, while we have almost 32 recommendations which we have collectively come up with through support of the entire stakeholder team who has participated in this discussion, but just the key points, if you can move ahead please to the next slide. On the awareness side, I think just 3 things which I would want to talk about is stricter enforcement of regulations on tobacco, whether it is through taxation or gradual banning, by providing alternative means of income right down to the farming level. On cervical cancer, much more stringent hygiene standards as well as sanitation becoming a much more popular topic going forward, both in rural and urban areas, as well as inclusion of the HPV vaccine in the immunization program. Focus on increased physical activity by creating areas of walking, jogging in metros as well as in the semi-urban and rural areas. On the screening side, if you can move ahead please. On the screening side, just ensuring that our HWCs are equipped with the right amount of trained workforce. GPs, which are the original gatekeepers, and we did see a lot of patients moving to the GPs first as the first port of call, being adequately trained about the symptoms as well as the kind of screening methods they should adopt, as well as creating a closed loop network, leveraging data to ensure that there is the right referral happening to the higher centers for confirmatory tests as well as for the treatment. And all of this, of course, can also be enabled if the government can look at inclusion of screening as well as annual health checkup in some form under their various schemes, which will help also leverage the capacity which is available with the private sector on the diagnostics front to make screening much more widespread in the country. On the access side, if you can please move on. Just a couple of points on the access side. Of course, if all of our public as well as private medical colleges were to mandate oncology as a program and also set up radiotherapy as a department, we could definitely increase access to many more number of districts, or at least double up the number of districts which have access to comprehensive cancer care. And this will also create demand in the country for attracting investments from medical technology companies to set up their facilities here, either from a manufacturing or an assembly line perspective. And not all of this demand, of course, can be made possible to be met through local manufacturing. We definitely need to look at the imports part, and in that space, customs duty, IGST reduction, both on radiotherapy equipments, radiation, your various reagents, radiation equipments, as well as pharmaceutical drugs would be key going forward. And I think the previous session also we touched upon specialty specific need for creation of DNB seats. Definitely on medical as well as on the surgical oncology side, there is need for creation of more seats, and for that relaxation provision to some of the private sector to participate more will be key. And I think just to sum up, if you can move to the next slide. On the affordability side, I think what is very critical at this point of time is to make sure that there is a set of standard treatment guidelines which guides these comprehensive care plans, and for that there should be some kind of an apex body of the likes of NCG which guides these kind of treatment pathway designs, care plan designs, and therefore the right reimbursement rates both for private insurance as well as for the public sector. And accreditation, which is cancer specific, will play a key role, like it is playing in a lot of the other developed parts of the country, to make standard treatment protocols, adoption of advanced care, as well as therefore having a positive impact on the outcomes, a possibility going forward. And I think I'd just like to close the session by saying that it's very important also for making cancer notification mandatory, as well as ensure that there is a much more wider setup of a network of cancer registries in the country, at least covering 40 to 50% of the population from the current 10%, such that we have a lot more data around incidence, mortality, as well as on the survivorship, which can guide targeted actions around the policy decisions which we need to take for this disease to be managed and controlled going forward. With that, I think we would like to now move on to the panel discussion. And if we have Dr. Badwe online, we could possibly start the discussion with Dr. Badwe. Do we have Dr. Badwe online? Good afternoon, Dr. Badwe.
Good afternoon. Am I audible there?
Yes, doctor.
Okay.
And a very warm welcome to you for the panel session. Doctor, given your wide body of experience on the practice side as well as also on a lot of research work which is being done by Tata Memorial, what is your view around the key patterns which are emerging across different parts of the country with respect to the disease burden? And how do you think this should guide our prevention and screening related policy measures going forward?
So today's reality is that the numbers are about 100 per 100,000 in cities, about 75 per 100,000 in mid-sized towns, and about 40 to 50 per 1 lakh population in rural India. Urbanization is happening at a rate, as per the last census, about 7%, rising up to 10% every decade, which I'm sure will increase a lot more rapidly across the country. What is good about India is that this 100 to 110 in cities has been the same number for the last 2.5 decades. So we are reaching up to whatever that 100 to 115 per 100,000 as the number, unlike the other BRIC countries where the numbers have gone up to somewhere close to about 200 and rising up to 350, which is the number in United States and in Europe, 350 per 100,000. So we are much less. Let's be fortunate that we are like that. And as the urbanization happens, the 1.3 million per annum is an estimate based on 100 per 100,000 for the whole population, and that's the number we will reach probably in another maybe a decade or so, or maybe longer. Longer the better. While we talk of this, our survival isn't so good, and that needs to be improved without increasing the denominator of the incidence. What is important is that there will be some increase in number with urbanization, and there will be even more increase in number if we were to screen. So screen only the places where we are likely to save lives, and screen with a modality that does not increase the diagnostic numbers. So over-diagnosis to be avoided. If these two facts are utilized appropriately for screening, we have won it. We have done it. We would be doing it extremely well. So for cervical cancer, either VIA or pap smear is good enough, and cervical cancer is reducing at a breakneck speed. The Mumbai numbers today stand at 7 per 100,000, a number which is 6.5 in United States. So we are already on low, and no registry across India has shown an increase in cervical cancer in the last 2 decades. So please understand, it's reducing. A good screening modality, either VIA or pap smear, should be good enough, and that will, I'm again talking about reducing the cost and increasing the efficacy without increasing the numbers, the absolute numbers that will start rising if we were to screen indiscriminately with a procedure which will have a lot more overdiagnosis. The second cancer that needs to be screened is breast cancer above 50. Since below 50 there is no efficacy parameter of any modality, and above 50 either a physical examination or judiciously mammography. Again, physical examination has 30% reduction in deaths because of breast cancer with no overdiagnosis, and mammography has somewhere close to about, again, 30% reduction with a 30% increase in the incidence. So overdiagnosis of 30% is what we cannot afford at this juncture without any added benefit. And third, which I find is the most important for India, since somewhere close to about 25 or 30% of cancers are related to tobacco, is some kind of oral cancer screening which is easy, accessible, can be performed by visual inspection, and that will pick up cancers early to be cured very effectively. On the therapeutic side, I would suggest that we should have modalities which are cost effective, which are at low cost and increasing the outcome sizably as far as survival is concerned. All this is possible if we are transparent enough. Each institute, each facility that is delivering care should have the responsibility of putting up what is the number that they treat every year, what is the staging of the patients that they are looking after, what is the compliance to the guidelines they have predefined before, and what is the 5-year cure rate of their patients. If these are available online for anybody to look at, I think that much of transparency would allow patients not to go far away from their own residence. I'll stop at that.
Thanks a lot, Doctor, and your views around the measures being resource stratified as well as transparent, I think are very key to this entire policy decision framework going forward. But Doctor, what is your view on the rate of capacity creation in the country, and what do you see as the role of a public-private combination in this going forward, such that patients can get treatment closer to their homes?
So public-private partnership is a key, the most important intervention to have affordable care everywhere. And the private partners should see to it that the costs don't go through the ceiling while it's being delivered. There should be a subsidy which should be given for those who can't afford, and a healthcare facility should look after the whole spectrum of society rather than a lopsided view of this is a rich man's place and that's a poor man's place. That is not sustainable for long term.
Got it. Thanks a lot, Doctor. And just to take on with that same point, Raj, if we could get your views on how the private sector is actually also playing a role on taking access beyond metros, standardizing care and improving outcomes. And how more do you see the private sector participating in a bigger way going forward in furthering the cause of cancer care?
So I think private sector is already playing a major transformative role in bringing the best cancer treatment to India. 70 to 75% comprehensive cancer centers in India are either private owned or trust owned. Majority of cancer patients, more than 60% of cancer patients, prefer private hospitals for their cancer treatment. As you know, as an organization, HCG has been a pioneer and a leader. We have the largest base of comprehensive cancer centers, 21 centers in 18 cities around 9 states. We have the largest installed base of linear accelerators and PET CTs. But one of the things that I feel most proud about what the organization has done is I was looking at the quote that is in front of me from Mahatma Gandhi, which says the industry should regard themselves as the trustees and servants of the poor. And all of us who have joined healthcare, somewhere that has resonated with us, our minds, our hearts at some point, and that's why we are part of healthcare. So for HCG, our journey to bring most advanced cancer care to non-metro cities, to tier 2, tier 3, tier 4 towns, started in 2003 with one center. Today, more than 2/3 of our 21 centers are in tier 2, tier 3, even tier 4 cities, with population of 2 to 5 lakh in places like Ongole, in places like Gulbarga, in places like Shimoga. Another thing that we all should feel proud about private sector is not only we've got the best technology and best treatment options to India, but with our frugality, with our ingenuity, we found a way in certain institutes to deliver the outcomes which Dr. Puri was talking about in the morning, which is comparable to the best institutes across the world at a fraction of cost. And this is very well documented through Harvard and other business case studies. So, you know, I feel that private sector is playing major role, and it will continue to play increasing role going forward. Today, there are emergence of regional players who are focusing on oncology. Even the national multi-specialty players are now looking beyond big cities. So things will get better and better. Now, how do we increase the greater participation of private sector? Like Dr. Puri earlier said, look at us as a partner who can help reduce, control, manage the disease burden across India. Engage with us, discuss with us how we can improve situation going forward. We have problems on both sides. We have financing viability problems on supply side, and we have affordability viability problems on demand side. So finding attractive financing, reducing duties. Radiation equipment is one of the most required critical equipment for oncology treatment, and we have a major gap there. But today, with custom duty and IGST, the cost of imported radiation equipment goes up by 30%. I'm sure we can do something about it. Insurance penetration is increasing. We need to do more and more to create awareness about retail insurance, private insurance, as well as government insurance. Really happy that government is stepping up as a role of a insurer or a payer. Number of people insured under government scheme has doubled in last 10 years, 16% to 32%. But we need to take it to the next level now. Certain basic diagnostic procedures are not covered in many schemes. PET CTs, biopsies, targeted therapies, immunotherapies. We need to find ways to accommodate them. Insurance rates don't get revised year on year. Last 10-year average inflation rate in India is 6+%. So 100 rupee in 10 years ago will be 170 rupee today. Rates are not revised regularly. Payments are not being made on time. We also need to find a way to cover pre and post treatment expenses under the insurance cover. Cancer is not an episodal treatment. Cancer journey starts at home and it continues for the rest of the life. So how do we, bring more and more that under the insurance cover and reduce out-of-pocket expenses is the challenge that we need to resolve. So those are some of the things that we are challenging. But I think with this report we'll be able to create more awareness, and I'm sure we'll be able to make faster progress going forward.
Thanks a lot, Raj. Just on that point around making the adoption of advanced treatment care possible, how do you improve the awareness around that also amongst patients, that they are more aware of the fact that cancer now is more of a curable disease and a lot of alternate treatment options are actually available?
Yeah, so I think the report statistics are alarming. More than 70% of cancer patients and their families have never undergone any screening. 61% of cancer patients get diagnosed after the symptoms appear. 49% of patients get diagnosed by GPs. So there is a lot more that we need to do in general in terms of what are the risk factors, how does one look after yourself, how should we go under regular checkups, screenings to detect it earlier. But I think we have an opportunity to engage the entire healthcare ecosystem as multipliers to do that. GPs, since most of the patients, cancer symptoms are headache, any body pain, they're not something different. So your first stop is GPs or nursing homes or multi-specialty hospital. Dr. Mahesh was talking about dentists. Probably head and neck oral cancers go to the dentist first. So how do we engage non-oncology specialists, healthcare workers to screen, identify, diagnose cancer symptoms as soon as possible without wasting time? So the early detection, early stage detection gives them their best chance not only to get best outcomes but reduce the lifetime cost of treatment for them. That's something that we need to do more and more. This year alone, we have done about 300 CMEs across 12 states, just focusing on educating, non-oncology doctors on it. Lot of outreach activities we have been doing. We have a very vibrant academic and research program. We have more than 70 courses for clinicians, nurses, paraclinical healthcare workers. About 140 candidates get admitted every year through our academic program. So there is a lot more effort that we need to do, but I think we need to think differently. You look at what is happening on education front. World had stopped being linear. We learned everything from left to right, page by page. Now kids learn from link to link, click to click. There's nothing linear about it. They don't learn just by reading or in class physical. They read through tweets, they read through Insta, they read through videos. There is so much opportunity to put that knowledge on various online platforms, so it's available on demand rather than when you want to give them or when they want. It should be when they want to hear it. This problem will have to address. You see, consumer behavior is also completely changing. Today, consumer decisions are happening across different channels, digital, physical, omni-channel. There is no linear journey there, right? If consumer patient, prospective patient is learning and behaving like that in every other aspect of life, they are expecting healthcare also to cater to that. And there is an opportunity to bridge that last mile gap by in cancer care communication and coordination by adopting this omni-channel digital physical strategy to bridge these gaps.
Thanks a lot, Raj, and maybe I think just in continuation to that on the skill creation, skill building aspect which you touched upon as well. I think I'd like to take the next question with Dr. Harith. And would like to hear your perspective on what do you think is the current maturity of standardization when it comes to treatment guidelines in the country, and how can this be more implemented in a much larger way? We do hear of multidisciplinary tumor boards being a very important measure for improving outcomes, and how can that be made more universal in the public and the private sector?
Thank you, Shrima, for this, and thank you for having me here. I think before I touch upon this, I'll just mention a couple of points from where Raj was talking about regarding awareness and screening and diagnosis. I feel there's an opportunity. The government is spending a lot in setting up these big hospitals, and then you have a mohalla clinic model. Somewhere in between these two things, we need diagnostic centers. We have so many private diagnostic centers, both imaging and pathology, but we do not have government supported diagnostic centers. I think all of us know very well the point when a patient reaches a physician, whether it's a GP or a specialist, from that point till the diagnosis happen, the average time is about 2 months. And majority of these patients are hovering with the general practitioner at one level, second level. And one of the major reasons for this is that lack of this easy availability and access for diagnostic centers. So there can be very well be something between these things as only diagnostic centers, which is technology driven largely, and supporting or rather addressing the issue of delay in diagnosis. This is not just relevant for cancer. I think it's relevant for the whole healthcare as an industry. And as you have already highlighted so well that the non-communicable diseases are such a big burden, I think this can play a very big role. And they can be only daycare centers. They don't have to be manned as a hospital is manned. So a lot is possible in that space. As far as the screening, and this can also work for screening as well, because what will happen, screening per se, as Dr. Badawi was highlighting, is not the best way forward for our country. And while we did hear that 20% people had undergone screening, but the real truth is that less than 2% people have any form of screening in this country. So screening is not the only way or to fight cancer or to detect early. I think early detection should be our goal. And one easy way is creating these centers, clubbing those GPs around that and forming a club kind of thing, discussions, format, and taking it forward. As far as the prevention is concerned, while going through your report only, while coming to this place, I was seeing that while we have talked a lot about how still alcohol consumption is there in Gujarat, but still it is only 6%. So if Gujarat can ban alcohol and 6% are only consuming, and head and neck, the CAGR is some 40-odd%, we are heading for a disaster. So it is time to wake up, and New Zealand is planning a ban. All this I've read while I was coming here. So why can't we, the NGOs are working a lot in tobacco space and healthcare and all that. It is time for us to really introspect and say, can we really ban this? Answer is yes or no, not grey. If you keep talking grey, then you will never have an answer. Answer is yes or no. If we can ban, who is benefiting from it and how we fight it out is the real question. So I don't think it's so difficult. It's just one of the things which we have to take head on and fight it out. And similar thing on diet and physical activity, engaging schools, models, all this is in domain, all NCD, non-communicable diseases. This is the big chunk where it starts, and we are the capital of the world, and this is not the very pride place. We should look at it also and fight it out. Now, for your question on the current maturity on terms of standardization. So everyone talks about tumor board. You name any cancer center, they talk about tumor board. The answer is, what is the quality of the tumor board? And if I can say, actually it is pathetic unless it is driven by purpose, and that is lacking largely. So, for example, at Max we have created a digital tumor board platform, Harmony, which we are using very well, and this is one of the prime areas where we are very passionate about. The NCG has done this doing VTB, and we are having weekly virtual tumor boards from Max and from Tata, but the participation is very poor. Why? Because there is no mandate from the government or from the institutions or from the insurance companies to look at the recommendation of a tumor board before an approval goes. Now, if we create a model where insurance approval or any support from a CGHS patient or a panel patient requires an essential roadmap for the patient. What was the diagnosis? What was the stage? What is the roadmap? Submit that, and then you get a tick for the insurance payout. Probably it will drive much better practices than just talking about tumor boards and don't have a measure to find out what is really happening there. So that is something which is doable, and all can this be created online. If you're talking about online sharing of data and online mandating, this is certainly an easy way to solve it. I also want to say that the whole ecosystem of oncology, while driven on the clinical side by surgical, medical, radiation, I think radiology, pathology, nuclear medicine are so integral to it that I love to say that oncology means all these 7-8 pillars together and not surgical, medical, radiation. Because unless we talk about it, we will not fix this. Unless they are integral part of the tumor board, the quality of discussion will never go up. Because nobody will talk actually what we missed in the imaging or what we have not identified as the tumor type, which will have a different approach to treatment. So that is very important, and it is high time that we create such audit platforms of measures that at this level of performance, your approval rating is this much, and therefore you get 1-star rates for every treatment. If you show and demonstrate how your tumor boards are impacting outcomes, you will have this level. And if you show that you are actually participating in audit and everything and research, then you get next level of approvals. So all this is game, and it is time for us to really connect these pieces together.
Great, thanks on that, Dr. Harit. Just another point, we've not talked a lot about research in the space of cancer, which is very fast progressing all over the globe. So how do you see a lot more collaboration in the space of research, again on the private public side, data pool creation? How does this actually also have a link with the creation of much more robust cancer registries in the country?
I think this year the PM has announced on the Red Fort that research is the way forward. Jai Jawan, Jai Kisan, and then he said Jai Vigyan and Jai Anusandhan. So research is the way forward, and this is an essential piece, more so in the space of oncology, because the cost is huge, the challenge is big, and as Raj was mentioning, frugal, innovative methods putting together, this can only happen, and we can actually solve the problem of the world. Because we are not unique in our financial situation. The world is facing it, and we are unique in actually having a good mind power which we can put together. We can all collectively put our mind together and solve these things. So in this space, again, digital power will help a lot. I feel that in last 2 years, since the COVID times, a lot of innovations happened, and at least 3-4 trials are going on, meaningful trials in terms of universal tumor test. One test which will pick up that you are high risk for cancer, not at high risk for cancer. If such a thing comes out, probably suddenly you will have a whole paradigm shift in early detection and screening. You will have one test and people will know whom to test further, not to test further. So this is all waiting to happen. When it will happen, it's just time for us. As far as strengthening this pillar in our community and our institutions, again, can be very well be part of scoring system. Everyone is doing a bit here, a bit there. Very few studies are really multi-institutional, collaborative, and going forward. For example, we at our institution are part of about 40 odd trials. But how many are PI driven? Not more than 7 or 8. Largely it is pharma driven trials on specific questions and this thing. Likewise, in terms of publications, we also do about 70-80 publications in a year. That is because we have a large pool of oncologists. But then, is it part of our culture? Probably no. We are trying to push, trying to keep talking. We have got once a month meeting on research and review for oncology. What are we doing? So that is helping us keep the momentum. But I think going forward, unless it is part of a mandate from insurance companies, for government, for all this, that if at different level your payouts change, there is, for example, in US, why they are ahead of the curve in terms of research? Because it's mandated that people will have 1 year exposure to lab before they get into high-end clinical work. Most of the major hospitals have 1 day off for clinical research work for the clinicians, and it's proportionately different tiers. So we are probably heading somewhere in that direction, but I think a push will be much stronger if it comes from the mandated structures and the payouts get linked to all.
Thanks a lot, Doctor, and thanks for bringing about the aspect around the significant need of linking both treatment as well as research with reimbursements going forward. With that, I'll come to Dr. Kaushal Kalra, and we also understand that the public tertiary healthcare setup on the cancer side is making great progress. And how do you see the adoption of modern techniques on the public tertiary healthcare side, specifically on cancer care?
Field. Cancer is a very rapidly evolving field in the healthcare system, and we can see before 10 years so many modalities were not there, but now it's are there, and government setup is also adopting these. We'll come for this thing from diagnostic. Previously only CT scan was available, bone scan was available, now PET scan. Each and every cancer center has PET scan facility. So I think almost cancer center in government setup also are having or on the way to procure the PET scan for the diagnostic purpose. But in so many districts, there is no PET scan machine. And in metro cities also we can see in AIMS PET scans, they are doing in 7.5K, 7,500. But in private setup, if patient will go, they will charge from 10,000 to 30,000. There is no cost capping. There is no cost, I think cost capping and cost fixation should be there for this test. Similarly, in diagnostic NGS, next generation sequencing, these are also we are adopting in government setup, but it's there only in few center. And for the charges for these are also very high, and which out of the pocket patient has to pay. So middle class also can't afford this thing. Now come for the surgery. Previously only conventional surgery, modified radical mastectomy for the breast cancer. Now they are coming to the breast conservation surgery. Now it's the time for the robotic surgery, and certain public sector, in certain public hospitals, they are doing robotic surgery. They have started, but not every. So training should be there, and trained staff should be recruited for that robotic surgery. Now similarly, radiotherapy, previously conventional cobalt radiotherapy machines available at every center, every hospital, big hospital. Now it's a linear accelerator, and almost every cancer center adopting this using linear accelerator. I am actually medical oncologist. In the medical oncology, previously only conventional chemotherapies are available. Now it's the era of targeted therapy and immunotherapy. But problem is the cost. Costs are very high because these are new invented medications, patent only proprietary molecule. The cost is too high, and even middle class can't procure this immunotherapies and targeted therapy. So government has started some plan like Ayushman Bharat, but most of the immunotherapy targeted therapies are not included in the Ayushman Bharat scheme package, and cost is also very high. Ayushman package give only 5 lakh, but if we will see this cost is averagely I think 1 to 2 lakh per month. In Rashtriya Arogya Nidhi, government is providing more, maximum 15 lakh for these things, but that is also not enough. If you can see, most of the targeted immunotherapy it's more than 15 lakh. But one thing I want to say, if patient is purchasing from his pocket these immunotherapy proprietary item, the company is providing patient assistance program like 1+1, 1+3. But when government is procuring for the like CGHS beneficiary, ESI beneficiary, there is no patient assistance program, no PAP. The company is providing at the full rate. If patient will purchase, it will be I think 1/4 or 1/5 rate. But if government is purchasing at the full cost. But country like India, I think company should come forward and these facilities should be given to the government patients also, government funded patient also, so that it should be affordable for the each patient, and patient will get complete treatment. Like if patient will get fund of 15 lakh from the Rashtriya Arogya Nidhi and some like Ulaperivan medicine or pembrolizumab, it costs around 3 lakh per month. After 5 months, what will happen? Patient can't afford, and patient is having metastatic disease. Till the progression of the disease, patient has to take. After 5 months, what will do? 15 lakh is very good amount. So company should come forward, and after 15 lakh, patient should be provided free of cost. Some companies are doing, if after 15 lakh of purchasing of the medication for whole life, till the progression, patient will be provided the medication free of cost. Some companies are providing targeted therapy in the installment basis, on installment, monthly EMIs. That is also good ideas, so that even middle class can also afford this thing.
Thanks a lot, Doctor, for your views around how the public sector is also trying to adopt the modern cancer treatment techniques which are available. So while we talked about a lot on the clinical needs and the advancements which are happening, I'd like to now pose the next question to Mr. Vineet Gupta on radiation. And the question here is in terms of, we talked about how the input costs needs to come down, and we also talked about how access needs to be improved from a radiation perspective. So what do you really think are some of the disruptive actions at a policy level which is required to make radiotherapy more accessible? And what is the mix? Should it be more of customs duty modification? Should there be local manufacturing, bulk purchasing? What are some of the various levers which should be used?
Thank you, Shrimai. Before I talk anything new in terms of disruptive policies or anything of that kind, I think we need to step back and take a view of the existing policies in this space. Now, how can we make them more efficient and more effective? Government has earmarked 19 state cancer institutes and 20 tertiary cancer care centers across, with a funding of almost 120 crore rupees for the SCIs and 45 crore rupees for tertiary cancer care centers. But today, out of 19, only 6 are 100% functional. So there are no checks and balances, there are no review systems. From the date of announcement till the time they get 100% clinically commissioned, what is that kind of time period one has to go through? I am aware that states like Madhya Pradesh, states like Rajasthan are struggling to buy equipment despite having money in their pockets. But they do not have the expertise, and they are struggling for they have come out with tenders multiple times, they have come out with different kind of models of procurement. Unfortunately, nothing has worked out. And at the end of the day, it is the patients who suffer. Let's say from the start of announcing an SCI till the time it becomes clinically commissioned, if we are losing 10 years, what's the point? Are we trying to address the disease burden this way from the government perspective? I think we need to bring in some kind of an accountability in the implementation of these policies. That is something which is the need of the hour. Coming to your point of bulk procurement, local technology, or duty reduction, I don't think all the three needs to be looked in the right mix, I would say. All the three are important. All of them are to be looked in a right mix. we are aware of the current shortages. The WHO guidelines suggest we need one linear accelerator per million in our country, per million population. We have seen in the report the current availability of linear accelerator comes down to only 0.4. While we are talking, we have about 700 plus linear accelerators and radiotherapy equipment installed in the country, and there is a shortage of about 700 units today while we are talking here. We add almost about 25 million of population, which would mean another 25 units we need every year, plus the wearing out of the older equipment is something we need to look at as well. So definitely there is, and we have also seen that 700 plus units which we have, majority of them are in the private sector. So there is a huge geographical skew, there is a huge skew in terms of availability of facilities, vis-a-vis private and government. And unfortunately, radiotherapy is one treatment which cannot be like the patient walks into the center, gets the treatment and gets away. The patient has to go 20 times, 25 times, 30 times, depending on the fractions they are required as per the disease severity of the patient. So, if the patient has to travel from one state to another to get the treatment, majority of the patients are not even able to complete their treatment. And they have to leave it in between because they are not able to afford the stay in another city. They are not able to comply with the loss of income, and so many other things. And majority of the patients, are not able to get a complete treatment. So yes, there is a huge urgency of a holistic program, where let's say we can target about 300 districts to be covered in next 5 years. And maybe by 2030 or 2033, 2032, we can look at covering all the districts of the country with the facility of linear accelerators. Today, the situation is so pathetic that there are states which do not even have a single unit of linear accelerators in the northeastern part of the countries. So there are states which do not have a linear accelerator in the government facilities, and big states like Madhya Pradesh today do not even have a single linear accelerators in their government facilities. So what I'm trying to say here is that yes, a holistic program where we can look at we can identify the districts by the disease burden. Ones which have the maximum disease burden can be covered first, and government can look at the bulk procurement, a centralized procurement, for these districts. Because I have seen the states and the implementing agencies struggle a lot when it comes to the procurement of the equipment. They are not able to decide, they are not able to they then look for, let's say, the existing facilities. They reach out to facilities, institutions like Tata Memorial, but it's more about copy-paste job. They are not able to envisage what is the kind of requirement they have, and are they looking at an equipment which is catering to their requirement. They just say, okay, fine, they have an institute which is running very well, they have this kind of a machine, let's buy it as it is, without realizing whether it will be 100% utilized in their facility or not. Coming to localization of technology, yes, this is the key word, buzzword, Make in India. And everybody feels that Make in India is a solution for everything today. But let us look at, unfortunately in the medtech sector, you mentioned that as one of the suggestions that PLI scheme can encourage Make in India. Trust me, it doesn't happen that way in the space of radiotherapy. We have had discussions with DPIIT and DOP multiple number of times where they have urged us to start manufacturing in India just because they have launched PLI scheme. It is the market maturity which decides whether anybody would like to start manufacturing in the country or not today. Today, I think around 70 odd units are physically installed in terms of linear accelerators. We as an organization this year have installed 56 units, which is highest till date, So what I'm trying to say here is this is the kind of market. And we have already an established supply chain manufacturing system, which is very well catering to the requirement, current requirement. Even if this requirement gets doubled, we have the capacity to address this requirement. But the challenge is that if the government feels that by bringing in the manufacturing locally here, the costs will come down, it will not happen from day one. Definitely not happen from day one. And let us also look at the fact that even if an organization starts looking at localization of technology, they will at best, start with one particular model of their range. They cannot bring the whole gamut of the total range they have in the country and start manufacturing. It is practically impossible. So I think a holistic program with a requirement of localization of technology can definitely address both these issues. We have seen examples. Ministry of Railways had come out with a requirement of diesel engines to be procured, and they put in a requirement of manufacturing it in India, and now GE is manufacturing them. And of course, they have kind of pushed it ahead to a different organization, but they are manufacturing it in India. Alstom is doing it for the electrical engines, I would say. Even for Tata Memorial, when they ordered the proton therapy units, they had this component in the procurement tender that 30% of the equipment has to be manufactured locally. And the organization which finally got the order is now manufacturing the ring gantries somewhere near Chandigarh, I guess. And they are exporting it out. So this is definitely feasible, that if you come out with a fixed requirement, then definitely localization of the technology is a feasible aspect. However, as I mentioned, even by bringing in localization, we can at best look at, let's say, one particular model, and the country definitely needs much more than that. So duty reduction today is a call of the hour. Today, linear accelerator attracts almost 30%, custom duties, which is very high, I would say. An equipment which cost in the range of $1.5 to $2 million, having this kind of a duty, not many players, especially in tier 2 cities, and even for that matter, tier 1 cities also, they get discouraged by these kind of duty increase and everything. So this is something which we have made several requests to the government on this aspect. And yes, we got some kind of a positive feedback from the Ministry of Finance also, but unfortunately, getting all the agencies from the government on the same platform to discuss one particular issue is also a huge challenge. So we have not been able to kind of push the government for this thing. And in terms of access, there's one thing which a lot of people talk about, public-private partnership also, and radiotherapy centers. Definitely, let's say if there is a holistic program and there is an availability of an equipment, let's say in whatever districts we are targeting, but we need people, we need trained people, trained staff to run those centers, which is definitely a huge challenge today. I think the numbers of radiation oncologists, we have got very senior panelists, but please allow me if I'm wrong. 1.3 radiation oncologists we have in the country per million population. So again, public-private partnership could be a model to deliver, services. However, there is a word of caution in this thing, because I have seen across many states in the country that when it comes to designing the public-private partnership model, governments start thinking that this is a way of making money for them. The bidding criteria are based on highest percentage of revenue sharing. Now, this is such a stumbling block that any service provider who wants to bid and he has to bid on this bidding criteria, then definitely they are starting on a wrong foot from day one itself. So I think these are few of the things which we need to kind of talk about, consider, and bring changes in, so that we can at least have the technology available to the larger part of the country. We know globally 50% of the cancer patients are being treated through radiotherapy. Unfortunately, India, this number is abysmally low, between 18 to 20%. So there is a huge journey to be covered, but we need to bring in some policy measures which can actually make it effective.
Thanks a lot, Vineet, and your point on spurring demand to attract investment and meet the supply side gaps, I think that is very pertinent. With that, I'd move to Mr. Mandeep Kumar, and again, extending the point around making more advanced technologies for treatment available. And so the question to you is that how do you see the impact of advanced surgical techniques such as robotics, the cost of cancer care, and therefore, how do you make them more accessible to a larger population base in the country?
Thanks for that question. A lot has been talked about cost today, so I won't repeat much of it. But let me also say that the whole notion of cost is a relatively less understood subject today. So firstly, I want to congratulate Eva and FICCI for doing that paper, and hopefully we'll continue to kind of enhance our pool of knowledge on costs. And I'll try and give a few examples why I say so. So firstly, when we say of cost, are we saying cost of that episodic treatment? I think that was talked about earlier. or the total cost of treatment. I'll take an example. Somebody undergoes a robotic surgery. Do you look at the cost of that surgery, or do you look at the cost of the number of blood transfusions you had to give, the length of stay that a patient had at the hospital, and whether the patient has a reoccurrence or not? I think we've still not evolved to a concept of seeing total cost. Then we talked about outcomes. We talked about outcomes of tumor boards. Dr. Harith talked about it. Raj Gore talked about, how do we track outcomes? I think that's an important thing. Are we really tracking outcomes of the interventions that we are making? I'll take another example here as well. Somebody has kidney cancer. Now, what would you treat or say as a good outcome? You take the cancerous tissue out, or you take the entire kidney out, you have treated kidney cancer. Or your defined outcome was that you will take only the affected part out, because the kidney is not going to regenerate itself, right? So you need to have the precision and the control to take only the affected part out. That really defines in terms of how are we really really measuring that outcome. I'll take another example. We talked about quality of life. What happens to the quality of life of a cancer patient? When you were showing some data on cancer in your earlier presentation, prostate cancer was mentioned, right? Now let's assume that somebody has been advised radical prostatectomy. So in simple words, the prostate has to be taken out. Now what is the outcome you're looking for? Is the outcome defined as you're wanting to take the prostate out? So you've solved for cancer. But at the same time, if you're doing that surgery using less evolved techniques, you could have two major issues. One, the patient could lose bladder function, they have urinary incontinence, right? The second, they could lose erection. So where would you measure in terms of what is the outcome that you are taking to look at it? So one thing I would say that, when we talk about cost, to me there are two most expensive kind of treatments. One, when we were talking about screening, we talked about that briefly. Doing or advocating something, or we also talked about in the virtual tumor board, that is not advocated or not required. It's like over-treating something. The second is a treatment that doesn't achieve the desired outcome. To me, that's the most expensive treatment. So if we are able to define our outcomes and use technology, and today we talk about technology being expensive, it's a question of from what perspective do we look at. I have many collaborators in this forum sitting that side on the table itself. Utilize the technology. We talked about government hospitals, right? We have teaching and referral institutions and government hospitals who are taking this benefit to more and more customers. Yesterday I was at UN Mehta Hospital where the Prime Minister pledged that cardiac care center to the nation. That's for pediatric cardiac robotic surgery. So it's a question that access and affordability is getting built up. What we need to do alongside is, we have talked about duties, so again I won't repeat that. Raj mentioned that, Vineet, you mentioned that. Yeah, 28% duty is prohibitive in a way. But also look at the positive sides. I think the work that the IRDAI did, so 2019 when this circular came, they included robotic surgery, that it can't be excluded today. Otherwise insurance companies were totally excluding it. We have worked with insurance companies. Now many insurance companies have robotics in their coverage. We partner or collaborate with hospitals to see how we can have that ease of accessibility to that technology. And ultimately we have to jointly solve for that problem. But the start point is, what are we really wanting to achieve? Are we looking at an outcome based only on that particular disease at that point in time, or the overall quality of life? I think our total notion to cost would change from that perspective. I firmly believe today we have about 100 plus robotic programs across the country, and I think each one of our collaborators who has shown faith in that, faith in our technology. And when you see, I get people come and talk at our meetings, or families of patients who come and talk and say, my husband's life is better because of this technology. That's what not you ascribe a cost to. I think that's the lens that we need to change. Yes, we need to continue to see how we work with the government to reduce duty. How do we work and partner with hospitals to see how the technology can be easily accessed and provided to more and more patients? And that's the focus that we are on. I would just leave at that last point, that let's measure cost from a total cost of outcome and a quality of life. And then these technologies with that lens are the ones which actually should be offered to anybody and everybody. So even like Safdarjung Hospital we're talking about, right? Dr. Koch was talking about. Safdarjung Hospital is offering that to patients, right? And they're doing a great job. So I think that's the lens we need to look at.
I just want to, one particular point, on access terms. you have mentioned in your recommendations like oncology department in medical colleges need to be mandatory and radiation oncology department as well. Now, I understand that Ministry of Health has already sent a recommendation on these lines to NMC, but I'll just give you a real life example of why is it important for the students to have a first-hand experience on the latest technology in a state of Chhattisgarh. When the government doctors were using cobalt technology, I'm talking about just about 3 years back, we invited them to a center where our new technology was functional and we wanted to demonstrate that. Trust me, the first response was that we are only comfortable on cobalt, and there was a huge hesitation in the doctor there. So these are real life examples why these things are important at the ground level itself, so that people come out confident enough to at least be comfortable with the technology.
Absolutely. And I think that can be also extended to robotic surgery, where we definitely need a much larger pool of trained surgical talent to be able to actually deliver it at the ground level. With that, I'll come to Mr. Venkatraman, and I think we talked a lot about the clinical needs, the supply side issues, etc. But in your view, being one of the new generation organizations, what are some of the innovative business models which you are actually seeing now coming forward, and which part of the patient journey do you see will have the maximum disruption going forward, and how will technology play a significant role on that?
Thank you, Vicky and ENY, for the opportunity. Speaking last has a couple of challenges. One, whatever you want to say has already been said by someone else in a lot more eloquent way. And second, in the midst of doyens and prominent clinicians, you're always intimidated coming from a very different industry and a very different perspective. Always what you say or attempt to say shouldn't border on blasphemy. So I take whatever I say or not say, please consider it with a pinch of salt. I'm a lawyer by training. I have done my finance and background in management with limited knowledge from any conventional oncology or oncologists, as the case might be. But what we have realized is, taking an external in view of having spent several years in Tatas and now last couple of years as a young startup, many of the innovations or solutions as what we see in other industries, if you take banking, fintech, retail, or automotives, many of these ideas may or may not come from conventional linear functionalities. Otherwise, a Volkswagen would have created a Tesla. When it comes to healthcare, we are often spooked by the level of intimidation that exists, saying, this is healthcare, it can't happen here. We are at least 15 or 20 years in terms of technology adoption, as well as in speed of execution of projects, as to why it can't happen in this particular premise, or why it needs to happen, or this can be the only way. However, thanks to support of people like Dr. Padwe, Tata Memorial Hospital and the government, at least in a couple of places, we have demonstrated the need as to why it can happen, or the methodology it can happen in a tiered hierarchy of a hub and spoke and further spoke. One, the hospital in Varanasi, where we were given a task of commissioning it in less than a couple of years. First, everyone might ask, why Varanasi? That's a question or a debate for another day. But a facility of close to 1 million square feet of hospital infrastructure in 2 locations within the city was commissioned in 11 months flat. Not 3 years, not 5 years, 11 months flat. When we were building it, many asked us the question as to why the load in Bombay will come down, you're only doing it to do X or Y or Z. Much of the planning was done remotely by experts at Tata Memorial. The execution was done locally. And in just 1 year of operations, you saw 100,000 plus patients, 7 linear accelerators, 12 operating theatres, waiting list of 8+ weeks for radiotherapy. So it gives us and shows that there is a significant demand definitely in the central, eastern and northeastern states. Second, the entire unbundling process between the 4 or 5 elements in oncology, prevention/early detection, diagnostics, delivery systems, as well as the knowledge data/insights, instead of looking at them as independent, isolated systems, there is a lot more interdependence than what we think. Dr. Richard mentioned the importance of radiology, nuclear medicine, pathology. Often, in most hospitals, the surgeons won't talk to a medonc won't talk to a radonc, and all of them, if they sit together, there is who's higher or who's lower in a clinical hierarchy. And decisions are not often taken by a tumor board with very little or minimal representation by people. Dr. Puri earlier mentioned in his talk about the need for quality. It's absolutely essential. Good or not, shank se pani aata hai, usko hi tirat bolte hai na. It's not as if only the Pope says it is sermon. And expertise in this field, we have to acknowledge it takes a generation to build, and it doesn't happen overnight. So long as we have that humility to acknowledge and not just the real numbers of X number of medical colleges set up in Y number of locations, we need to be conscious about the outcome measures as well. And in our ability to create capacity at scale, the knowledge systems in a digital first hierarchy can be a significant way forward in terms of understanding of this disease. Today there are AR, VR, 3D models of getting people to understand anatomy in a lot more different way than trying to do and look at in cadavers. And those sort of investments would have to be a participatory platform which are literally public good, which are shareable resources across public, private and charities. And the government and others also should not look at private sector as a money-making enterprise alone. Obviously, if you have to sustain, you have to generate a rate of return which is higher than your weighted average cost of capital. We can't be under the notion of communism is dead, but communists still live on. And there is an economic incentive that needs to be adequately embedded in order to live, survive, and hopefully thrive someday. At the same time, while statistics can often be misleading when we talk about in terms of per 100,000 population, we need to acknowledge in terms of absolute numbers, we are the highest in most cancers. In cases like head and neck, we are 40% of the global burden. And for some of these, we need to engage and embrace a lot more what you call public health or people who are not oncologists in the ecosystem. For example, a dentist can pick up precancerous signs of oral leukoplakia. Earlier someone mentioned the dentists or dental surgeons are not part of it. With little bit of training, many of them can become very good maxillofacial surgeons. You don't need an onco-surgeon only to perform those surgeries. In TMH, we ran a program on training general surgeons in oncology. They were good, adequate enough for solving many common forms of cancer. So what technology can do or bring is facilitate and accelerate that participatory ecosystem at a scale which is unprecedented. In fact, Intuitive Surgical, before they sold robotics, they started a training center which enabled a cadre of people getting trained in robotics. Even in aviation as a starting point, you first do 90% of it in a simulator before actually going for a check ride. So those things in oncology are very much doable, and several other industries elsewhere have thought those systems. Can we bring some elements of it into care in a system where 50% of people or 70% of people are detected late and 90% of them are effectively ending up palliative or end of life? And for that, we really need to ask ourselves, while prescribing those very advanced or complex treatments, if the outcomes are not going to be fundamentally different, are those treatments really required or not? We need to be first transparent within ourselves before getting into those modalities. So you ask on where specific trends one would need or like to focus is on getting the early detection right and hopefully the diagnostics right in the first instance, with a standard of quality where anyone going anywhere can hopefully get the same experience everywhere. And last, we also would need to realize that this is an aspirational India under an inspirational leadership. 20 years ago, someone asked in an eastern or northeastern states, please give me roads. The person said, why do you need roads? You can't even buy a bicycle. Why do you need a 4-lane highway? Today we are seeing 8-lane highways in Bundelkhand. So we need to acknowledge that even people in remotest of areas will ask for a CGP at some point of time. Will ask for an immunotherapy drug. Will ask for an affordable diagnostics. So long as we acknowledge that reality, it's great. Even in hospital rooms today, literally everyone asks for a single room with a privacy. It's So long as that acknowledgement exists, it's great. But if you try to hoop away from that, saying you're a government, you should do X, or you're private, you do Y, it will not work. It will come back to haunt us quite badly.
And Mr. Mandeep, do you want to just add on to some points which Mr. Venkatraman touched upon around skilling?
I think that's great you mentioned that, Mr. Venkatraman. Like you were mentioning about simulation techniques. We have about 800 hours of simulation techniques where a surgeon trains on a simulator before we take them through a full-fledged training program. And for training for us is also a continuum. It's not an event, right? I know we are short on time, so I won't go into the full detail of it. But firstly, I think whosoever has not had a chance to see our experience center that is down below, it's in a van between the entry gate and the exit gate. Please make a visit, because we talked about outcomes, and outcomes are related for a surgeon from a point of view of vision, control, and precision. You'll be able to see for yourself in terms of what the surgeon is doing. We'll even make you sit on a surgeon console. We'll make your time to that experience center worth the visit. So please try and do that. And the second, just to add on to the simulation, we also have something which is a My Intuitive app. We do about 1 million plus surgeries every year. On that app, a surgeon can compare data of proficiency and time spent and where what they are doing with the average of the best in the world. So I think skilling is a journey which we have to be on, and it's a continuous process. More as we talk about when we meet later over lunch or in the experience center.
Thanks a lot to everybody, to all the panelists, the esteemed panel members who've actually joined us for this session today. We're short on time, but we are very happy to hear all the insightful recommendations which came in across the pillars of awareness, prevention, detection, treatment, affordability, as well as the use of data and innovative business models and skilling going required for making the National Cancer Control Program a success in the country. Thanks a lot, everybody.
Thank you very much to all the panelists.
With Terry,
requesting everyone for a group photograph, please. Okay. So in the meantime, I would request the panelists of the next session to come near the dais, please. We have a session on Heal in India, Heal by India. And the chair, Sri Love Agarwal, Additional Secretary, Ministry of Health and Family Welfare, will be joining us virtually. We have the moderator, Ms. Neha Mordani, Deputy Editor of India Today TV. And we have two speakers, Dr. Anupam Sibbal and Dr. Devleena Chakravarti, requesting everyone to please join us on the dais.
Can someone confirm if I'm audible?
Sir, we can hear you, and we're just setting the desk. In next 2 minutes, we'll be starting, sir.
Fine, thank you.
Requesting everyone to kindly settle down on your seats, please. Ms. Neha Mordani, over to you, please.
Good afternoon, everyone. We are here to talk about the much talked about Heal in India program by the Government of India. And I'm requesting everyone to please settle down because we're really running short of time and we want to make the most of what we have, like we always do. I'm welcoming Mr. Love Agarwal, Additional Secretary, Ministry of Health, Family Welfare, Government of India, the man who's always been on a mission. You recognize him. He's actually been the most familiar face on Indian news channels and television during the peak of the pandemic. And this time around, he is here to talk to us about the Heal in India program, what it means for all of us. And Dr. Anupam Sibal is also with us, Group Medical Director, Apollo Hospitals. Thank you so much for coming. And Dr. Devleena Chakravarti, Managing Director, Artemis Hospitals. Thank you for joining us here. Without much delay, I'm going to hand it over to Mr. Love Agarwal. You can start your presentation, Mr. Agarwal, and talk about the Heal in India program, what it means for all of us, not just for the Indian medical industry, but for all of us as citizens.
Thank you, Ms. Nehaji, and thanks for kind words. Let me also welcome our colleagues, Dr. Devleena and Dr. Anupam, who are present on the dais. I'm sorry I'm traveling, so perforce I'm basically joining online. But I think the issue which is under discussion today, Heal in India or Heal by India, this is something which can actually be a game-changing event for the Indian health sector. And I would just like to run through a small presentation so that we can discuss the issues at hand and what opportunities it offers to us. So dear friends and colleagues who are present here, I would just like to start by highlighting that Honorable Prime Minister during pandemic, he had very specifically highlighted the vision for One Earth, One Health. That is, pandemic has taught us कि health को हम लोग separate नहीं कर सकते between countries, and this also, as you would kindly be agreeing to that, this is also ingrained into our ancient Indian philosophy of Vasudha Kutumbakam. So as part of that approach, two initiatives are under discussion, soon to be launched. One is Heal in India, second is Heal by India. Now, Heal in India talks about ensuring value-based healthcare, wherein patients from one country, if they do not have the required treatment facilities available in their country, or if it is costlier or there are other challenges within their country, they can come and travel to some other country and take treatment. Something which is very unique to our Indian context is that not only we are good in modern medicine, we also have integrated and holistic healthcare approach through traditional medicine. So this is something we would like to cover under the concept of Heal in India and highlight it. Second aspect is Heal by India. And this talks about health workforce mobility, wherein Indian health workforce can be actually a brand ambassador for India across the world. Just to sort of take us to the journey of Heal in India, that is the medical value travel approach. So we actually provide a very unique proposition to the whole world. Not only we have modern medical treatment for curative purposes, be it cardiac surgery, organ transplant, we also have traditional medical intervention through Ayush for therapeutic as well as wellness, and also the overall concept of wellness focused on rejuvenation, spiritual and mental well-being. To give a snapshot of what does the market indicate, if I would really urge, if you can see the diagram on the left side, you will see that overall global market size for this economy in 2020 was somewhere around approximately 3.9 lakh crore or 4 lakh crore. And it is expected to rise as high as 15 lakh crore in next 5 years. And within this, if we see that the market size in India and the forecast for 2026, we have around 50,000 5.5 lakh crore, which was the market size as in 2020, and it is expected to more than double in the next 5 years. And this is when government is actually not intervening. Dear colleagues, I would specifically like to highlight, if government and private sector in the country can combine hands, combine forces, then we should be able to achieve this target sooner than later. In terms of profile of medical tourists coming to India, we had around 5.5 lakh international patients who came from treatment from over 50 countries. And most of them actually came from 10 countries that has been indicated in the pie chart, primarily for cardiovascular diseases, diabetes and kidney treatments. But let me also submit here that these numbers do not reflect medical tourists who might be coming on with tourist visa from Nepal or some other countries on tourist visa. Similarly, This number also does not contain the figures of tourists who are coming to India for wellness and Ayush offering. So what I'm trying to highlight here, that the number indicated above is actually not reflecting the true picture, but a larger set of people across the world are coming to India already and accessing the health services here. If you see what advantages we offer to world, specifically I would like to highlight that more than 13 lakh plus allopathic doctors, more than 8 lakh plus Ayush doctors. Parallelly, we also have fluency in English in terms of communication. Similarly, we have large set of treatment from the hospitals which are accredited hospitals. So just to highlight that we have 40 Joint Commissioner International accredited hospitals and more than 1,400 plus National Accreditation Board for Hospital accredited hospitals in this country, which ensure that the standard treatment is provided to the patient from people across the world. Similarly, a very unique proposition which India offers is in terms of affordability, which means that vis-a-vis other parts of the world, we can get the same quality treatment provided at 1/3 of the approximate price. I did mention about the fact that we have also focus on integrative health. We are talking about spiritual well-being, we're talking about yoga, and we are talking about integrating modern medicine with Ayush so as to provide integrated healthcare across the world. And equally important to submit to you is that this is one country vis-a-vis other parts of the world where if you actually get sick, you might have to wait for 6 months, 1 year, 2 years for getting a treatment. And in the meantime, the patient continues suffering. So while there might be time required for treatment in India, but this can be done at a much fast track level with reduced 7 trillion market across the world. This is a market which can be tapped by India. If we see where do we stand in this in the world, we are already 10th in medical tourism index worldwide. We are 12th in wellness tourism market worldwide. And if we see the Asia Pacific region, we are already 5th in the wellness market. But the target here is how do we sort of work towards ensuring that we actually are able to provide higher services and capture a bigger segment of the market. Just to see that, it is not only few parts of the country, but across the country, we have had centers now, we are having centers where large set of treatment can be availed by people from across the world, be it from Kerala, Telangana, or southern part of the country to Chandigarh and Jaipur across another part of the country. And you would just see that for multiple set of tertiary care treatments, similarly for Ayush treatment, there are centers which have developed across the world. And again, to submit in terms of the facts and figures where lies our major competing strength is we have indicated here that if we were to take heart valve replacement, heart bypass treatment, hip replacement, knee replacement, or spinal fusion, just a sample of the treatment which can be made available in India. And if we compare their cost for getting the same quality treatment in US, Thailand, Singapore, Malaysia, or India, I'm happy to submit to you that medical treatment in India is 65 to 90% cheaper than what is happening across the world today, across that in USA. And so that is where lies our competitive advantage, which we collectively need to take advantage of. Dear friends, to ensure that we can take this momentum forward, we had certain actions already initiated, and we also are working towards creating a single window approach for the global patient through a MVT India portal. This is a portal which is already developed and major portions are further being upgraded. This is a portal which provides global citizen in multilingual approaches to locate a particular doctor, to locate a particular procedure, or to locate a medical value travel facilitator, so that based on which they can sort of identify a doctor and not only provide information, but it also provides end-to-end patient journey management. We also have a mobile application along with a web-based application. And we have also integrated WhatsApp in this to ensure that there is efficient communication between patient facilitators and doctors. This portal will also ensure that you have transparent online packaging pricing for all system of medicine. So it will ensure transparency within the medical value travel sector also. This portal very specifically also focuses on allowing from government to government collaboration. And if a government from one country would like to align with a particular hospital, either Artemis or Apollo, for that matter Medanta, then they can align with that particular hospital, and only those hospital, as per the MOU between the government or the hospital, those doctors will be made available. Similarly, one hospital from one country can align with hospital in our countries, and a patient can also directly access the medical facility. So, dear colleagues, what I'm trying to highlight that this portal will actually ensure transparency gets inbuilt into system. Grievance redressal mechanism is put in place so that if a patient has come to India and if he has some grievance at any point of time, then am I?
Yes, you are audible. Yes,
Yeah.
we can see you again. Yes.
Okay, sorry. So, is my screen visible, please?
Yes, your screen is no. I mean, we can see you, but we can't see your presentation, Mr. Agarwal.
Just a second. So this is the challenge of being online at times when you start using technology. Is it visible now?
Yes, it is. Thank you.
Okay, thank you. So just to highlight that this will be actually a game-changing event, and this is just a snapshot of the portal where any patient across the world can actually identify and locate a particular hospital, locate a particular doctor, identify a particular treatment and a facilitator. And the advantage of this portal is that the patient journey from the time when a visa invitation letter has been sent to him to the fact that what ticket he has booked to arrive to India, who has received him at the airport, to the fact whether he's in OPD or IPD, the whole patient journey can be monitored. Transparency in terms of pricing can be ensured. And I'm also happy to submit to you that already we have started interacting with our hospital chains across the world from both modern as well as the Ayush sector, and already 164 hospitals have onboarded from 16 states and covering 45 cities onto this portal. 3,500 plus doctors have registered and 2,182 treatments have been made available. Dear colleague, one side, while we are focusing on ensuring transparency and global find to this particular portal, we are also coordinating the Ministry of Civil Aviation, Ministry of External Affairs, Home Affairs, Tourism and state government to focus on the destination building, focus on hygiene factor, also focusing on ensuring that how do we come up with the concept of where medical visa can be further eased. And so this is the overall comprehensive approach within which we are trying to sort of promote medical tourism in this country. This is just the snapshot of the mobile app where you can actually select a doctor, upload and share reports to the doctor, and including do telemedicine with the doctor. So dear colleagues, focus here is that how do we position India as a global leader for medical and wellness tourism in the next 5 years across the world? How do we not only highlight that we are affordable, providing quality services, but we're also the destination of choice for the world? We are known as the pharmacy of the world. We should also be known as the medical hub of the world. Similarly, how do we also position India's traditional medicine as a unique offering in a mission mode? And most important component I would like to submit is certain things which are ingrained into Indian philosophy, that is focus on seva as well as Atithi Devo Bhava concept, working into this and saying that for India, medical sector is not a commercial activity alone, but it is ingrained within seva and Atithi Devo Bhava concept. So the person can come to India and with folded hands, we welcome him in India and treat him and send him back. Dear colleagues, another component, Heal by India, is also mentioned. This is another initiative we plan to take. And this is where we want to basically facilitate Indian health professionals to provide their services globally, and they should become an international brand. Just to highlight what is the need we will try to fulfill. I did mention that Honorable Prime Minister has talked about One Earth, One Health. And if you see that there is supposed to be a global shortage of 1.5 crore health professionals by 2030, and around 0.8 crore global shortage of nurses alone by 2030. And this is a snapshot that whether it is America's region, European region, MENA region, or Western Pacific region, that a sharp shortage is being observed, and this is where India can actually fulfill the need. We did talk about that Indian health workforce is actually a strong workforce, not only in terms of 35 lakh nurses and ANMs, 13 lakh allied and health professionals, 8 lakh Ayush doctors, 13 lakh plus allopathic doctors, dentists and pharmacists. This is the workforce which presently is serving India, and we can also serve the world at large also. I would just like to also highlight here also that if you go to any part of the world today, you will find yoga centers. Similarly, Also, if we see the focus on traditional medicine, the world at large is realizing that how traditional medicine can be a supportive therapeutic intervention in terms of health service delivery presently. And here, what I have highlighted and submitted here is that there are around 124 countries in the world which have a legal framework for herbal medicine. And similarly, 170 countries in the world which acknowledge the usage of traditional complementary medicine, and as high as 16 countries in the world which have even recognized Ayurveda system of medicine. So this is again an opportunity not only for the medical professionals from the modern medicine, but also from traditional medicine to basically serve the world at large. Why we think that we can also add value to the world is the efforts taken by government across the spectrum of healthcare service delivery in the last 2 decades. If you see 95-fold increase in availability of nursing seats, similarly pharma 22-fold, dental 3-fold, Ayush and medical 1.8-fold. So these increase of seats facilitate that we will have manpower to manage services within country, and in any case, we can also provide services to the world at large. And if you were to see in terms of data, then in the OECD region, doctors we are from India, which are going and working there, we are first there in terms of India as being providing our doctors, as well as second in terms of provision of nurses. And not only US, Canada, UK, and Australia, across the world, you find Indian professionals are already serving the community at large. Where also what we are trying to do under the Heal by India concept is to bring all the stakeholders together, whether it is concerned ministries, whether it is health professionals in this country, our councils or commissions, and recruiting agent and foreign employers. So this also is going to be supported by digital intervention, wherein through a Heal by India portal, all the respective stakeholders will be integrated, and a foreign employer can look for a person who has shown his interest to go and work in a particular field in a particular country, and recruiting agencies also will be onboarded so as to ensure that there is a transparency in terms of providing support to that doctor. So for example, if I want to go to Japan, I may need services in terms of what exams to give for that my degree can be actually, or I can do work there itself, or do I need some language training, do I need some cultural aspect related training. So the whole process will be coordinated and supported through this particular portal. So through this portal, what we are trying to ensure is that there is no lack of information. This again becomes a single window approach for going across the world and providing services. We would help in terms of creating unified registry for health professionals, and we would also ensure that there's a simple registration process where all stakeholders can be integrated. Just to give a snapshot, where you will have recruiters directory, the employers directory, and parallelly, you can search as an employer across the world if you are looking for a particular set of a professional who has shown his interest to go and work in their country. Similarly, there will be multiple dashboards made available to all the stakeholders, which will tell where that person is there. And this also will also parallelly ensure that any person who has gone abroad, if there is a grievance when he is going and serving abroad, that grievance also can be coordinated and monitored through this particular platform. In terms of road ahead, a lot of homework is already being done, duly involving our private sector associations. Also, FICCI is also integrally involved with us in this process, along with CI and other professional bodies, and as well as our medical fraternity. We want to create an enabling framework where we serve not only our country but world at large. The focus here is that how do we position India as a hub for medical services across the world, and I'm sure this would be one of India's offering as India's soft power to aid world to come either heal in India or heal by India. Thank you very much.
Thank you so much, Mr. Love Agarwal. That was very informative, and also what really stands out is what he said about the fact that wellness is incomplete, health rather is incomplete, medical care is incomplete without wellness. And India has the special advantage of offering end-to-end patient care that involves so many things than just offering medical services to the patient or to the family members of the patient who come along with the patient to India. Thank you so much, Mr. Agarwal, for that presentation. I'm now going to ask Dr. Devleena Chakravarti for her comments, her perspective on what she thinks of Heal in India, Heal by India, and what the private sector essentially can do to ensure that what always has been India's sunshine industry, which is the medical tourism industry, shines even further.
Thank you, Sneha. Thank you for this opportunity here today. And I'm extremely excited to be here. Honorable Chairperson, delegates on the podium, colleagues, my dear friends, ladies and gentlemen. Today I asked for 5 minutes of time from FICCI to speak this morning when I looked at the program, because simply I was too excited to be back in person after a long, long hiatus. And I know we are running out of time, and I'm going to keep it as brief as possible. 2 years we stood away, suffering COVID, and what a time it was. Each one of us went through much emotional, physical, and mental stress. And while the COVID pandemic, the outbreak was visible all over the world, and various countries were grappling with their own issues, they were looking at India. And they said, Inka kya hoga? Such a huge population, gaps in healthcare infrastructure, poverty, lack of affordability. Inka kya hoga when COVID hits India? And today, post-COVID, we stand tall. And I must admit, when the outbreak happened, each one of us was nervous. We did not know what this virus was all about. But in my hospital, in a briefing with my team of doctors, one thing I said to my doctors at that point was, we have an opportunity. It's a blessing. All throughout our lives, it's our soldiers and our military force which saves and protects this country. Today, as doctors, we have an opportunity to show our might. And I'm sure this conversation would have happened in each and every hospital, primary healthcare center, and wherever there was a healthcare professional. Because what we saw was people folding their sleeves and going out to save lives. What we did was phenomenal. In no time, we were able to can this virus. The world looked at us in awe. They could not believe it. They tried to poke holes in our system, in our protocols. But at the end of the day, they had to emulate us. We had homegrown vaccines. We had homegrown drugs. Great protocols, which we devised overnight because we did not know what this virus was all about. And a country which everybody wondered what we were going to do at the end of COVID, we became an example for the world. We were backed by great policy decision. We were backed by bureaucrats who helped us. But at the forefront, it was the healthcare professional who took this challenge up. So what I'm trying to say is, it is the grit and the ability of the medical professionals of India, which put us on the map, then on the medical value travel, and today as great solutions to any problem in the health sector. Nobody can deny us our place under the sun today, and that is what I'm trying to say. MVT started in India, and I was one of the very initial people involved with MVT, more out of default than by design. It was a group of private hospitals trying to draw traction for their own business. And soon the world started realizing what is it that we have to offer. And it was unbelievable. It was not just cost of treatment. Of course, cost of treatment is very, very important because we are talking about universal healthcare, affordable healthcare. But what we must highlight is our outcomes. They have been truly, truly remarkable and backed by service excellence, which I don't think can happen anywhere in the world. The MVT, the program, which was at $6 billion, maybe in 2005, 2006, is now pegged at $13 billion by 2026. It's becoming an industry by itself. And how? Because we have all the ingredients to do it. We have a product which the world cannot deny. Today, Prime Minister's vision of Heal by India and Heal in India is garnering further traction to what we have to deliver to the world. Undoubtedly, today, the MVT sector is backed by Ministry of Health, Ministry of Commerce, Tourism, the MEA. So now we are actually, posturing and we are actually taking the required shape to tell the world what we have to offer to them. Let Heal by India become the tagline, like Heal in India. Let Heal by India be used in every mission that India has in every country, Heal in India and Heal by India. Because like our Honorable Chairperson mentioned, Mr. Agarwal said, not only can we treat in our country, we have the capacity to go out and treat patients where they need us most. And that is the best way. When you go to their country and you treat their patients, that's the best way of creating the trust. We at the Artemis level or other private hospital level, we are already doing this. But when this becomes a national movement, you will see the impact coming much better and faster. And there is nothing better than becoming a soft power in health. When we started, a few years back, it was UAE, it was Africa, from where typically patients would come. But today the list is unending. And people, even from Canada, from Denmark, and European countries, a lot of Southeast Asian countries are now coming to India for cure. So we have the product ready. Today, when India wants to become and is in the path of becoming an economic power, let us give the impetus which is required to Heal in India program, the MVT program, and truly the country is going to be unstoppable. Thank you.
Thank you so much for that, Dr. Chakravarti. You spoke about trust and you talked about the much needed impetus, and I'm now going to hand it over to Dr. Sibyl to talk about what he thinks this impetus, essentially this push, should be, and what can the private sector do.
Hi, thanks. Good afternoon. I'd like to thank the amazing health team at FICCI for bringing us all together. You do awesome work. Thank you so much. Could I have the slides, please, because I wanted to show some images. Could I have a slide forwarder, please? Forwarder, please.
Anshu, if you could just take a look at that.
Excuse me, ma'am. What is the website which Shri Love Agarwal has said? MVT. Can you please tell me what is the website? MVT portal. What is the website?
We'll just get back to you on that.
Fine, thank you.
I can't see the slides. There's no laptop. So it's a double handicap. Next, kaise karu? I can't see the slides, na? So either I'll have to go there and do that. If there's a problem, I'll just move there and stand. Yahan se kar leta hu. Okay, chalo. Can move it for me. Okay. Apologize for that. I guess we have to innovate and do it this way. So basically, the idea really is to share some thoughts on Heal in India and Heal by India. We launched satellites for 35 countries. Next, please. We have the ability to launch more than 100 satellites in a single mission. Next, please. We also have the ability to bring down a satellite should the need arise. Next, please. I don't know how many of us saw the film Gravity. It costs $100 million to make. Next, please. But our Mars orbiter mission, the first mission in the world to be successful in its maiden attempt, cost $75 million. we understand frugal innovation. Why am I talking about space technology in a health conference? Because there's just so many similarities between Heal in India or medical value travel or medical tourism and space technology. It's about cooperation between countries. And how does a country choose a partner country? Next, please. They look at, next, please. They look at quality, they look at service, and they look at competitive cost. And I think in all three counts, India scores heavily both in space technology and in healthcare. Next, please. We have world-class processes that have been developed over the last 3 decades. Next, please. We have technology that is available anywhere in the world. This is just an image of the proton center, and there are only a handful of proton therapy centers in the world. Next, please. If you just look at the sheer volumes, joint replacements, 220,000 plus, open heart surgeries, 205,000, robotic surgeries, 10,000 and growing, solid organ transplants, 10,000 and growing. And these are very large volumes. Next, please. India performs 8% of the world's kidney transplants. In fact, we at Apollo perform 1% of the world's kidney transplants. 5% of the world's liver transplants are performed in India. Next, please. Let me share with you some images of individuals whose lives have been transformed or saved. This young girl lives 300 kilometers near Karachi and has an atlantoaxial rotatory defect, and every time she would move, it would hurt. So she was bedridden, and this is her after her corrective surgery. Next, please. We recently transferred a patient from the United States, which would be the longest air transfer, 23 hours. Next, please. This child at 3.75 kilos was the youngest child to have a successful liver transplant. The same girl 4 years later. Next, please. Abriana and Adriana came from Tanzania, conjoined twins, and you can see that after their separation. Next, please. This little one came from Philippines. Just look at how malnourished she is and look at her a year later and 4 years later. Next, please. This little one was so small that after a liver transplant, her belly couldn't be closed. But this is her a couple of weeks later. Next, please. 500 patients from just Pakistan who received transplants. Next, please. We got a call from a family in Bangladesh. We sent in an aircraft, tracked the aircraft coming back into Indian airspace. Next, please. Transplanted that patient. Next, please. 2 days later, this is him 7 days later, and then at discharge. Next, please. I just shared with you images because this is really high-end work that only a handful of hospitals can perform across the globe. Accreditation was alluded to by Lavji, and we have the boss of NABH here. We have 40 JCI accredited hospitals and growing. Next, please. A growing number of NABH accredited hospitals. Next, please. But more important than just accreditation is what patients want, the referring doctors want, are outcomes. Next, please. So we now have systems to measure outcomes, and I'm just giving you an example of what we follow at Apollo, which is just one example, which is Apollo Clinical Excellence at 25. Next, please. Benchmarking practices against the world's best published outcomes. Next, please. Tracking them every month in a score that goes to the board. Next, please. Of course, Lavji alluded to this. We excel in terms of service excellence because for us, next, please. Atiti Devo Bhavan. Next, please. We understand cultural sensitivities. After all, we have 1.4 billion people who believe in 9 religions. Next, please. We have just 22 official languages, but 1,369 recognized dialects. So we understand the importance of language. Next, please. You move from north to the south, to east to the west, the food preferences are different. So we understand the importance of food. Next, please. And of course, our cost is 1/10 for many procedures when you compare to the United States. So we make for a very compelling destination as far as HEAL in India goes. Next, please. Turning to HEAL by India. 2014, we produced 52,000 MBBS doctors. That's up to 91,000. And in the next 2 years, it's going to become 100,000 a year. So that is more doctors by far than any other country in the world produced every year. Next, please. In terms of post-graduation, we've gone up from 32,000 to 45,000 plus, which is going to become 60,000 in the next couple of years. Next, please. And if we look at the shortage that the WHO projects of 12.9 million healthcare workers globally, India, because of the demographic dividend that we enjoy, can push out 1 million healthcare workers every year out there into the workforce. Therefore, there's an opportunity for young Indians to heal the aging global population. Next, please. We are the world's third largest pharmaceutical manufacturer. 60% of all vaccines in the world are made in India, 40% of all the generics in the US, and 25% of all medicines in the UK. From making no PPEs, we became the second biggest manufacturer of PPEs. So clearly there is much that we can do in terms of supplying medication, vaccination, consumables, and hopefully technology in the years to come. Next, please. And just look at the cutting edge work that we do. I'm just giving you an example of COVID. There on PubMed Central, there are 417,000 plus papers on COVID. India contributed 14% to all COVID publications. And if you just look at some of the centers that I've highlighted, pretty substantive contribution from individual centers that collaborated across the public and the private sector. Next, please. India's embraced technology more than anyone else. Arogya Setu became the most downloaded app in the world in the first 2 weeks. Next, please. You go in on COVID and you will get 2.19 billion vaccine results available to you in about 20 seconds. Next, please. If we look at how digital health, and digital health is very relevant when it comes to how India positions itself. eSanjeevani itself has seen 6.4 crore consults. The COVID risk screen that we developed at Apollo had 16 million downloads. And while we've done 13 million telemedicines in 20 years, in just the COVID time, we've done 3 million. So eICUs, teleradiology, digital pathology, AI, ML are now becoming mainstream in India. Next, please. I just want you to pause 1 minute and think of what the size of the Indian IT industry was in 1991. $0.5 million. Today it's $227 billion. Can you imagine the world functioning without the 5 million IT professionals that run software for the world? The same can happen in healthcare. We have an opportunity. Next, please. It took the world, COVID, to realize what we've always believed in. Vasudev Kutumbakam, the world is one family. And we don't just believe in it. Next, please. We actually demonstrated it by sending out 242 million vaccines to 101 countries. Next, please. Lavji talked about the Indian diaspora. There are 1.5 million physicians of Indian origin across the world. And for our last conference, the Honorable Prime Minister for the Global Association of Physicians of Indian Origin conference sent out a message, and I quote, "Our worldview is anchored in our ethos of Sarve Bhavantu Sukhina, Sarve Santu Niramaya. May everyone be at peace and may no one suffer from illness." And I think with that ethos, next, please, we are well positioned through Heal in India and Heal by India to become Vishwa Gurus in healthcare. Next, please. Thank you very much.
Thank you so much. And amen to that, Dr. Sibyl. I'm going to ask you a question because, like I keep saying, we're really running short of time as much as we can accommodate. I want to ask you, Dr. Sibyl, as far as Apollo Hospital and private medical care in India is concerned, I want to know how have you recovered really after the pandemic? And what is it that the government of India can do in terms of ensuring things are smooth, not just for the patients, but also for the medical industry by and large? What are your expectations from the program Heal in India, Heal by India as well in that sense?
So I'm going to just confine my comments to Heal in India and Heal by India, and I'm not going to get into the larger debate of what health the sector needs, what is it that we want in terms of reforms and so on and so forth, because, that'll take 10 minutes. Basically, I think what we are seeing with Heal in India is pretty remarkable. We've not seen this kind of traction, this kind of push ever before. And I think in the last 6 months, clearly the Ministry of Health and Family Welfare, the Ministry of External Affairs, Ministry of Home, Ministry of Commerce have come together to really position India as a destination for medical value travel. And I think what Lavji shared in terms of the portal, the accreditation, in terms of the facilitators, what our Indian missions are doing, the road shows that are planned, the portal, the Prime Minister is going to launch this campaign himself. I think there's much that's been done, and I just hope that this trajectory continues. In terms of Heal in India, Clearly, we've seen a lot of traction, Heal by India, we're seeing a lot of traction in human resource development and there is a proposal now. In fact, we run a public-private partnership in a medical college that we run in Chittoor. The hospital is actually the district general hospital and we have the medical college. So there are examples of more and more of that happening in terms of collaboration, which can really help us get to that 100,000 and then 60,000 postgraduates and hopefully a ratio of 1:1 for PGs and MBBS. I think in nursing we can train a lot more, but we really need certain changes through legislation in terms of nurse practitioners, nurse managers, so that there is a clear career path, which at this point in time does not exist for nursing and for technicians, because then we'll see more and more people get into healthcare and then we can export human resources just like we do other services. In terms of your first question, which was how has the industry recovered, I think the recovery has been pretty good in the last few months. Not only are we serving our own patients, but we also beginning to see plane loads, I can't say truckloads, but plane loads of patients coming from different destinations. And I think hopefully with us taking over the presidency of G20, we will see greater traction in this space. Thank you so much.
Dr. Chakravarti, what are the challenges that the sector essentially is facing now?
So while I said that, there is a lot of awareness and people, the government, various ministries are backing us, there's no doubt about it. But there are certain challenges and which are some of the low-hanging fruits which the government can immediately look into and correct. And so what has happened is 2.5 years of COVID with no flights, no medical tourists. Our patients and our customers, our clients, whatever you may want to call them, have slightly forgotten us. Yeah. So they have found other destinations, and once you get used to something, you continue doing it. So we have to first understand, is our traffic, the international traffic post-COVID, the same, lower or higher? And if it is lower, then what are the reasons and from which countries are these lower? That is the first correction and the first kind of brainstorming which people have to do now. So there are a couple of reasons for it. One is, of course, people getting used to other countries, but having said that, they are paying a higher price for the same treatment and the outcomes are not as good. So it's a question of time when they are going to come back. The second, our airlines and airspace is still not completely open to multiple countries, and the frequency is still not there what it was there during the pre-COVID times. So that is something which needs to be immediately corrected. Third, the visa. Now every mission, Indian mission in any country, they should feel that it is their task to support the government and the Prime Minister's view on HEAL in India. They must ensure quick visas, medical visas should happen now at a phenomenal speed, much better than what it was happening in the pre-COVID times. So we have to immediately look at our short-term problems and the short-term challenges. I know the government wants to do more. We are conferring with it. The problems have to be immediately highlighted and corrected. This is a short-term request I have from the government. And in the mid and the long term, a lot of things like make HEAL in India and HEAL by India the tagline in every mission. Make sure when a patient walks into our mission for a medical visa, we do faster than any of the other countries which are now emerging as a hub for medical tourism. And road shows and portals, which the government is already doing, that has to be more kind of active, more user-friendly, more usable. I don't know how many people are actually using it while we are creating these projects. So there are multiple things we can look at, but as a short term, let's only focus as one thing. Are the numbers the same which were there during the pre-COVID time? If not, identify the causes and identify the countries, and let's work together to get the numbers back and even more than what we had during the pre-COVID times. Thank you.
All right, thank you so much. Mr. Love Agarwal?
May I speak, please?
I'll just take in a comment from Mr. Love Agarwal, then I'll open
Fine,
the
thank
floor
you.
to the audience. Yeah.
Okay.
Mr. Love Agarwal, please.
Thank you, Snehaji. Good that I could stay and hear the presentation by Mr. Anupam also, and I think it was very clear and very strongly it was conveying. So let me start by highlighting $74 million to send a satellite versus $100 million just to make a movie. This is the cost effectiveness which India has. Second aspect is, we started with a very small journey for IT revolution, and today we have around $220 billion worth of IT exports from this country. So this conveys the potential which we have. And parallelly, I just would like to sort of touch upon the issue which Ms. Devlanaji has mentioned. So, Ms. Devlanaji, as I mentioned, so let me just highlight whether it is working with airlines to improve connectivity, whether it is working with MEA to ensure effective communication across the world, highlighting our strength, parallelly also ensuring visa regime which become much more friendly. These are already processes which are happening. I could not explain them in greater detail because of paucity of time, but not only that, road shows, working with insurance companies. So a multi stakeholder engagement is already in process. Honorable Prime Minister, Honorable Minister has been very categorical that we really make an impact and we work together. I would just highlight the point which Devlinaji has mentioned, that we have to work together. I think today the most important need of the hour is that we need to work together. How do we work together and create this partnership between our hospitals and government? This is what we should be focusing on. Second aspect we should be focusing on is that this opportunity is huge. So we should be working in a mission mode. The point she has alluded to, that if you do not take up this opportunity, there would be other competing countries which should be taking up this opportunity. Third aspect I would like to highlight, I was addressing all the honorable tourism ministers from every state of the country in Dharamshala recently. And I realized that just sheer focus on medical tourism alone under HEAL in India would be a market of around 50,000 crore rupees for this country. And if you see the world data, it is just to highlight that $100 billion is the approximate market for medical tourism. And $30 billion is the market just of sheer Gulf countries alone. And these are the countries which fund their citizens for treatment abroad. That is where government to government interaction working together will actually be a game-changing event. So we all need to work together in a mission mode, and we all need to sort of see that we create this partnership, position India in terms of Honorable Prime Minister's overall vision of One Health, Vasudha Kutumbakam. Thank you very much.
All right. I'm going to ask the audience to ask some questions if they have, and please introduce yourself and also be clear about whom the question is addressed to.
Madam Devla.
Yes.
You were saying that customers were coming from abroad. So when the customers are coming, you must be knowing their addresses, phone numbers, etc. So my only question is, you want government to do. Who am I? I am a Paras Rastogi dealing in medical devices in India, near Delhi. Okay, so I must know that you must have, your staff must have correlated them, contacted them through email, phone number, and if there are PROs, public relation officers who travel in India, maybe you must be having some international people, so they must be going in touch with them and getting the feedback as to what is the reason behind as to why the patient is not coming from abroad to India.
So
this is,
I think like there is a interpretation issue here. It's not that patients are not coming to India.
Okay.
It is pre-COVID, if we had X number of patients.
Understood.
Today, after 2 years of stopping all medical value travel because of the no connectivity and all, we should try and see how do we do better than what we were doing before, right? Because patients abhi ikkathe ho gaye hain wahan par, 2 saal se aaye nahi hai, so we have to see how do we get it more. So what I'm trying to say, there are 3 causes. First is some of the connectivities are still not air connectivity. या कुछ बने नहीं है, या number of flights, the frequencies have not happened. जो 4 times in a week आते थे वो अब once a week आते हैं. जैसे Delhi Mauritius flight still not started by Air Mauritius, right? Pehle we used to get 3 flights in a week and Mumbai used to get every week. This is just to give you an example now. So we are making petition to the Aviation Ministry, all these flights and their frequencies, not just flights, their frequencies should be resumed.
Only
That
one
is
point.
one.
Yes.
That is one.
Understood.
Second point is, say, give you an example of a place like Iraq. Maximum patients used to come to us from Iraq. So then when our second wave came, so we had stopped the air flights from Iraq. So people started going to Turkey, they started going to Amman. So क्या होता है कि उसमें एक habit बन जाता है. They are going to that place, their relative has gone, the next guy going will go to the same place because he's getting a direct reference. Yeah, they're used to it, they're happy unless the outcomes fall, which is falling, and it is a question of time when it will happen. Third, what I'm trying to say is that because there has been such a big backlog of visas, because when flights had stopped, there was a backlog of visas from these countries, from where they were coming. Those systems and processes should become faster. These are the three helps I have asked, which is institutional help that I'm requiring. Calling patients, calling their relatives, sending our people, sending our doctors, doing the camps, all that has started. And that's why we are seeing the kind of revival which we can do at a hospital level. All that has started and much more for all hospitals, not just us. So that's why we are seeing revival. But some of these help items, which is institutional, which a country has to support us, will help us take the numbers to the next level.
Okay, thank you.
Gentleman right in the front.
Yeah,
Please introduce yourself,
yeah,
sir.
Panigrahi from Fortis. To Mr. Agrawal, I think so the MVT.
I have to tell all of you that Mr. Love Agarwal has just left the conversation. He had to go. So the questions have to be either to Dr. Chakravarti or Dr. Sibal.
Yes, my next question is 5G.
One second, sir. Opportunity.
No, it is for him actually.
Sorry?
It was for him.
It was for him. He's just informed that he's had to leave.
I'll tell you.
Yeah.
So the message is that, see, his plan is to quadruple the growth, the medical value. As it is, our hospitals are now running around 70% occupancy. So they are nearing peak capacity very shortly. So to go from this 1 to 4 that was mentioned here, we need to enhance the capacity across the country. So for that, help there's a one window system. Similarly, those who have to enhance the capacity have to have new blocks, new equipments. So some support has to be there. Like you have the PLI, which has come in for the industry. Something like that has to come in. And to Devalina's point, I think so. Indian doctors give the best outcomes. The US study has shown it. The US patients who have been treated by Indian doctors, their mortality morbidity rates have been much lower. So if we, as a proactive measure, we capture the outcomes of all the treatments that happen, that will be a nice way to present it.
Agree with you, sir.
Primarily the ones which are restricted to like Delhi, Mumbai, Chennai, the metros. The idea is also to engage in the two-tier cities and develop capacities there. So you're right. In terms of our capacity, we need to look at enhancing the capacity. And also the idea is that let us also introduce new centers to the foreign patients, that you could consider Lucknow, you could consider Ahmedabad, they go there. But primarily right now it's like Chennai, Kolkata, Delhi. So, but point well taken. I'll take it up with Mr. Agrawal.
All right, any more questions? Yes.
Actually, the question was for Mr. Love Agarwal,
Yes.
but since he's left, maybe the seniors can answer it. My name is Tenzin.
Let's put that to Dr. Sibal.
Yeah, Dr. Sibal. My name is Tenzin. I am from health tech entrepreneur. So when we talk of the MVT portal, so I think, and I could be wrong, I think one challenge is since we don't have any clinical outcome data being captured at a center level. So once we have a portal which is supposed to, let's say, prioritize or rank the let's say centers without data, then it would actually be more of a randomized system. So now that I think, if you look at, let's say, a Google or a Zomato or any other, site, so there is a algorithm which is driven by data. So since here there is, and I could be wrong, so you could correct me, since there is no data available and I don't see a roadmap, at least publicly available. So how would we rank the system?
Yeah, great point. I don't think there is a ranking system that has been shared with us. Maybe there's some thinking on how they want to do that. But you're absolutely right. In fact, there are hardly any hospitals that make public their outcomes. And NABH does not expect outcomes to be made public. In fact, no accreditation system in the world expects outcomes to be made public. So great point. I'm sure the team's thinking about how to actually present this.
So just to add, sir, actually, if you look at, let's say, US system, some of the websites there, ZocDoc or, likewise, so there we have seen that, the data at a hospital level or a doctor level is actually, on outcome basis. I mean, though it's not apple to apple comparison, but I was thinking, maybe in the roadmap, if a similar exercise is planned, it could become more
No, Tenzing, great point, but I don't think we're going to be able to get that. We'll take 3 years to do that. And by that time, Turkey would have killed us.
No, actually, ranking is something which is very ambiguous because sometimes you do not know what you are really looking at. The portal is basically to highlight the hospitals which are accredited by the government and various accredited body which are credible and whom you can approach if you want to come for medical value travel. Now, if you have identified the hospital, say you identify my hospital, Artemis, you go on to my website and then you go into a chat bot asking for more details of the doctor, his outcomes and so on and so forth. And I think for a very long time, these outcomes will be shared because we have credentialing for our doctors based on their outcomes, right? So you have to get into the subspace of the hospital and ask for that data rather than on a government portal. Government portal is just guiding you which way to go. Yeah.
All right, I'm going to now thank the audience and also thank Dr. Sibal and Dr. Chakravarti for joining us and sharing with us your perspective on this very important conversation that we're having today. Thank you.
Thank you, Sneha. To all our delegates, please join us for lunch. And then we'll have session after lunch at the second floor conference room. For a lot of us who don't know Dr. Deblina Chakravarti, it's a homecoming for you because she was my first chair of the Medical Devices Committee. Thank you so much, ma'am. We look forward to seeing you now more often here.
So this is known as the iron triangle. In the world of healthcare quality, the cost quality access conundrum has been hotly debated. And I do not overstate or indulge in hyperbole when I say that this is the important topic which is worldwide of prime importance for every healthcare economics, for every person involved with healthcare. But before I indulge into the nitty gritty, the nuances of these things, please allow me to share certain data. Next, please. Definition of quality has not changed for the past 20-25 years. Good quality means providing patients with appropriate services in technologically competent manner with good communication, shared decision making with cultural sensitivity and with greatest of efficiency. Well, here or there, a word here, word there, tweak here or there, but by and large, this definition has stood the test of time. Next, please. What is new is the emerging concept of patient safety. In India, it's a relatively newer concept. if I can be very, very optimistic, I can say that this is only about as old as NABH, because in 2005, the first hospital, Indraprasth Apollo, got itself the JCI, coveted JCI accreditation, and same got bad press, and Government of India requested QCI to institute a board, and thus was formed the NABH. And then the concept of patient safety has started to evolve over the past 18 odd years, and patient safety is a healthcare discipline that has emerged with the evolving complexity in the healthcare systems and the resulting rise of unintended patient harm. So to prevent and reduce risk, errors and harm, the entire framework of whatever the ecosystem has evolved. Next please. So this is a very stark where are we currently. India ranks 112 on the health effectiveness out of 191 countries. We are low on accessibility, affordability, acceptability, adequacy towards universal health coverage. There are currently 1.5 beds per 1,000 population versus 3.5 WHO requirement. There is poor accessibility in tier 3, 4, 5 cities. We are doing very well on the doctors, as was mentioned in the last session also, but the norm is 1 per 1,000 population. We'll soon achieve that. A lack of doctors every year will be churned out. We are less in nursing officers. There's poor compliance on regulation and quality. In the Human Development Index, we score low. But the positive silver lining is that we are now speaking about it, we are talking about it, and post-pandemic, we are catalyzed, and the entire healthcare is now very high on the political agenda. Next, please. This is the health sector in numbers. The private sector beds are about 11,80,000 beds. Government beds score a lower 60%, 7,13,986 from the published figures. Private sector has 60% of inpatient and 85% of the tertiary care multi-speciality beds are catered for by the private sector. Hospitals with more than 100 beds are only about 3,000, out of which 986 are NABH accredited, miles to go. Hospitals having 30 to 100 beds, largely unregulated sector, are numbering about 25,000. This is a vague official figure from India.gov, but still the hospitals less than 30 beds, the mom and pop nursing homes are about 40,000. So total, we aspire to touch about 1 lakh here or there, but that figure also is an anomaly. Next, please. The average medical expenses, I'll not go into it. They change from rural versus urban geographies, and the difference in where you stay can jack up the cost by up to 300% or more. That is also, and as is very, very obvious, the urban cost per hospitalization is significantly higher, we can see. Next, please. Out of pocket expenditure, we score amongst all the contemporary SAARC countries one of the highest. There's 65% out of pocket expenditure. Next, please. These are the key challenges for the healthcare industry. There are lots of negative perception, lots of trust deficit, if we can speak it, lack of focus on promotive and preventive care. The non-communicable disease burden is rising, medico-legal cases are taking shape, lots of antipathy against the medical professionals. There is a shortage, there is a issue of financial sustenance post-pandemic especially. Many of the small and smaller hospitals have gone out of business. There's lots of technology around, which is a positive, but which can be a little negative also, because there's a cost involved to that. And of course, the main issue which we come now to, the quality and patient safety, is also in cost. Next, please. Well, that was the gloomy picture, but to look at the rosy, the silver lining, India is getting serious about healthcare. We are a young population, and this young population is more aware, and going forward needs to invest more in healthcare also. Next, please. expenditure on health and well-being, well, it's incremental, small, incremental. Every budget allocation is increasing. It's still below 2%, but government has promised us that over the next few years, by 2025, we hope to see a significant jump in our budgetary outgoes. Next, please. So this is the allocation for the current year. We've seen that the COVID, the knock which we took because of the COVID has significantly come down from 39,000. It has come down to 5,000 CR. But still, for all the planned budget, the health and family welfare, the health research, there have been some incremental budgetary allocations, increased positive change, but not as much as a developed country, which we all aspire to be, a 5 trillion economy, a developed nation by 2047. So all those are the key figures. Next, please. Another silver lining is that political leadership has taken note and give us, for the first time, a clear roadmap for digital thing. We have realized that amongst the far and wide and diverse country, we only leveraging technology can bridge this huge divide. And that divide is in the form of, can be filled only because of ABDM, the Ayushman Bharat Digital Mission. We have been given a very clear framework of FIRE, the fast healthcare interoperability resources based framework, HL7 and all. For the first time, we are speaking about the 4 basic tenets, the ABA number, the Ayushman Bharat health account is a boon. I think it's a wonderful step. The health facility registry, health professional registry, the interoperability. So all of us are discussing, speaking about this thing, and this is going to change everything, the way we practice, and that is not too far, not 10 years hence, it may be as early as in 6 months or 18 months or 2 years. Next, please. And somewhere along the thing, we are very fortunate to have, this is my promotion bit, that NABH standards also took shape for the past 17, 18 years. And many countries in the world still do not have any standards. So they rely on us or third party. And fortunately, we have a very structured system, extremely structured system of 10 chapter approach. First 5 are patient centric, the next 5 are facility centric or management centric, and we do it at 1/10 of the cost of our nearest contemporaries like JCI or ACHS. Next, please. So this is a snapshot. While JCI, which started in 2005, touches about 42 odd hospitals, we touch about 15,800 hospitals at a very rough estimate and counting. So that is, I believe, a big achievement for our founding fathers, lots of whom are in attendance today. Next, please. So we are also investing a lot in digital analytics, the predictive analysis, the preventive analysis, and that is the golden future which will help every policy maker with solid data-based decision making. Next, please. So we all know the total concept of total quality management, how to delight. So all the brickwork is in place. Now we only have to take action. Next, please. And again, now to come back to the basic thing, the cost, quality, access conundrum, because each of these, for these we have the experts now. I'll not, without much ado, but I'll leave you with 2 quotes for all the panelists. Next, please. This is the fundamental challenge which we'll attempt to answer, sirs and madams, in the next 30 odd minutes which we have, that how to reduce cost and provide quality service. They're the golden adage actually. Next, please. We can only choose 2 out of these 3. What is good and cheap will not be fast. What is fast and good will not be cheap, and what is cheap and fast will not be good. That is the understood axiom. But if we are to get all 3 on a platter, what does that golden mean? So please guide us on that. And also in the end, I'll request each of you to answer how confidently you subscribe to the next please. The bitterness of poor quality is remembered long after the sweetness of price has faded from memory. So that is the golden thing attributed to Benjamin Franklin and then Aldo Gucci. But your comments on that. Next, please. So now let's move from one or the other expert, and starting with Dr. Y.P. Bhatia, sir. You are a founder of, one of the founders of NABH. You are an astute administrator. You run big hospitals like Sri Venkateshwara Hospital. You run a health care consultancy which develops hospitals and have developed hospitals by the name of Astron also. So what is your take on the entire thing, sir? How would you like to open this thing and address the issues of transparency of cost? You realize what it takes to run a multi-speciality big hospital. So very candidly, where does the top dollar go? How difficult it is to implement quality? And how do you find that fine balance between morality, transparency and costing?
Thank you, Dr. Kochar, and good afternoon, ladies and gentlemen. This is a question, which has been right from the time we started talking about quality. I think this question has always remained. This is the one from where the cost of quality, the cost at which the quality. In fact, it is a very dilemmatic situation. Everyone, when they go to buy something, they want to get something, they ask for quality. Even a simple thing like a chappal, if they want to buy, or the vegetable market, they say, achhi quality ki dena. And when they say ki, haan, achhi quality ki, it's a little expensive, they say, don't mind. But the moment it comes to healthcare, that dilemmatic situation changes. We require quality, but at the same time, the cost question comes up, how it can be met, how it would be met. We were just discussing over the lunch about what changes CGHS is trying to bring into the payment system of the hospitals, and ultimately you are expecting that the best of quality would be delivered at the cost which doesn't even sustain the organization. We all know that what are the definitions of quality that we have been talking about. We are ultimately talking of a healthcare that is safe, timely, equitable, effective, efficient, patient-centered. Now, all this has been talked, and all this is something, which we are already struggling with. Lot of consciousness is being created about accreditation, NABH accredited hospitals and other accreditations that we are talking about. Lot of regulation is being brought in. That without NABL you cannot have a CGHS recognition. There are all these factors being brought in. A public awareness about the quality is getting created through some of these platforms, though very loosely, but it is getting created. But at the same time, have we ever able to educate the public or the regulatory authorities or anyone about the cost of quality? One subject which I feel is very badly missing in our country is the health economics. Have anyone tried to do a proper economy of services, pricing to be ultimately adjusted to that? Even in the private hospitals, what we are doing, when we fix up our schedule of charges, in 4 hospital ke charges nikal lo, schedule of charges nikal lo. If others are charging 500 rupees, let me charge 400 rupees because I have to beat him in the competition. But have I ever calculated that for providing that service, how much is actually it is costing to the organization? And within the organizational system, have we ever worked upon that let me price my services, okay, my, the margins that we are talking of, from the financial jugglery, you are talking EBITDA or whatever you are talking of. If you are talking about 20%, I have to make 20% on each particular procedure. At the end of the day, that 80% costing, from where it is coming and what exactly does it amount to? I don't think many institutions are working on that pattern. And when it comes to our public health authorities, I don't think that estimates ever been put together. Today we get a note that 40% discount on MRP on the implants. These kind of margins may not be existing in the overall market scenario. Has someone done a study on that? That if you are asking for that kind of price, then how it's going to work out? So ultimately, the social fabric and its linkage to the requirement of quality is something where there is a total dilemma. Now, what we need to do, of course, somewhere down the line, there has to be a comprehensive system where a cost of quality has to be worked out. We have been shirking away from that responsibility. We haven't really worked on that. I mean, there have been some attempts at level of FICCI and other, CII and others to bring out those costing mechanisms in some way or the other. But we haven't. Yes.
The solution is the hospitals can be classified into ABC options, ABC, depending on the number of hospitals
Please
and
introduce.
facilities.
Just a minute. We'll take questions. We'll open questions at the end. Please. Thank you.
I request that let me complete this thing, because the flow in which you are speaking, it disrupts your thought process, and anyway, I don't now remember where I was. But I think we were talking about that. There have been some attempts at various chambers of commerce to loosely put it together, and but the outcomes are still missing, and those reports which should actually constitute the basis of what we are talking of, now that has to be taken care. Now, question is, what should we do? Because these constraints are going to remain. These are the competitive scenarios in which we are working in the market, and constraints are bound to come. And at the same time, the expectations of the quality are going to remain, and in fact going to remain going up and up and up. With the advancement in technology, what we are bringing into the country. You are talking about robotic surgeries today, and we are talking about the high-end technologies being brought into every sphere of medicine, which costs. But the moment you go with this high-end technology, the insurance company says, no, we are not covering it. While hospital is investing into that, the physicians are investing in their skill set on that, and overall expectation rate is going up on that. So at the end of the day, there has to be a scientific costing of what we are doing, while putting it together, few exercises, because in this scenario, we have to do something. We just can't sit that this is going to happen and this is happening and this is how we are going to work on. There are few things which every organization can start working on to meet those challenges, and ultimately work out costs which are effective in delivering quality at the expected cost or expected price balance which is required to be there in the market. We have to come up with what we call value-based care models. Outcome-related, value-based models. These are the care models which will have to be worked out over a period of time. And that's probably one of the first things which we need to look at. For each particular, we have to do an ABC analysis, and after doing ABC analysis, what are the most commonly being done procedures in the organization, how the value-based model can be brought out to that. Because ultimately the A items are the ones which are going to be the maximum utilized, and they may be contributed maximum to your revenue also, but one has to look into that. Second component on which I have been speaking on a lot of international platforms has been elimination of waste. We do a lot of audits in our organizations, the financial audits and other audits. I don't know how many of our organizations are doing waste audit. And some of the studies have shown that as high as 38% of the hospital revenue is being wasted in some form or the other. Whether it is paper or water or food or the human resource or whatever you talk about, there is a complete set of things which you can do, but at the same time, as high as 38% of revenues have gone waste in many of the organizations, and this number varies from most of the studies that we saw in audits, 18% to 38%. So just imagine that most of the hospitals, when they work at 15, 20, 25, 22%, if 18% is going as a waste, where it's your the quality component, how it can be compensated by the waste component and helping it out in the organization. The social determinants of health, that analyzing the life context of the healthcare cost. That's another concept on which we need to work, because finally where we are coming to is the overall cost model, not the cost of a particular procedure, but the overall cost model. Now, increased dependence on the continuous therapies, projecting the effect of aging, chronically ill populations, how we can work on, a subject which again is the executive health checkups in the organizations are basically limited to a very high-end effective program. But preventology as a discipline hasn't come up in the country. I was working at Washington Cancer Institute. The medical oncologist there, when he was working at that time, the preventive oncology, the Department of Preventology by itself. In fact, every day at lunchtime, 12:30 to 1, his clinic used to become a studio. So he'll shut down all the doors, open an almirah, which is, turns into all the mics and gadgetry and everything, and the radio station is on. And during lunchtime, the topics on preventology are being spread across this thing. So preventology by discipline itself, ultimately we need to find a way that catch early, and treat at a cost which is acceptable cost, and that's, a balance which will have to be created. And of course, I again comes to economics, the behavioral economics as well as the health economics. These are the two things which have to be brought into our system, because unless we bring out that if I have to give this it costs. The ad hocism that we have in preparation of the schedule of charges, whether at institutional level, whether at the regulatory level, whether at the insurance company level, everything, it makes a difference. You are talking of rates being fixed up by GIPSA. They say you are a new hospital, so you'll get the lower rates. Now, a new hospital, if it's providing technology and services equivalent to one of the most advanced hospitals in the city, just where is the fault of it being a new hospital? The cost of services still remain the same. Maybe 10% lower because there some other costs may be there, but you can't be definitely 40% less than other the players in the market. And it's only after 3 years you'll get a 10% increase. By that time the inflation factor is probably 30 to 40%. So that's where, if all the stakeholders, they come together, look at the economic proportion at which it has been done, and then ultimately the pricing. I think this cost quality quadrant that we keep on discussing, and this has been discussing for last more than 2 decades that I have been associated with the quality movement in the country. And every time we talk about it, every time we say the cost of quality, every time we say the increasing cost because of quality, every time we say that we are not able to achieve a balance, every time the customer says that they are being looted or they are being charged too much in the name of quality and still getting poor quality. So at the end of the bottom, we really don't know, or no one knows actually, no one has been made clear about it, that this is what it costs. And this is where you have to be, if you have to be working on a standardized cost, whether we are talking NABH or NABL or JCI or no accreditation. Accreditation is only a certification of what you have done and you are being recognized for that, irrespective of what accreditation or certification you carry or don't carry. This is what it costs. And that economic model, along with few factors which I put together, I think is the way forward on which we should work together. Thank you.
Thank you, sir. I think this is really pithy words of wisdom. You mentioned scientific costing, value-based care, outcome-based care, eliminate waste, increase efficiency. But to come, and you are a very strong proponent of health economics. But let's come now to the health economist who is amidst one of our key panelists, Dr. Shankar Prinja, sir. You are in the hot seat, right? You are representing National Health Authority. You are a professor of at the prestigious PGI Chandigarh. You are well versed with health economics, cost-effective analysis, equity analysis, and healthcare financing too. You are also currently responsible for health policy, quality assurance. You are the executive director and also the person responsible for framing, designing, and implementing the health benefit package 2.034, whatever the industry wishes. So, there are lots of, you are in the hot seat, sir. So please, and some people may, really turn on their mic and really pounce on you. The CGHS circular recently, and we were discussing it casually during lunchtime also, they said government is arm twisting. So I'll be very candid. How fair how fair is reducing prices through regulation? That is one. And what steps under your leadership, dynamic leadership, you are going to take, and how will you ensure that to incentivize our partners? Very well. Over to you, sir. Very candidly.
Sure. Thank you so much. And I think before the session, we were having a light discussion with Mr. Puri, and he said that we definitely need more dialogue, more interaction to understand what exactly is going on. So in that light, I think it's a good start in that sense. I'll touch upon a few things that at the National Authority we're trying to do, and which are very pertinent to the discussion that was going on, and a lot of points that Dr. Bhatia has also very rightly raised. I'll begin with the health benefit package and pricing, etc. So we have actually moved quite a long way since the time that the health benefit package was first conceived under the PMJY, when the scheme was launched by the Honorable Prime Minister. And at that time, as is being rightly said, the extent of availability of evidence on cost was very scarce, especially on cost of different services, etc. But we've moved actually quite a long way since then, and we have tried developing a very strong database of healthcare costs, which has now resulted into development of a national health system cost database as well, which is based fundamentally on a costing that has been carried out in hospitals, which are numbering close to about 100, representing both the public and the private sector hospitals, ranging different types of hospitals, tertiary care, secondary care as well. And also in terms of the distribution of the bed size of these hospitals, so smaller hospitals, medium-sized hospitals, and the larger hospitals also. And based on that, in April this year, we announced the new health benefit package, where we have increased the prices of 800 plus packages under the PMJY. It takes a bit of a time for the effect of that change in the health benefit package to actually reach the ground, because the states are the ones who implement it, and sometimes there is a bit of a lag period since the time you actually announce the package till the time the patients start to get benefit of the program. Another important thing that we introduced in the new health benefit package is a concept of differential pricing, something very similar to what our colleague just initially started to mention actually. So now we do recognize the fact that cost of care is extremely heterogeneous. You know, you talk about so the ones who are data scientists here in the audience, and statisticians or people who are involved in data handling, you would realize that in majority of the data that you analyze, you have some kind of a normal distribution. But cost is one data which defies all normal distributions. It's a skewed data. And you have a very huge heterogeneity in the data that exists for cost. And especially in healthcare, this heterogeneity in cost of care emanates from two reasons. One is the health system's characteristic, or in other words, the hospital's characteristic. And the second is the patient characteristics. So the cost of care, delivering care, depends on whether the hospital is located in a tier 1 city, tier 2 city, or a tier 3 city. Whether it is delivering tertiary care or whether it is delivering secondary care. Whether it is a hospital that is of more than 500 bed capacity, or between 200 to 500, or less than 50 bed hospital, let's say. And then obviously at what capacity utilization are you operating at. All these factors influence cost. And what we have made a departure to the original costing or pricing that we have made in this health benefit package is that we've introduced the differential pricing, where prices are, it's not a uniform price across for all cities of the country, for all states in the country. It used to be a single price. Now it's a differential price, and the price is differentiated based on the location of the hospital. So if you're in a tier 1, 2, or 3 cities, there is a difference in the price. And whether you are delivering a tertiary care service or a secondary care service, again there is a difference in price, and it can go up to as high as at least 50% higher if you are delivering a tertiary care in a metro city, in a tier 1 city, as compared to the same service if you are delivering in a tier 3 city. So there is a significant gradation as well. And in order to arrive at these factors, there has been a proper data science that has gone behind it, where analysis has been undertaken to identify that how does the cost vary across these changes in the characteristics of the hospital. We obviously did not keep any kind of price weights for, let's say, the level of capacity at which you are operating, because we do not necessarily want to incentivize hospitals to operate at low bed capacity utilization. So you want to incentivize efficiency rather than inefficiency. But these are factors that have already been adjusted for in the cost analysis that has been undertaken to derive this differential pricing. There is also, so the first factor that I mentioned is that leads to variation in cost is the health system characteristic or the hospital characteristics, which has been adjusted right now in the differential pricing that we have introduced. The second factor that I also mentioned is that the patient profile may also vary very significantly. So you may have a patient who has a single diagnosis, so just a patient with a coronary artery disease who is to be treated, versus another patient who has a coexisting complicated diabetes also, or who has a coexisting complicated renal disease also. The cost would vary whether you have 1, 2 or 3 comorbid conditions and likewise. We have started a pilot in 5 states, which is to change or transform the pricing system or provider payment system to what is called as a DRG based payment system, wherein the payment to the hospital is that a given hospital receives for a given case being treated is not just an average for that particular disease condition, but is cognizant of the fact that there are 1, 2 or 3 comorbidities, or there is 1 or second complication that has arisen in that particular case. And in order to do that, we have already introduced the ICD-11 classification into our transaction management system. The hospitals are providing ICD diagnosis to the 4 primary diagnoses, and unlimited secondary diagnosis can be entered into the TMS. And the pilot that is ongoing in the 5 states that I mentioned is basically a system of cost surveillance that we have tried to set up. So whatever data that we had even now also was an aggregate cost that was available at the hospital and a specialty level. For such kind of pricing reforms, you need actually data at the patient level, because you want to differentiate between patients who come with different levels of comorbidity or complication, how much more or less you need to pay for a patient who is more complicated than a minor one. So this data, as we move forward, will allow us to refine our pricing in a much bigger way, which will allow the pricing to be sensitive to the patient's condition as well. And here you understand now the hospitals are not disincentivized, or they are not incentivized to cut corners if there is a complicated case. They'll get the required remuneration as per the amount of resources that they're spending, given the fact that a case is more complicated than the rest. But an important thing to recognize here, and I'm saying this because this is an audience which represents a large sector of even private hospitals as well, is that for such pricing reforms to be successful, we need willingness to share the data as well on cost, which should come from both the public and the private sector hospitals also. And here the private sector hospitals are at a much better place, because in majority of the public sector hospitals, you do not have such good patient level MIS systems that enable us to do such good cost data collection. But majority of the private hospitals have very good MIS system, electronic health records, and they also have very good billing system that allow us to capture that kind of information. But definitely there is a need to have or inculcate a greater willingness to participate in such kind of cost surveillance activity as well. The third point that I wanted to mention is that for all these things that we move forward with, there is a significant bit of consultation that we engage in. It's not something that we are doing within the 4 walls of NHA. Like the pilot for the DRG or for the differential pricing that we introduced, we had a consultation paper that we rolled out. And I see several of colleagues in the audience who had provided us with very good feedback as part of those consultations that we organized. And these consultations were organized with the public sector, with the private sector, with representatives from FICCI, IMA, CII, AHPI. Everybody had participated and they provided very rich feedback. And based on that, we then articulated the policy document. So it took about nearly 5 months for us to move from a consultation paper to a policy and then make all these changes. The third point that I was mentioning was around value-based incentives. So we definitely recognize that we need to move from a volume-based to a value-based care model. We actually, again, we had a consultation paper on this particular subject itself that we had rolled out around 3 months back or 4 months back. And then we had a series of consultations, following which during the last Arogya Manthan, we released our policy document on value-based incentives. Now this is again a move towards incentivizing better outpatient outcomes among the patients who are being treated in hospitals empaneled under PMJY. So what we are proposing as part of this is that the hospitals will be assessed for the performance of the care that is being delivered. Traditionally, we have an incentive system under the PMJY where hospitals are given incentives for accreditations that they have. So if you are an NABH full accredited hospital, you get a 15% markup over the price that is set. If you're an entry level accreditation, you have a 10%, and if you're a bronze certification, then you have a 5% incentive. What we are saying is that the incentive should be not just dependent on an accreditation, which once done remains for 3 years, and it is largely based on inputs and infrastructure and the processes that have been set at one point of time, but should also be based on patient reported outcomes, both in terms of user satisfaction and in terms of improvement in the clinical quality of life of the patient. And in order to do that, we have tried to identify what would be the indicators to measure this hospital performance. Now this is a very tricky job because there can be as many people as we have in this room. We can have as many voices about the indicators that we can have. And we obviously, as part of the consultation also, we got a lot of feedback that this indicator should also be included and that should also be included. Our clear philosophy was the choice of indicators should be determined based on 3 factors. A, they should be congruent with the philosophy of universal health coverage. B, they should be easy to collect. It should not impose another added obligation on the providers to provide that data, and it should not become a data collection exercise in itself. It should become a part of a routine process in itself. And 3, it should not be something that is possible to be gamed. So for example, we know that hospital reinfection rate is a very good indicator of quality, but which hospital will report that there's a hospital acquired infection that happened? So as a result, such indicators of quality, which are established indicators of quality, were not included as measurement metrics for incentive calculation. So we have finalized a set of 5 indicators that we have started a pilot with in 5 states again to measure those, to set up our IT systems in order to collect that kind of data in a routine manner, and then based on that come up with a clear policy on how do we finally arrive at the incentive amount, what kind of weightages do we apply, do we have some exclusions for certain services because they do not fit into that kind of measurement metrics, etc. And then based on that again have a consultation to see that with that change in model of incentive structure, how does it affect the revenue model of the hospital, how does it affect the claim payout of the SHAs or the payers for that matter, and how does it affect the overall efficiency of the health system. So that's the third point that I wanted to mention. This is something again, a pilot that has already started. In about a year's time, we definitely hope that we should be able to make, in about 6 months time actually, we should be able to have the final structure revised, etc. The fourth and the final point that I wanted to mention was that we are also, because this is a fundamental thing that we want to incentivize good quality care. We want to incentivize products, healthcare technologies that offer better outcomes and price them accordingly as well. So what we have done also alongside as well is that we have set up processes of health technology assessment, wherein we have also set up a portal on our website to invite submissions from any stakeholder, public, private, hospital, patient group, SHA, non-government entity, where they can submit us topics that, okay, we have a new healthcare technology, we have a new drug, we have a new treatment, this should be included into the health benefit package. These new, we are using the word technologies quote unquote, this means intervention, drug, device, anything. Now these would be subjected to a very thorough process of assessments which would include assessing the cost effectiveness of those newer treatments or interventions, looking at its impact on how much it can potentially reduce the out-of-pocket expenditure, how does it distributionally benefit the poor, that means does it have an equity impact on the utilization of the poor, and what's the kind of budget impact it will likely have. And based on these 4 criteria, we will make a policy on or make a decision about the inclusion of that particular package. The use of this evidence for policy making is not just limited to decisions on whether we include or exclude interventions. It is also to make standard treatment guidelines. So very recently, for example, we saw that, you have, because sir mentioned about something around oncology treatment. We know oncology is hugely heterogeneous. The care in oncology is hugely heterogeneous. And so we have a patient of breast cancer may present in different stages, lymph node status, metastasis status, etc. Radiation oncology treatment is available, but it is cost effective if you give it among those who have node positive disease. If you have a woman who is a node negative disease, it offers you no additional health benefits at all and comes at an added cost. So we are trying to refine even our standard treatment guidelines, that where is it this is a particular treatment indicated, and it should then be made available for use in those indications only where it is cost effective. So that's again an area that we have very consciously tried to build capacity within the NHA, as well as build very transparent systems that are institutionalized and are not individual driven, so that they last for a much more longer period of time, and also trying to build partnerships across different range of stakeholders who can enable that kind of an ecosystem to function. I'll stop at this point. Thank you very much.
So I think, thank you so much, sir, for this very clear vision of the ringside, of what goes on inside. And frankly, I think NABH is very fortunate to work in tandem with NHA, to be part of every consultative process. We are part of your value-based team also. And we've seen at close range how elaborately you go to involve every stakeholder for their opinion, comments, and then arrive at a drafting stage. And I think I have no hesitation in saying that ABPMJ is pride of the nation, and thus slowly and every day, day by day, it's improving the way we handle, look at and relook at healthcare. So thank you so much for that very, very candid, elaborate, comprehensive opinion. I'll come back to you with a question, but coming to the lady, the first lady of our panel, Dr. Upasana Madam, you are a key healthcare industry leader. You run a chain of hospitals by the name of Yashoda Group of Hospitals. You, as a family-based model also, despite you have learned to adapt, invest in every quality certification which is there. And she takes personal pains to get green certification to improve efficiency. And you are the first ISQA fellow from the country also. So that's a very strong statement for somebody who invests lots of time in quality and supports quality and accreditation. And so first challenge, as Dr. Puri is very fond of saying, is that whenever you talk quality to a hospital, the first resistance comes from doctors and clinicians. And male doctors double than the female doctors. That's what he says. So what is, how could you convince your team, how could you set up that team to deliver despite all challenges of resistance and cost, everything? So cost, you are fast, you are not costly, and yet you provide full quality. So how do you find that golden mean?
Thank you, Dr. Atul. And today I am feeling really lucky that I am sitting with Dr. Narottam Puri, Dr. Bhatia, because they are the one who has started NABH, and NABH is my passion. So when we started our journey in 2009, so it was actually quite tough to make everybody ready to do lots of paperwork. But after when they realized that after all these things which they are supposed to follow, they are actually getting some benefit. Because what NABH is doing? NABH is doing quality care of patient and patient safety. So every doctor needs to get their patient, safe, as well as their length of stay is very less. There are less HAI. So when they were feeling like it's a very good thing that our patients are safe, and now there is, because of NABH, HIC is a main thing which we are supposed to follow. So through HIC, we are all the time, doing surveillance in our hospital, and last beneficiary was patients. But patient is the brand ambassador of a hospital, and luckily today conference when I was in ASSOCHAM, that time also I met few people who are talking about my hospital very nice, and gentleman who is sitting in front, he was also talking very nice about my hospital. So how we are getting all this thing, because everybody feels that this is a big paperwork, but not only paperwork. You are tracking things, as our previous speaker was talking about data. When you are working on data, then you are realizing that it is really very important for a hospital, for a doctor, and especially for a CEO level person, that he can see everything just in one go. So, to promote quality, it is always required that you have to show some good cases in front of your doctors, in front of your staff, as well as your patients also. You need to tell those stories which you are able to, treat successfully within a time limit, within a, quality comes with cost, I really believe. But, in long term, you will find that if you are working in a quality atmosphere, your cost is actually you are recovering, because you are not wasting your money for SSI, like patient is coming back with lots of infection, and then you are supposed to treat that patient, or there is a fall in the room, and now that patient is talking bad about your hospital. So when you are following all these quality norms and patient safety, then you will get definitely benefits. And those benefits you are supposed to, share with your colleagues. Like we are all the time, every month we are raising a paper, and we are telling to our doctors that this is the infection rate in hospital, and this is different ICUs and everywhere. So they know that our hospital is doing great job, and if we need to put some efforts, so they are also agree and they are ready, because our average length of stay is very less. So that is how hospital is also getting benefit from that, because one patient who is coming to the hospital, he is basically maximum test has been done within 1 or 2 days. So after, if there is a long patient stay, you are not getting anything. Just patient is, after 4 or 5 days, he started complaining for many things. So it is better that you should work with the quality, and you will get the results. But same time, how to, manage doctors. Doctors are now quite happy, and but it's still one thing I should say, they are not ready to write time and date. So now you have to, excuse us for that. But otherwise, they are following care plan and all. And it because NABH has given us one thing very important, that if there is any medical legal cases and your case summary is properly written, so you are always safe. And this thing now doctors are also understanding that these days this kind of things are actually happening in the society. So they have to be careful. So I think I am very lucky that I am surrounded by good people. So that is how our journey is like that. And I hope that within few years, NABH is going to take our whole industry, because everybody who is not having any accreditation, they are also looking for some kind of even certification, so they can, do also quality care. Thank you.
No, fantastic, madam. I think this is what a true leader can do, turn around an organization and lead by example. And I think we should invite you to be our brand ambassador, frankly speaking. We are also joined online by Mr. Rizwan Koita. Mr. Rizwan, are you there?
Dr. Atul, can you see me and hear me clearly?
Yeah, good afternoon, Rizwan. It's a pleasure to have you with us. Rizwan, you are a serial entrepreneur. You first formed, you are a IIT Mumbai product. You went to MIT, you joined McKinsey. You worked with you formed the first BPO which was acquired, first positive serial exit, business exit. It was acquired by Mahindra Group, Aditya Birla Group, sorry. Then you co-founded the CTS Tech, which is the first unicorn in the digital healthcare space. You are today leading a company. You were till last year the CEO of the group and the majority shareholder of CTS Tech, which is providing and empowering hospitals across Europe and US, enabling them for digital health. Now you are on the philanthropy route. You are working with NHA. You have founded the Koita Foundation for Digital Health with IIT Mumbai, IIT Delhi, with Tata Memorial Hospital. You are working with the Cancer Grid. So practically you have, and you are a NABH board member also guiding us, and we are very thankful for that. So overall, with your bird's eye perspective of healthcare quality and the digital revolution which is in shape currently, where do you see us? What will it entail? What costs will it entail? And will the entire investment pay off by itself, or what does it take? I mean, your very candid view on the entire thing.
Sure. Yeah, so thank you very much, Dr. Atul. Pleasure joining the session. I wish I was there in person, but I'm able to join only online. I'm hoping that you can hear me very clearly. So I'll go back to a comment that you mentioned about, you can either buy something which is good, cheap, or fast. And the good news is that technology has the lever to be able to achieve all three dimensions, which under normal conditions you have to pick between the two. But we've seen in many areas of technology, whether it's in India or other parts of the world, where even core platforms like UPI, Aadhaar, and others have been able to improve both on the cost, cheap, and fast dimensions simultaneously, and have been able to achieve fairly strong order of magnitude improvement in many of these dimensions. Based on the experience that we've had in healthcare worldwide, we feel that similar opportunities exist. In fact, we believe that similar opportunities exist in the world of healthcare as well. And if you look at how healthcare has evolved globally, especially in the last 15-20 years, we can see a marked induction of technology in the business of healthcare, which has been quite profound. Specifically, if you look at the cost dimension, and I'm using the word dimension here because there are many ways of looking at the return that you get on technology. If you look at cost, across industries, digital adoption has had anywhere between a 5 to 10% improvement in costs. It doesn't matter. You look at the travel industry, you look at the entertainment industry, you look at manufacturing, you look at others. By improving the adoption of technology, there have been very significant cost reductions. And even if you look at the conversation that we are having this afternoon, it is very clear that in many areas of healthcare, there is opportunity to reduce waste. There is opportunity to impact the way we are forecasting many of our needs to be able to improve cost. Even in areas where traditionally hospitals take a more conservative view, like for example, I'll take two specific ones and I will expand on it for the purposes of today's meeting. One is on patient registration. You have a paper-based system. It is very quick. You have somebody fill it up in the computer. It often takes time. But the reality is that the impact of doing patient registration right has not only, while in a very narrow sense, it may take, a few more minutes to do patient registration. Getting it right and getting it in a digitized form has a huge downstream impact and on efficiency, and the fact that you don't need to capture this information on an ongoing basis at different departments. You don't need to be tracking this information at the point of submitting a claim or what have you. So it's important to look at cost of deploying technology, not only at the point where you're deploying it, but look at it at an overall systemic level and the improvements that you get. India is going to go down the Ayushman Bharat digital mission platform route, and one of the core ingredients to be able to do that well is the use of electronic medical records by doctors. And Dr. Upasana made a point where even to get doctors to do a few different things right is difficult. Deploying an electronic medical record can be quite challenging for hospitals. And often the extra time that it is taking a doctor or the staff to be able to key in patient information can be seen as an added cost. What we've seen globally is that while if you take a very narrow view of the cost of time to put patient information in, it may seem like you're increasing your cost. but the overall impact of capturing that patient information electronically in the system has huge benefits, right from improving patient satisfaction, resulting in much larger repeat business, to being able to see trending in what is happening at an overall level, what type of patients are coming in, whether they are being treated adequately, what is the performance levels, as well as on specific patient conditions. You can create a patient alert, you can be doing many things. So if you look at the overall systemic impact on the patient as well as on the facility by use of electronic medical records, there is enough sort of healthcare economics data, which was we spoke about that earlier as well, which show that it improves efficiencies quite significantly. I think the most important benefit of using digital technology in healthcare, in my mind, and what I've seen, is not only the cost reduction, but the increase in revenue opportunity that it creates for hospitals, right? And examples of these would be, one, you get a much more repeat business, because if I'm a patient of a hospital and I truly believe that the hospital is doing a good job of capturing my information, I'm far more likely to come back to the hospital than to go anywhere else, because in a sense, the data that is residing of mine in the hospital creates a certain level of stickiness for me, and that is a big value add. The second value add is the ability for hospitals to provide add-on services which otherwise may get missed. So if I go to a hospital and my patient information denotes that I am diabetic, the hospital is more likely to propose a diabetes plan or some other benefit to me, which will allow me to not only give more revenues to the hospital, but actually benefit in the long run. So there are revenue opportunities that get created as a consequence of having my information with the hospital in a digital format. And finally, even when you look at areas like reimbursement, for example, there is enough and more data to show that capturing data electronically improves reimbursement rates, improves the ability to be able to track costs in a more granular manner, and be able to improve the overall sort of value that is getting created by use of digital tools. So overall, if I can summarize, a huge impact on the business by using digital tools, patient satisfaction, repeat business, revenue growth, far more important, but you're also going to start to see cost optimization. Now, the caution that I would like to bring is that healthcare is complicated, and therefore many times there is a time lag between making the investments and truly starting to see the positive impact on the bottom line. And my assessment is that for hospitals, it could be from a 9 to 18 to 24-month cycle between putting in the effort required upfront and the cost required and the investment required upfront to starting to see the benefits. It's really important that the leadership team in a hospital take a much more long-term view of the return and not expect short-term gains. The second thing I'll mention is that it's really important that as you start to deploy new technology tools, you have a very clear indicator of the key performance indicators that you're tracking. If revenue is a key performance indicator, or a certain type of revenue is a key indicator, or a cost is an indicator, then making sure that as you're deploying new technologies, those metrics are improving in the direction that you wanted to improve, and having that close monitoring becomes important. And then the final point I will make before I pass it on to you, that any change in technology, the biggest impediment of that is the human factor. That will the team in a hospital, right from the doctor to the nurse to the administrator, use the technology in a consistent manner that it was designed for? Because there is nothing worse than having incomplete data. If the hospital is going to use information or the digital tools in an on and off way, a very little value is going to get added to the institution. And the only way that happens is if some of these initiatives are driven from the top. So the leadership of the organization needs to be very closely involved, needs to demonstrate their commitment to the long-term success. And if we are able to do that, then we have seen over 20 years across literally hundreds of organizations that there is a huge positive return on investment and a huge value to patients, to doctors by using technology, and not just in cost reduction, but more so from a growth in revenue perspective. Yeah. So with that, I'm going to pass it back to you, Dr. Atul.
Thank you. Option of revenue in the medium term also can be strong stimulus to adopt. That's music to ears, and that's a very strong case going by your global experience. We are told that CEO NHA may join us shortly, but before he joins us, we'll come to the prettiest lady also. Dr. Lalu Joseph, Madam, you are the Secretary General of CAHO. You are a passionate master trainer. You have devised about 30 plus courses, and you have led the CAHO movement, which is now a true movement and a revolution. You have done studies to find the impact and cost of accreditation. So we'll need your experience with cost and quality. Quickly, we may have to put a hard stop, but till sir comes, and we need closing comments also. So what is your impression on that, and what exactly are your findings from the cost, accreditation, quality, impact study?
Thank you very much, Dr. Atul and FICCI, for giving me this opportunity. So before I start with the study part of it, please interrupt me anytime, Dr. Atul. Yeah. So before I start with the study part of it, I just want to know how many of you are representing organizations that are less than 100 beds? Not one? That's exactly the scenario. So we are talking about 3,000 hospitals that are probably over 100 beds. So this group of elite hospitals are the ones that have the funding, that have groups of people as quality managers, patient safety officers to take the accreditation journey forward. As Dr. Atul put across, there are more than 25,000 hospitals that are less than 100 beds, and within that, again, 40,000 hospitals less than 30 beds. These are the groups that don't have the resources and understand what is quality at all. They are scared. They don't know, they don't want to expose their inefficiencies for accreditation, certifications, whatever we talk about. I come from a hospital which is accredited and from 2013, and this is probably the largest hospital in the country to be accredited. I belong to the Christian Medical College and Hospital, Vellore. We've been accredited from 2013. So the way we get things around, again, any CEO would vouch by that. It is to show the returns. I'm doing something, I'm doing an activity to improve the process. What am I going to benefit out of it? One example I want to put across. When we started tracking the indicators, when we started asking people to report near misses, incidents, nobody was reporting. But we knew we were having retained objects, we were having wrong surgeries performed. Of course, those come to the notice. So we started tracking them, and we started also understanding the near misses that were coming through the nurses, because they are quite okay with reporting. So the nurses would report to us. So we started costing the near misses. So when we started costing the near misses as though the event had happened and presenting this to our clinicians, to our administration, they realized the importance of actually the cost of implementing practices in place. So every simple intervention we started costing. So just to give you an example of CSSD, our CSSD has been in practice from 1970. And we have about 100 odd nurses who are actually in the CSSD. And we noticed that they were sitting and cutting these small cotton balls, putting them in drums and packing them, sterilizing them, and then that goes into the theater. Hardly 3 or 4 balls would be used out of that, and the entire thing goes waste. So we tried telling them, listen, we can buy, packed, pre-packed, maybe 5 in a pack or 10 in a pack. Nobody would listen. We did the entire costing. Believe me, it is almost 50% cheaper than having this entire lot just sitting down on the floor and cutting these cost pieces. So we showed a cost benefit of almost 15 lakhs in a year and surrendered 7 nurses. What more to expect? Now our administration was very keen. So with every simple intervention that we were doing, we started costing. One important study that we undertook as part of CAHO HPA, along with Indian Institute of Management and the Institute of Cost Accountants, is to see the cost of accreditation versus the benefits, whether we are actually reaching, is it very expensive? We did notice with the 10 hospitals that we sampled that year -2, which is the 2 years before implementing the accreditation standards, versus year of accreditation, yes, there was an increase in the investment towards infrastructure, fire safety compliances, particularly infrastructure related with regards to clean air standards in operating rooms, and some amount of training expenses, putting in people together. But year 1 and year 2, the expenses gradually came down. But the number of footfalls certainly increased in these hospitals, because we tracked these 10 hospitals that were part of us as different groups. One hospital was year 5 after accreditation, and we noticed the number of footfalls had increased. The CEO of that particular hospital was much convinced that people were open, reporting incidents. The training gave the morale boost to all the doctors, nurses who were involved in implementing the systems. And also to say that, they felt safer because systems have been implemented better in their hospitals. Though it's a very contradicting thing to say, because literature, we don't have enough studies available to say that accreditation has brought in the kind of benefits that we desire. I think it's seen everywhere. When I go to small hospitals, implementing quality systems there in these small hospitals, helping them out, the first thing the CEO says is, it's so expensive running this hospital. And then you start looking at it, it's pilferages all over the place, poor systems in place, because this hospital, small hospital, is run by a doctor and his wife probably, who are pure clinicians, who have not gone into the administrative aspects of running this hospital. And when you see the pharmacy, that's the first place that you go and see. 150 probably molecules and 7 to 8 brands in each molecule. Why? Because one clinician who joined them for 3 months, he will want a particular brand added, they would have added that. And that would be remaining on the shelf for many, many years. So such things keep getting added, accumulated. So when you set up a formulary committee, when you set up a formulary and a therapeutic committee, the rationale, the justification, initially there is resistance. But slowly, I went back to this hospital that I implemented, helped them implement after 5 years. This time, the formulary, the hospital, the pharmacy was spick and span. It was beautiful. Their revenues, he vouched, that had increased by 15% from the pharmacy. So every area, it is to look at the cost of poor quality. And these hospitals require the kind of help. And that is why we went into developing all these smaller modules, hand-holding hospitals on a pro bono basis to help them understand the cost benefits of doing this exercise. Because we strongly believe, after our experience of getting this 120-year-old organization with more than 12,500 staff involved in this accreditation exercise, the only exercise that is from the chairman to the doorman is this exercise. When MCA inspection happens, it's typically the doctors who are running around. And when the Indian Nursing Council happens, the nurses are running, everybody else is laughing. But this exercise, everybody gets involved. From the doorman to the chairman, everybody is involved. People function in silos in hospitals. And after this exercise, we notice that people function together. There's accountability. There's a reporting mechanism that's happening. And everywhere you know what is happening in every system. So it's a beautiful thing to work on systems, processes, and therefore improving the outcomes, provided you do it with the right intent of getting people together. And this is what we have been trying to highlight to all these smaller hospitals that require help with this kind of exercise. Not investing in something that, they are scared of. So we need to really allay the fear and get them to do this exercise. And with the right intent, with this NABH accreditation, it brings a lot of cost benefit. And believe me, now we are commissioning a hospital, 1,500 bedded facility, and just yesterday we moved our bone marrow transplant unit there. But whatever mistakes we had done in our previous setup, we had corrected, because it's been a beautiful learning experience for over 15 years of going through this process, trying to tighten every aspect of it, trying to bring in the benefits to the patients that deserve that, so that they don't end up spending extra cost for the poor efficiency and poor quality of services that we offer. So it's been a brilliant exercise for us, and I would really say, in my opinion, this is not costly. It is just dissecting your systems, understanding your processes, putting systems in place, and reiterating to the clinicians and nurses that it's an exercise what their medical college and nursing college taught them, but they have forgotten to do. So it's just a reiteration of that. And thank you so much for this brilliant opportunity given to me.
think, Madam, I think you very, very clearly put it that technology, the quality, the accreditation, everything when done properly is the only way out for our country actually. That's the only way we can take healthcare, quality healthcare to the last man in the line. I think it's been a wonderful session and thank you all to the esteemed panelists for such succinct, clear vision and guidance. And I think we do not have time for closing comments, but we can pose for a photograph before sir arrives.
Thank you to all our panelists for a very invigorating session. And we start with the next session on digital health, changing landscape, opportunities and challenges. With the next session. I would now request all our distinguished join us on the dais. Welcome Dr. R.S. Sharma, the Session Chair and CEO, National Health Authority, Government of India. Session Convener, Dr. Harsha Rajaram. Mr. Dhruv Sukhrani, Mr. Prashant Javeri, Dr. Vaibhav Kapoor, Ms. Khushbu Agarwal, and we have two panelists joining us, Anton Roy and Mr. Jonathan Sudarta. Request all our distinguished guests to please join us on the dais. I request Mr. Gautam Khanna, Chair FICCI Health Services Committee, to welcome Dr. R.S. Sharma with a green certificate. So this is a thicket of 6 trees planted in your name in Sundarbans. I would now request the session convener, Dr. Harsha Rajaram, co-chair FICCI Digital Health Task Force and Chief Operating Officer, Aster Telehealth India and GCC, to set the context for the session and take it forward. Please, Dr. Rajaram.
Thank you, Ms. Sarita. Good evening, ladies and gentlemen. It is a privilege to be standing in front of this august audience and the panel members here. I would like to welcome you all for the session themed Digital Health, Changing Landscape, Challenges and Opportunities. I think in the last 2 days, it has not been a single session where we haven't heard the buzzword digital health. And in every session, there was a mention of digital health and how it can impact the entire healthcare spectrum. So today, in today's context, we will try to restrict to the access part of healthcare because we have distinguished panelists here who come from incumbent side and also from insurgents. So we would be sticking to the access part of the care. You're all aware that pandemic really provided us immense opportunity to test and scale various digital health solutions. And as we see the normalization, we are back to normalization today. Digital health is finding its own space and synergies with the traditional healthcare models now. And even the government today has played an active role in creating a conducive ecosystem in promoting digital health and have been pioneers in introducing models such as e-Sanjeevani, which has seen nearly 6 crores of consultation. So digital health would help us bridge the gap and help us in both affordability and accessibility. Today, during the session, we would be spending time in discussing with various leaders here who have questioned the status quo and also redefined model of care, how they address and what are they looking forward to. While all the sessions what we attended in the last 2 days has been problem oriented, this is very future oriented and a lot of opportunities being created, a lot of possibilities has been also created. So we'll spend some time on it. I have the honor of requesting and privilege to introduce chairperson of the session, R.S. Sharma ji, CEO, National Health Authority. Dr. Sharma ji is, in his current role, heads the very important healthcare initiative of the country, two important healthcare initiatives, Ayushman Bharat Jan Arogya Yojana and Ayushman Bharat Digital Mission, a platform to promote digitization of healthcare in India. He, in his previous role, has played a very important role in developing Digital India while he headed the Telecom Regulatory Authority of India and Unique Identification Authority of India, which is our Aadhaar. He is also chairperson of the Empowered Committee for Administration of COVID-19 vaccine, which played a key role in administration of more than 200 crore vaccination across the country. He has also been honored by Prime Minister's Award for Excellence in Public Administration. We are really honored to have you, sir. And in addition to that, we have other panelists. So since sir has other commitments, would request sir to come down and share his thoughts on digital health and his vision for the domain. Thank you, sir. Anyway, sir, whatever you're comfortable. Yeah, okay.
So thank you very much, Sri Harsh Rajaramji and my colleagues on the panel and all my friends from FICCI. Last time I came to this hall was probably before pandemic, and this was in connection with the telecom, space where we were having lot of controversies relating to, Jio's entry and, interconnects user charges and all kinds of things. And this was a highly, quite kind of controversial or highly debated issues at that point in time. And I remember having a very interactive and vibrant session on that subject. Today I'm happy to say that, though I don't take credit for it, but I am happy to say that when I joined the TRAI as its chairman in 2015, the data was selling at the rate of 275 rupees per gigabyte. The number of 4G connections were very, very limited. In fact, there were no 4G connections, 3G and 2G. Today, the data is selling at the rate of 7 rupees per gigabyte, from 274 to 7. Today, India is consuming, every consumer is consuming on an average 17 gigabytes per month per user. The entire network is 4G. We have 800 million internet connections. We have 1.2 billion mobile connections. We have 600 million smartphones in this country. Just for a comparison, the data rate in America of the mobile phones is $12.34 US per gigabyte, as against 7 rupees per gigabyte here in this country. So I take some satisfaction out of that, that we were able to, and India today has been one of the cheapest markets in the world, and previously people were afraid that there'll be only monopoly or duopoly. Nothing of that sort has happened. Telecom operators are doing very well. Now you have 5G coming. As you know, 5G has been launched in some of the cities of this country. The speeds are pretty good of the 4G also. And I think cheapness of the data can be gauged from the fact that today Indians are watching films on the mobile phone. I don't think there's any country in the world which is watching films on the mobile phone. So this is a great satisfaction. And one of the pillars of Digital India, when it was announced in 2014 and formally launched on 1st of July 2015, was that we will have digital connectivity as the first vision area. Digital infrastructure as a utility to citizens. That was the first part, and that first part seems to have been completed. Of course, we still have a lot to go in the fixed line connectivity, which is required, and then 5G coming in, then fixed wireless access will also happen. So connectivity piece is actually quite settled piece. Now the second piece which was required was the software and services on demand. And that also we have done pretty well in the Digital India program. There have been lots and lots of developments. Also the soft digital infrastructure, which was, which is another requirement, that foundational infrastructure in a digital world, those things also have been done. So digital identity, for that matter, where every Indian has got a digital identity which can be plugged into any any sort of application or any transaction. So whether using that digital identity and electronic KYC generated by Aadhaar, you can open a bank account, you can buy a mobile SIM, you can get ration from the fair price shop. All kinds of things can be done, many things which require identity proof. And this is a digital, so therefore you don't require any physical documents to carry yourself. So that's another aspect which has been done. Similarly, in the payment space also we have done a very significant amount of work. Imagine, we did last month we did about 7 billion transactions on UPI, and UPI transactions, as you know, are absolutely free of cost. There is no limit on the lower limit on the money. So if I transfer 50 paisa to you, only 50 paisa will go to you, not even 49 paisa. So that's the kind of digital public goods which this country has created. And some of these foundational goods have also had their fruits or their offsprings. So for example, electronic KYC is there. You have digital locker where you can store your documents, your degrees, your all kinds of digital, your health records, for example. The digital locker is there. Today in digital locker we have got 5 billion records being stored. So that's one part. You have the electronic signature, digital signature on demand, which is what we call e-sign, whereby you can sign your document without even having a dongle, just by proving your identity, just by using your digital identity. So you have electronic consent artifact. Many things have been done. CoWIN is the latest example whereby we created a platform which actually accelerated to 2 billion plus in a matter of 1 year. And some of the attributes of these digital public goods are they are interoperable. So they are not really silos. They are interoperable. They can connect to various kinds of applications. So for example, CoWIN is connecting to 150 applications: Make My Trip, Apollo Hospitals, ATM, whatever. Talk about any application, Infosys. All these applications are actually delivering the same services of searching for the vaccination centers, getting the appointment done, getting the certificates downloaded. All those facilities are happening. So openness, open APIs, open standards, even open source, interoperable, scalable. These are some of the, because you are building something for 1.3 billion, you are not building for a small kind of persons. So that's something which we have developed. So I think India has really capped, in a digital space, we have really leapfrogged. The country has leapfrogged. And the Prime Minister's vision of the presence-less, cashless and paperless governance actually is happening. In a way, it's being realized. Of course, a lot of work needs to be done still, but this is something which has been achieved and we should be proud of that. I must also share with you that whenever we discuss these kinds of things and the architecture, people are really amazed. People in other places, they don't really believe that things at this scale and then this kind of architecture could happen. And when we call up digital public goods, as you know, our Prime Minister announced that the CoWIN as a platform must be converted into open source and must be exported to countries free of cost. And we have already had agreement with Guyana, for example. There are multiple countries who are actually wanting to use it. Some countries are already using it without giving credit to us because it's open source. I mean, I don't want to name them, but many of these countries are using, because they now understood the overall architecture, and it's a free. It's on GitHub actually. It's a open source. So that's what we are doing. So the idea is that now India as a country feels absolutely confident to really get into other domains besides these horizontal domains. Why I say horizontal? Because payment is a horizontal utility, identity is a horizontal utility, digital signature is horizontal, digital locker. I mean, it can be used by multiple domains. Now comes the idea of using this infrastructure and these kinds of building blocks into a specific domain. And what could be a more important domain than digital health? The health is as you know, COVID has really been absolute disaster for the entire world, also for us. So the only good thing which has come out of the COVID is increased digitization, increased use of digital means. So we in COVID, when we could not go out of our house, we were calling doctor, also doing video calls saying that साहब देखिए मेरा इतना बुखार है, ये reading इसकी oxygen level मेरा इतना है, what do I do? So this digital use of communication tools, that has increased during COVID. And I think the Honorable Prime Minister saw this happening in some sense on 15th of August 2020, when we did not have this, kind of stuff. The COVID had not as yet, it came in about March 2021, if I'm not wrong, no? March 2020. So in 15th August, he actually announced that from 15th of August, we will have the digital, mission of the medicine, digital health mission in 6 union territories. So that way we had been, actually the conversation began in June of 2020, that this should happen. We should have the COVID vaccine will not come, but we will have this. We should have a health program. So that health program was actually announced by PM, and then from, of course, last September 2021, it was launched for the whole country. And now we are, doing this digital mission in the health space. And we feel that digitization will result into a number of, desirable attributes for health. One, it will make health provisioning more affordable. Why? Because using digital tools, you are able to reduce cost. You don't have to camp here in front of AIMS to wait for 10 days and then, or you can sit at home and do a teleconsultation. So it makes it more affordable. It makes it more accessible, because then now you don't have to, you can be in a very remote area and still you could connect using the teleconsultation, which is now very much popular. In fact, we are having 200,000 teleconsultations per day in this country. Even now, even only e-Sanjeevani figures are 200,000. There are many private, Practo, 1mg, many other, people who are doing many more consultations. So that is one thing which has happened. So it makes it more accessible. Then it makes it also affordable, accessible, and then of course quality. Quality also improved because everything is transparent now. So these are some of the basic attributes which will happen. Second, India already has the enablers for these transactions to happen. So for example, the teleconsultation. Now teleconsultation, what do you need? You need to prove your identity, because doctor wants to be sure that you are the patient. Doctor's identity, because the patient wants to be sure that the person on the other side is a qualified MBBS doctor. You need to pay the doctor. Now, digital identity provides that identity authentication. UPI provides the payment facility. The doctor gives a prescription at the end of the teleconsultation, and he is able to digitally sign using the digital signatures. This is e-sign. He doesn't have to, give a fax or anything like that. He can just e-sign the document, and that document, as you know, legally is as, sort of good as a pen signed document. So I think all these building blocks which can enable this transaction to take place are already available. What is other attribute which is required is interoperability. And I must tell you why interoperability is so important. Let's take an example of a teleconsultation. I'm speaking to you because you are all people from the health space and you are all, familiar with these terms. Normally, I would have given a generic bhashan which would not have meant much. But so basically, let's say a teleconsultation. Now, there are multiple applications which have come in the country. Practo, 1mg, e-Sanjeevani, or maybe there are other things also I may not be aware of. Now, the requirement of these is that the patient also has to have the same application as the doctor. So if doctor is on e-Sanjeevani, the patient also has got to be e-Sanjeevani. This is similar to when you are, let's say, buying something on Amazon. You have to have an Amazon application on your mobile to basically transact on an Amazon platform. That's the platform approach. Now we have gone beyond platform approach. We are going to what is called a network approach. Internet is a finest example of network, because internet you are able to connect disparate systems because they use the same protocol, underlying protocols. If for mail it is the SMTP, for other communications it is TCP/IP. There are many couple of protocols which are used. So what is happening is we are now, suppose if I have a 1 mg client, or I have, let's say, even what is called the Arogya Setu or any other client application, and the doctor may have e-Sanjeevani 1 mg Practo. If I could talk to him interoperably, then one need not have multiple applications on his device. If I have just, it's similar to, if UPI is one example, very right. Also, telecom world, again I want to give the example. If the Vodafone person could only talk to a Vodafone person, then this would have been a platform or a silo kind of approach. You could have balkanized the entire, sort of internet or whatever. Now, Vodafone fellow can talk to Airtel person without even knowing as to what is the brand of what is the network operator of the other fellow. This is the thing. So therefore, without bothering, if I have a teleconsult application, and I can see the doctor which are available, whatever their platform can be, I could talk to them. Now this will actually give, this will be giving a order of magnitude larger numbers, and this will make things very, very easy. This is what we are doing in the digital health, Ayushman Bharat digital mission, whereby we are making everything interoperable. So this is what the people are doing in ONDC, Open Network for Digital Commerce, where we are saying it is not a platform approach, it's a network approach. So basically, if I have, let's say, a protocol and I want to see the doctors, whatever may be the other application the doctors may have, so long as they follow that protocol, I will be able to see them, and the doctors will be able to have their calendar. I could be able to make a booking to them. So I could search, I could book, I could fulfill. So I can search for ambulances, I can search for doctors, I can search for laboratories, search for health facilities. These are the basic attributes of the ABDM. We are making a couple of registries of health facilities, registry of health professionals, drug registry. These are authenticated registries whereby you could see that a person on this is a verified doctor, so he is not a quack, and you could test, when you do a teleconsult, you could verify that this person is a genuine doctor. So this gives a kind of confidence and trust. That is what we are building. Then you have the personal records. One should be able to build longitudinal health records. So we have what is called Ayushman Bharat Health Account. That is simply a number around which you could link all your records, and then they could be made visual and visualized. We are doing a small experiment in Lady Hardinge Medical College, and maybe you can go, some of you can go. What we are doing here is that there is a Ayushman Bharat Health account with a person. There is a QR code. The person does not have to stand in the line. He just goes there, he scans that QR code. His profile is transferred to the hospital's HMIS, and his OPD card is generated. So that way, without being in the line. So essentially, these are small trivial applications, but they are very important for a person who has to stand in the line at All India Institute of Medical Sciences. 4 a.m. he stands in the line, 12 p.m. he just gets out of it because he did not get his number. Again दूसरे दिन फिर आ जाता है बेचारा. तो ये छोटी छोटी चीज़ें हैं, बहुत महत्वपूर्ण है. उसी प्रकार से हेल्थ रिकॉर्ड्स आप अपने स्टोर कर सकते हैं अपने फ़ोन में, अपने डिजिटल लॉकर में. You can enable them. You have privacy fully done because nobody can access your health record without your permission. You can share your health record with your doctor. Then your diagnosis will be much better. Your cost will become less because every time you don't have to do X-ray or whatever diagnostic tests. So I think this is all happening. Now we have created 25 crore Ayushman Bharat health accounts. We all now starting a campaign whereby in schools, in colleges, In medical colleges, other institutions, we will be able to create health accounts for everybody. Immunization of children will be actually a part of the health account. We are repurposing COVID to become a universal immunization application, which means that usko polio drop lagaya to uska bhi record aa gaya, uska bhi he can have a certificate downloaded similar to the COVID certificate, COVID vaccination certificate. So all this is happening. Blood banks will also be on the same network. So we are creating a network which will be able to subsume or cater for a large number of services. But what is required is actually, technology is all done, friends, believe me, and technology is scalable, I can guarantee that. It preserves privacy. It is absolutely, flawless in that sense of the term. However, what is important is, this is a project which is a very difficult project. I did Aadhaar, and I find that Aadhaar was an order of magnitude simpler than this project. Why? It was simpler because there were only two people, two entities, two stakeholders. One were the people of this country who wanted a digital identity. Free of cost it was being given to them. Other was the government who was giving identity to them. So people were enrolling in rolls, there were lines, and we had to have lathi charge in some places where there were too many fellows, and the fellow could not enroll so many people. Here the stakeholders are, patient of course is the central part, but you have doctors, you have facilities, you have laboratories, you have all kinds of institutions, homeopathy, Ayurvedic, all professional institutions. So you have pharmacies. So many people are there, and everybody's interests are not necessarily aligned. Some people feel कि मैं ज़्यादा digital करने लगूंगा तो income tax वाला आकर के मेरा पकड़ लेगा मुझे. So there are all kinds of issues. GST हुआ तो everybody started कि भाई तो business डूब गया हमारा, because अब now I can't do any hanky panky. So basically all these things are there. But let us understand, we can have a little bit of small sacrifices for a larger public good. And I think if we can do it, if India can do it, I think it will be really transformational. Because let me tell you, wherever it has been done thus far, Europe and America, it has been done in an absolutely wrong way. In sense, America, you have Cerner, you have, I don't know, another company, Epic or something. Epic and Cerner, these guys control about 80 to 90% of the records, the health records. Now, that's not the way to do it, bhai. It should be completely democratic. It should be completely mobile, interoperable. So that's the way it should be. So basically, from World Go, we have started on a journey which is a very clean architecture. So we have an advantage, having begun late, I think, or beginning on a clean slate, we have an advantage, and I think that advantage should give rise. And I think we can do things at a scale, and we will do things completely differently. One of the aspects of doing things in India is frugality. India is an extremely cost-sensitive market. If you say मैं 5 रुपये आपसे लूँगा, मैं नहीं दूँगा आपको. UPI में अगर मान लीजिए मुझसे कोई कहे कि 100 रुपया ट्रांसफर करने के लिए 2 रुपये का टैक्स लगेगा या कमी होगी, मैं कहूँगा भैया मैं जाके दे आऊँगा उसको 100 रुपये चेक. This is true. So therefore you have to have frugality built into the system. The system, Aadhaar जैसे कार्ड की, UK's ID card was costing 135 British pounds per card. India's Aadhaar has cost less than 100 rupees per Aadhaar. The total money spent thus far is less than 10,000 crores. We have issued 130 crore Aadhaars. So basically frugality, we have to understand, we are a poor country, why we can't afford to have very, very costly infrastructure. We are using completely, commodity hardware. लोगों ने उस समय आधार बना के कहा भाई बढ़िया हम आपको एक स्पेशलाइज्ड हार्डवेयर दे देंगे. तो हमने कहा भाई साहब आप दे दीजिएगा स्पेशलाइज्ड हार्डवेयर, बट देन आई विल बी मैरिड टू दैट ब्लडी हार्डवेयर थ्रू ऑफ माय लाइफ. द वेंडर लॉक इन हो जाएगा भाई. तो आई डोंट वांट वेंडर लॉक इन. So basically we are very clear as to what our objectives are. And once you are very clear in your objective, once you are very clear about your architecture from the word go, I think things will succeed. But this time around, things will succeed only when all of you become a partner into that process. And today I want to urge all of you who are influence maker, you are the opinion makers in your sector, to basically come together and actually make this digital health journey a successful journey. Thank you so much. taken more time than what I was allotted.
Thank you, sir. Thank you for providing an insight and giving us an overview of the ecosystem and in such a fast pace what we are doing in India, and I think getting to know the learning from different sectors and also doing the best in the world. Thank you for that, sir. And now I request Gautam Khanna to.
Yeah, I'm so sorry. I have a meeting I had fixed at 5, so I will be leaving in about 2-4 minutes. So may I leave now? Thank you so much. School. Okay. Thank you, sir. Thank you, sir.
Thank you so much, sir.
Thank you all. We'll continue with the session now, and now I'm very really sorry that Dr. R.S. Sharma had to leave. Now I would take the opportunity to introduce the other panelists here. We have Mr. Dhruv, who's the partner at Bain and Company, and has a rich experience in marketing and also healthcare provider space, and has been part of various digital transformation journeys of different organizations, and would like to welcome him as a moderator. So he would be helping us moderate the session. We also have Vaibhav Kapoor, founder of Pristine Care, surgeon who's leveraging digital platform to bridge the accessibility to the general surgery with the available sunken and unutilized capacity across the country. So we'd like to welcome him also. We have with us Mr. Prashant Javeri, CEO of Flipkart Health. The e-commerce giant have recently started their healthcare division and already making a lot of buzz in the industry now. And they would certainly leverage their existing model and platform to provide better care. We also have our passionate founder of Xyla Health, Ms. Kushbu Agrawal, who is into enablement of personalized healthcare, leveraging data and technology. So we'd like to welcome you also. We also have, we would like to thank and also welcome Brandon Roberry and Dr. Jonathan, who have actually connected to us remotely from Dubai and Jakarta, who will help us in providing an international perspective, share best practices and also challenges what they're facing in implementing the digital transformation journey in the region. Mr. Brandon is currently the CEO of Aster Digital Health and is playing a key role in the digital transformation journey for the group. He comes with rich experience of working with Mayo Clinic and the world's largest healthcare company, United Health Group. Mr. Jonathan is the founder of HelloDoc and is one of the largest health tech company in Indonesia, having a user base of more than 20 million. So welcome you both, and sorry for making you wait remotely, Brandon and Jonathan. I think you have been waiting for an hour now. Thanks for being there. To set the context for the session, I would request Dhruv to provide a short overview of the digital health landscape, and which would help us set the context and the discussion later on, and then follow up with the moderation for the session. Over to you.
Yeah, thank you, Dr. Harsha. I think it was a very inspiring talk by Dr. R.S. Sharma,
And I think the discussion today will focus, I think, on not only the health tech landscape and how it's evolving, but also basically the role all of us can play in, driving the adoption of the EBDM. So I think these two topics. I'll just spend a few minutes on, how the landscape is evolving in India, and I know a lot of us would have a good sense, but I'll just walk through. I think we've had now, I think COVID, hopefully COVID is done. I think we've seen pre-COVID, during COVID and post-COVID, all three different, phases. And I think health tech has spawned during this time. And, I think behaviors have changed. So maybe we talk through a little bit, somebody can pull up the slides. But basically, I think that as Bain, we've been looking at the evolution of behaviors of patients, doctors over time, and I think there's a survey we do. But on all counts, I think if you go to the next page, I think patient adoption of healthcare, of digital healthcare, willingness to use digital healthcare, do research online, 70% plus of customers, if you see the first chart, are willing to do their research online and adopt digital. Similarly, I think on the other hand, doctors, I think we've always had, a point of view that doctors will not adopt digital. But now if you ask doctors, this is a 2022 survey on how much they think can be done through telehealth, more than 25-30% of doctors and even 50% are open to doing teleconsultation and have actually used teleconsultation. So I think clearly, and we've seen signs with eSanjeevani and others that, this is a thing on the up. From a behavior perspective, both patients and doctors are showing, a move towards digital. If I look at the next page, this is also reflecting in, a lot of my colleagues, a lot of the folks here are kind of, seeing this upsurge. I think this is, monthly active user data or daily active user data of different platforms in India. And while there was a surge in teleconsult and usage of online, even post-COVID, if you look at the red bars on this chart, this growth continues to sustain. So, I mean, there's always been a debate on, how much will happen digitally and then will it move and, move back to traditional. The point you see over here is there is still significant growth on the adoption of telehealth even post-COVID. And, it is a trend which is likely to remain in the future. So I think that is another point to make. So, platforms are also seeing a lot of traction. If I go to the next page now, I think the third party, so there's doctors, there's patients, and then there's the government. I think all are now very supportive of taking digital forward. I think the telehealth guidelines, eSanjeevani's success, the 6.4 crore teleconsultations which have happened so far, the mental health portal which has come up, and obviously, the ABDM. All of these are opportunities basically to drive, adoption of digital health, and the government is very supportive, as we heard from Dr. Arish Sharma today. So this is basically what's happening with the three stakeholders around digital health. If I go to the next slide now, I think the private sector is also now looking at this and building up a lot of momentum around this. A lot of large conglomerates and insurgents have entered the space. Reliance, Tata, Amazon, Flipkart, Apollo, PharmEasy, these are all, and some of the esteemed folks are here, are taking up the opportunity and are looking to build a full integrated offering for customers across, preventive, curative, and enabling elements. So, a lot of action is happening in the space. A lot of people are entering. It is an opportunity for us. And I think the last ecosystem beyond the private sector, if I go to the next page, is, the entire funding landscape. And these are numbers. I think funding during COVID went all the way to 3.9. The red bar is basically, the around health tech. But if you see, the health tech investments have been very prominent. So there is also investors who are still are very much backing the cause and driving the growth here, right? So I think across all, members in the ecosystem, there is a lot of support for digital health adoption. And as we talk through the panel today, if I go to the next page, I think we need to look at basically, 4 or 5 key questions. Just go to the next page, please. Yeah. And just one more thing which I should say actually is globally, if you look at the number of, India has obviously created a lot of unicorns across different sectors. But globally, if you see, there are 100 health tech focused unicorns, right? And India currently has 5, which is very inspiring, but which shows that there is a significant opportunity going forward to unlock a lot of potential, right? So I think that is one last thought. And with all of this in mind and all the 5 stakeholders kind of, supporting the journey, if I move to the next page, some questions we should think about, and, we'll discuss some of this in the panel is, and we heard a lot of this across so many panels today. How do you increase access? How do you increase affordability? How do you increase quality? How do you drive preventive health and wellness as a way of life? And then, how does ABDM fit in and help us leapfrog in lines with what we did in telecom and fintech, right? These are like questions which are very important, and that will basically be the theme of the conversation today in the panel, right? So maybe we quickly move on to the panel given time. So I think, thank you so much all for joining. Really, really appreciate your time. I think there are 2 sets of topics. One is a little bit on the health tech learnings, challenges, and how people are seeing the health tech landscape evolve. And I think the second part of the panel will be more about the ABDM and how does the private sector, drive adoption and make it a success. I think there are 2 different parts of the panel. The first one, maybe Prashant, we can talk a little bit about, health tech. Flipkart has obviously gotten recently into the health tech journey, and 2 parts of the health tech, which is telehealth and pharmacy, have picked up. But more broadly, what is your play and where do you see opportunities in digital health overall? Maybe we can just get your thoughts on that.
Thanks, Dhruv. I think as we've thought of health tech, there is everything that actually happens. Before I speak about health tech, think about healthcare itself. We think about stuff that actually happens inside the hospital, the treatment, and then there is the trinity of consultations, labs, and medicines. Over the last close to a decade now, we've seen a lot of action in, like you rightly called out, Dhruv, in the e-pharmacy space. We've seen a lot of action in the teleconsultation space. And, I've got, esteemed, panelists on this podium itself. We've got, interesting play that's happening and interesting work that's happening in surgeries and chronic disease management, so on and so forth. But if we were to take a step back, the challenge essentially has been that after being around for a decade, if you look at the online penetration of e-pharmacy, for example, that is still in single-digit percentages. If you look at diagnostics or labs, for that matter, that is even lesser. It's interesting when Mr. Sharma, he basically spoke about, Dr. Sharma, he spoke about, what is it that we're trying to solve for? You've got to keep it simple. As you think about it from the point of view of the consumer, we may think of life as saying there's chronic medication, there's acute medication. But for the end consumer, for the patient, for the life, it is saying, doctor's actually given me a prescription, I need all of these medicines. The patient doesn't think of it as saying, is this chronic and should I actually be going somewhere else versus acute and should I be going somewhere else? The problem statement very clearly, Sharma ji spoke about was saying, hey, listen, how do I solve for the waiting time in the queue? Right? As simple as saying, I've got my Aadhaar ID, I hop over to a QR code, I scan the QR code and pop, comes out my OPD card. So sometimes we know it is going to be a series of experiments and series of innovations as we think of evolution of health tech. And health tech is not about saying, is it online first, is it offline first? Once again, the consumer doesn't really care. The consumer is saying, is it really solving a pain point? Is it really solving a problem? Is it simplifying my life? Right? So I think the evolution is going to be around as we start thinking about healthcare, not just as the individual, but also the family. And I think this family, phenomenon more so plays out in healthcare. I've been around for 17 years in healthcare than any other. My mom, my wife will care more about my health than I will do for my own health, for example. Or I'd care about my kids, and it's always a family affair. So how do you, as you think of evolution, and if I was to also refer to the traditional world, over the last 2 decades, we've seen, as you think of hospitals, multi-specialty, quaternary care facilities, doing everything from dental and dialysis on the one hand, to transplants and bypass surgeries on the other. And then over the last 2 decades, we step back, hey, listen, maybe you don't really have to step inside the hospital for everything. So you start carving out pieces. You say, hey, listen, maybe there's a separate dental chain, a separate dialysis chain, Hoftal can be carved out, mother and child can be carved out, so on and so forth. Likewise, as you think of, health tech, once again, online technology, platforms, networks, as an enabler for the consumer to be able to access healthcare seamlessly. That also will play itself out similarly. There will be horizontal platforms, I would think, that actually cover the length and breadth of healthcare services, just like a traditional hospital has done everything from getting a health checkup done to a transplant done. And at the same time, one would think that there will be silo operators that actually have very specialized, very niche focus. But the power of it all, as you think of it from the lens of the consumer, once again, like Dr. Sharma said, saying, can you actually make it interoperable? Can you actually take a network approach? Can an Airtel customer call a Vodafone customer without thinking, saying, does that fella have a Vodafone card or an Airtel card? As simple as that, right? So I think that, and at the end of the day, it is, healthcare is very obfuscated. It is very opaque, as you think about it from the lens of the consumer. I've been around in healthcare for 17 years, and I can still tell you I know less than 10%. And someone who's actually just availing healthcare, to be able to get better, to prevent disease, so on and so forth, there is much more work that needs to be done. So it is about helping that consumer seamlessly access healthcare, about the frugality, about making it affordable, about helping the end consumer, the patient, the life, make an informed decision, all of this and more. So I think as a wise man once said, you can only join the dots looking back. Likewise, the way this, in my opinion, will play itself out, Dhruv, is we'll have to do a series of experiments, a series of innovations, figure out what's working, what's not, see how we can then, scale them and demonstrate that we're a country of 1.4 billion people. So we've got to think of scale in every single thing we do. If we can demonstrate it works at scale, that is when true blue evolution would have really kicked in. And once again, the advantage of having a clean slate, we got to make the most of it.
Thanks so much, Prashant. Very useful. I think what I'm picking up is, I think a lot of this is, we're at the beginning of it. There are opportunities to make it seamless, to make it scalable. There is the family angle, and making it truly differentiated from a customer lens. I think that is key, and then we will look to solve a lot of opportunities with digital. So thanks, Prashant. Maybe Brandon is involved with Aster. I think, Brandon, you're seeing a lot of this action happening in India. Just your view from a traditional player like Aster, how are you looking to build on the digital opportunity? And what do you think are your inherent advantages and your challenges as you look to win in this market and grow and adopt the digital opportunity?
Sure, thanks, Drew. And I'll start off by just saying I'll agree with Prashant at least 90% of the way. That's pretty good, close enough. But mostly agree on the lens of the customer and the patient, and that everything has to inherently all filter through them. So I'll tell you one thing, what we're not trying to do is build from the hospital or the healthcare provider back. We're trying to build from the customer and the patient forward, right, for them first. So there's a few key pieces. What does the patient or customer actually want after understanding who they really are? They want to understand as they walk in and get or call in or video in that they can get great care. They want to understand in the palm of their hand what that care means for me, and what are the next steps, and what are my prescriptions and non-prescription medications that I need to have. They don't want to go into one place and then you not recognize them in the next place, or then not recognize them at home, right? We call it the master patient index. It eludes us many times as healthcare providers who have hospitals and clinics and pharmacies, etc. How do you wrap that all together? So those are some of the things we're starting with, right? The master patient index, one view of the customer and patient, being able to care for them and their families more holistically, because we really understand all of those touch points. That's kind of easy to say, but really difficult to do, given the data and the architecture and all of those pieces. Because the patient, look, they want to take more ownership of their health in the same way they do with their finances and their shopping and their retail and their entertainment and the other industries that are far ahead of healthcare in being able to provide them those kinds of options and opportunity. At Aster, our mission is affordable access to quality healthcare, right? That's what we're trying to do, and that's what we're pushing forward to do. And so you think of digital health being at the forefront of that and wrapping all of those assets and opportunities together. That's what we have to do, but we have to do it in a patient-centric kind of way. So Drew said, what are the advantages and or challenges of being a traditional player? So we've all seen a lot of your big tech companies try to get into the space, many of them spending billions of dollars and kind of crashing and burning and then backing out of the space only to get back in 5 or 7 years later with some new opportunity. It's really difficult for them to do such because of what they either do or don't understand about healthcare. I think one of the advantages of being a traditional player like Aster is we do have the capability and capacity of a healthcare provider with a decent and large footprint across a number of areas. So that provides us scale, that provides us density. But the challenges are, I don't think, maybe that much different from any large incumbent type of organization, right? We're too slow. The data is difficult to get a hold of, even just for ourselves and understanding what that is, which is where all you fabulous insurgents come into the marketplace to provide those great solutions that we can then partner together with. And I think those are the exact touch points where we do partner together with on those use case solutions. So from Aster's standpoint, we're trying to take it sort of customer and patient first, use case by use case by use case in building that out. Yes, we have teleconsultation. Yes, we have appointment booking. You can see your medical records now online in the palm of your hand. You can get your lab reports. You can upload your prescription and get that delivered to your home. You can go to your pharmacy or shop on ePharmacy. You can get home care and delivered. Chronic condition management solutions are there. But what's even further there? What about the personalization and the AI algorithms that stack on top of that so that we can understand you more and better? It is a process and it is a journey, but I think, as Prashant said, as we focus on the customer and patient first in designing that out, we will be in better stead. So I think for insurgents, in terms of their coming into the marketplace, I would just say, from our standpoint, we welcome you. I don't think it's that we're necessarily looking to be upended, but I think we can both learn from each other and take advantage of what each one of us has in order to win in the burgeoning marketplace, not just in India, but all over the world. And hopefully we can together then build more of that affordable accessibility to quality healthcare. So I'm in Dubai now, and one of the things I love most about being associated with Aster is its cost to serve metric and how digital can help to drive that. Right? As you can tell by my accent, I come from the United States. You understand how much we have our cost to serve metric? It is ridiculously out of control, and so many multiples higher than what we have at Aster. It's embarrassing to me. So grateful to be part of an institution and link arms with all of you that can drive more to the affordable access to care.
Journey and the touch points and actually making it a true customer first kind of approach which is needed from a digital health perspective, and great to see some thoughts of partnership, which is probably the way forward on many of these elements on how everybody works together. So thanks so much for your response. Maybe I'll move to WebHub, and WebHub, you're now I think getting into a very interesting part of the market, which is the surgery market. You are amongst the leaders, amongst the pioneers of actually doing this. Maybe talk a little bit about your model, but also talk about through your experience, you would have touched base with a lot of small hospitals, large hospitals, patients, doctors, government, insurance companies. What do you think are the pain points which exist today in the system? And also talk a little bit about what can a platform asset like yourself do to solve some of these problems.
All right. So I'm also a surgeon, so I've been practicing for the last 10-12 years, having done a lot of OPDs, a lot of surgeries myself before we started Pristine, and Pristine is a 4-year-old health tech startup as of now. The idea is, like Dr. Sharma said, there are multiple stakeholders, when you come to delivering a secondary care or a tertiary care health, facility. The idea is, and the most important of them, I believe, is hospital, the insurance, the patients themselves, and the doctors. So if you see, if we talk about them one-on-one, hospitals bearing a few larger government and top hospitals in India, rest of them work at a 30-40% utilization capacity, right? While we always say India needs more hospitals, right? But also the dilemma is the existing infrastructure beyond certain hospitals is just 30-40% utilized, right? Now, why is that, right? One, probably these hospitals don't have access to the latest healthcare protocols, right? Two, they might not have access to the latest medical equipments which are used to do the most advanced surgeries. So probably they can't, grab that patient attention. Similarly, we say that we need a lot of more doctors in India, and probably the medical seats and everything should also go high. But at the same time, if you talk to any doctor, he needs more patients, right? There's no doctor who would say probably I have enough patients and I don't need more. Every doctor is finding ways, going to a lot of platforms where they say probably how can they get more and more patients, right, which they can actually see. So they are also underutilized. Similarly, on the insurance side, if you talk to some of the larger insurance companies, they would of course say that they have close to 10,000 hospitals on their panel, but probably 90% of their business is being derived from the top 10 percentile of their hospitals, right? So for them, if they want to sort of have cost benefit, they want a broader utilization of their network as well, right? Especially when it comes to secondary care surgeries, if they're happening in a secondary care hospital, it is of course cost effective for them. And then last, and I think the most important, the patient themselves. I truly believe, and having, gone through so many patients myself, the healthcare experience, especially during a surgery, is completely broken for the patient and his family members. Right? Surgery itself is no less than a trauma, but the entire process from finding the right doctor to getting their pre-surgery things done, to getting their insurance clearances, the day of surgery, probably 3 weeks of follow-up and recovery, the entire family, goes through that, literal trauma where probably, if my father undergoes a surgery, I'll probably not go to my place for next 5-7 days. I'll skip my office for next 5-7 days, because I understand it's a complete journey where the family is also get involved. So it's not just the patient. So I think these are the broader inefficiencies which we have in our system. Now platforms like Pristine, so we normally say we are new age healthcare service providers, right? How do we come into picture, right? So the idea is we today work with close to 1,000 mid-size hospitals across India. Now the gaps which I mentioned, right? So what we first do is, as Pristine, we go and we first ensure the quality protocols are placed in all these hospitals. So there's a quality team of Pristine which would go to these hospitals, train their nursing staffs, in pre-surgery things, how do things work in ward, what are the emergency parameters which you have to take care, right? Then we go inside the operation theater, we check the entire protocols are set or not, the basic standing operating protocols which you require in a surgery, standard terms like a sign in, a sign out, gauze count checks and everything, and the post surgery care. So we invest a lot in training the hospital team members, and it's mostly the paramedics, the RMO doctors, the MBBS doctors, who are taking actual care there, right? So when we go there, we upgrade them to the standard protocol. So today we say probably Pristine is one of the largest 1,000 hospital chain where at least those standard operating protocols are being set up. We are trying to work with NABH, with Dr. Atul Kochar, where we institutionalize that entire process itself, right? Second, now these hospitals lack these basic high-end equipments because they are costly equipments. Probably they will do 1 or 2 surgeries a month there, so they cannot afford to buy that. They don't have that muscle to buy those equipments because these hospitals are generally run by a a good surgeon, a good physician, or probably a small institution. So we since we don't build our own assets, we invest in buying these all latest equipments, whether it is lasers, for proctology, for varicose veins, whether it is, for kidney stone surgeries, whether it's for any kind of disease. So we invest in buying all these latest equipments. So when we buy all these equipments and we place them in these hospitals, now this mid-size 50-bedded hospital can actually, is empowered to do a similar kind of a surgery which is happening in a tertiary care hospital, right? The similar, the similar standard of care and the similar quality of treatment. Third, of course, since the doctors are of pristine and we have all full-time surgeons and they're all super specialists with very high experience. Now when they go to these mid-sized hospitals, the quality of care for a patient doesn't change at all. So I think by doing this, we are actually empowering the hospitals, using their assets and making them give them better utilization and as well as training their protocols. Second thing is on the doctor side. Like I said, now all the doctors who join Pristine, they virtually get a platform where they understand that, okay, I as a surgeon, I know how to do an OPD, how to do a surgery. Pristine is going to take care of all my other hassles, right? I don't have to think about how do I get more patients. That is going to be Pristine's responsibility, right? I just have to care about my medical excellence. So we are investing a lot in their training. There are a lot of technologies which are relatively new in India right now, right? They are of course FDA approved, so we upskill them into that as well, right? Because in medical it's a constant upgradation, right? What I've learned 5 years ago, new things have come up, I have to relearn a lot of other things as well. So I think we constantly work on that. So doctors believe that at Pristine, this problem is at least solved. Similarly, when these secondary care surgeries can happen in a mid-sized hospital and the distribution becomes slightly better, right? I think insurance can definitely have a better cost benefit there. So I think that is how we'd be trying to collaborate with insurance companies and brokers and TPAs, where we can actually give them a lot of cost benefit there. And I think the most important part is patient. So for patient, there's a virtual care coordinator with every patient, right? So it's like a member where you can who you have access 24/7. You can he'll assist you in your OPD, he'll assist you in your pre-diagnostics, he'll assist you in your insurance clearances, he'll sort of assist you in your admission, in hospital stay if you need anything, post discharge till probably your last follow-up. So I think so we've taken these 4 segments and we've tried to institutionalize a lot of these in each segment, and I think that is we've been trying to do for the last 4 years, and patients have of course recognized this. In 4 years we're doing decently large number of surgeries. We've grown in spite of being in COVID. So I think that is what Pristine is doing right now.
Well, this is truly inspiring, and I think it's an example of where we are solving for there are only 3,000 hospitals in India which are more than 100 beds, and I think we are actually looking at a solution which actually solves for the less than 100-bed hospital. And again, the themes which I'm picking up are seamless journey for patients. I think the specific solution for hospitals and a little bit of the partnership between the nursing home and the new age players, and how that's working. So amazing, and thanks Vaibhav for your thoughts. Maybe I'll pull in Jonathan. Jonathan, I think Jonathan's built the leading player in telehealth in Indonesia, and Jonathan, it'll be good to talk to us about your model. Talk to us about how have you evolved during COVID, post-COVID, and I think telehealth in India specifically, I think there are areas around scalability, unit economics. How do you partner? The same theme. Talk about how you've done that. You have a few years ahead of us in terms of the evolution on your path. So it'll be good to get your thoughts, Jonathan.
Thank you very much, Dhruv, and thank you very much for the audience for having me here, the FICCI organization as well. I think you're being too kind about saying that we are 2 years ahead of India. I think I learned a lot more from the Indian company, but probably just a little bit about what we do in Indonesia. We connect patients to providers, in this case doctors, hospitals, pharmacy, including insurance. We are working with probably 75% private insurance and managing also as a TPA for them. So the patient experience would be you basically just talk to a doctor online. You might get a prescription, and if you press a button, you get the medicine in average about 28 minutes. for you to in 140 cities in the country of Indonesia, in which you can, if you need, you also can do an appointment booking for hospitals, for referral of hospitals, or if you want to do a home service, like for example blood tests, PCR tests, and other part of the test at home, and you get the whole results in your phone, in which all of this are catered by insurance or directly by patients. So probably that's a little bit about the product. Now, with regards to unit economics, I think you mentioned about I don't know how things are play out in India. In Indonesia, I think so far the market have been quite it's not a market where everybody is trying to do discount here and there. It's a market where I think patients are comfortable in trusting a platform to speak to a doctor that they are in need, and I think because of that, I think like you mentioned, I think many of the players, or at least for us, I think we are in quite a healthy position with regards to business, with regards to unit economics on that. Now, how does COVID? I think before we talk about COVID, I think what I have to mention is about how the government of Indonesia is really has been a catalyst of the if the keyword is insurgence of the coming of insurgence of telehealth, because I think since we started Halodoc in 2016, I came to meet the government back in 2015 to pitch the idea of Halodoc, which is connecting patients to the whole platform. I think the government of Indonesia, I have to say, was very humble to say that, John, I'm not too sure about what you're building, but I know that technology it's coming. So rather than we're trying to block you or stopping you, I think it's better for you to do and inform us. Let's create some regulation around something that you built. Today we call it sandbox regulation, but back then they just basically said just do it. Now I think that is a philosophy that they have been adopting since 2016 until today. So during the period of COVID, I think it was very clear that the government was very open to create a relationship or a partnership, a public-private partnership, in which we were helping the government with distribution of vaccines. I think we create up to 400 drive-through location in the country for vaccination. We partner with the government also for testing. There was a point where we provide about 10% of testing in Indonesia for COVID, and up to a point where I think last February we actually partner with the government that we give free consultation for patients who got COVID. The medicine and the delivery is actually paid by the government, and there was like reaching a position of like 40% of patients who got COVID actually use telemedicine because of this collaboration. So I think COVID have definitely created a significant buzz about the technology or telemedicine itself in the country, that helps to educate not just patients but also providers and payers. So I think that's maybe that's a bit of the sharing that I can share to you, Dhruv, and to the whole audience.
It is 28 minutes and 10% at some point of actually COVID testing happening through Halodoc. So really impressive, and I think just the thought on collaborating with the government and them being open to experimentation, and we've seen signs of that as well in India. Through COVID, a lot of initiatives have happened with the government, and even now you heard Dr. Arish Sharma talking about how do we take it forward. So thanks, very useful. Maybe I'll turn to now Khushbu. Khushbu, you're trying to do something very interesting at Xyla. I think you should first explain what you're doing, and I think also I know it's based a little bit about value-based care, and I think that's a concept we've heard more in the US, and starting to pick up in other geographies. So how do you think it'll apply to India, and what will be the role of the government and payers in making it happen? Good to get your thoughts.
Sure. Thanks, Dhruv. First of all, it's really a pleasure to be sitting here amongst this esteemed panel today. Thankfully, we also heard about value-based care from Mr. Shankar, a number of dignitaries today, and it was music to my ears. So just to share some background on what we do at Xyla and why we do what we do, I'll just bring to the audience a very fundamental question, given that this is the FICCI conference, FICCI HEAL conference. What was really the purpose of healthcare, right? Why do we practice healthcare? It was to make people better in terms of their health. It was to bring about a change in their health. It was to bring about a healthcare outcome. Now, in whatever we have seen and done in healthcare for the last many decades in India, be it structuring hospitals and pharmacies up on the ground until the 2010s, to now the digital revolution on delivering medicine online or lab tests online, what we have seen is that it's still transactional. It's still doing a transaction with the patient. We are still missing the link of, hey, I did this blood test, hey, I did this doctor consultation, or hey, I got this health intervention from the hospital. Did my health improve? No one is really answering that question, and that's the question Xyla is trying to answer for the country. The reason that question is not answered so far is that healthcare is being delivered for less than 1 day out of your 365 days in the year. And how do I give you that math? How many times in the year do you visit a doctor? On an average in India, it's less than 1. It's in decimal points. How many times do you get hospitalized in a year? In India, the average is less than 1. Where is healthcare delivered in India? In the clinic or the hospital, which means healthcare is not being delivered, right? For me to be better, I need healthcare. I need a continuity of care management, which ensures that my symptoms, my diagnosis, my health issues are being taken care of and someone is improving them continuously. That is what we are trying to do with Xyla. We are really creating this meta layer of care, which will be sitting as a de facto health connection, a health concierge in every family. Prashant mentioned about family being integral to healthcare. Extremely true. Imagine 10 years back, 15 years back, we did not think that an Airtel or another telecom provider would be such an integral part of our day-to-day life. All of you have a newspaper connection, a telephone connection, a Netflix connection, or a Hotstar connection. Do you have a default healthcare connection? Who do you turn to when you don't feel well? Who is actually checking in on you and ensuring that you're doing well today? Xyla will be that default healthcare connection that we are building. We are building this because there has to be a layer of care amongst all the madness of the healthcare ecosystem, right? We're talking about 25,000 plus hospitals. We're talking about lakhs and lakhs of pharmacies and diagnostic labs where patients are going and seeking care. But who is tying it all together? Who is actually going in first and understanding, this is my health record, this is the care I need, and now these are the transactions I need to do, or I am at a heart attack risk because of certain familial history or high triglycerides, and I need to do an echo test so that I don't fall in the trap of a heart attack. So that continuous care management and 365 days of care against a decimal point in the year is extremely crucial for you to be healthy and for healthcare to deliver on its promise. Now, how do we do this? Just bringing back my consulting experience from the US, I was at Deloitte Monitor earlier. What we built there was value-based care models, which means 80, 90, 95% of the US or UK is insured, right? So insurance has penetrated way beyond what it has done in India. Majority of that insurance is being provided by the government or by your employer. Some few percentage would be through private insurance. When insurance has done its job and insured almost the complete population, now for them to improve on their P&L and to actually make better profits, they have to reduce their costs because the market is captured, right? You have actually insured as many people as you have to. How do you reduce your costs? By ensuring that people don't land up in the hospital, because that is cost for me, that is claim for me. So to cut the long story short, in the US and the UK, the government or the insurer licensed with the hospitals and the doctors to ensure that they are paid for outcome, what Mr. Shankar was so nicely stating in the afternoon, which means that the government, like a Medicare, Medicaid in the US or the NHS in the UK, would tell the provider, the hospital or the doctor that, hey, I will pay you this % as a fee for service,
but the remaining is a variable. You show me the outcome and quality of care, and then you get paid. This is globally how healthcare is delivered at scale in a patient-centric manner, so that we actually deliver on outcomes. In India, it is still evolving. We are 10 years behind, I would say, the US still, but it's emerging. Ayushman Bharat and the Aadhaar card is a great advancement to actually first capture the data of the user before we start doing all of this. In India, what Xyla is now doing is that we are actually licensing with that insurer, that payer, be it a private insurer, large private insurer covering tens and 20 million plus lives, or the corporate that's covering their people, their employees towards health insurance. We're telling them that, hey, we will assess the health of your people, your policyholders, your employees. We will understand who needs what care. We will provide that care, and we will ensure they stay out of the hospital and they stay healthy. As a result, we show ROI on that investment. That insurer or corporate has paid me for this continuity of care through my platform, through Xyla's product. And now when I show them ROI, they see that their costs reduce and they're ready to invest more and more. So providing that continuity of care through the insurer at scale is critical for us to do justice to the 1.3 billion people in India. Otherwise, we may end up just doing transactional care and not really showing the healthcare outcome the country deserves.
So this is very interesting, Khushbu, and it's interesting that I think the network and how you tie it together, and also it's good to see that the government's making the right moves, and I think there was good conversation around the outcome-based approach. I think it's early days, but I think it's a very aspirational goal, and a lot of things need to work together, and stakeholders need to come together. So power to you. But I think so. This was, I think, section 1. I know, just in terms of respecting time, we have another section, and I'll skip a few questions there. But this was a little bit, the Ayushman Bharat digital mission and overall government role, and what are the policy interventions required. I think we have folks from all different chapters within the health tech ecosystem who I wanted to kind of get thoughts from. But maybe Brandon and Jonathan, and I know, Jonathan, you talked a little bit about the role government played, but Brandon, what you were experiencing in the UAE and with the DHA and others, and how they are facilitating, maybe some inspiration for India as well. If you could talk a little bit about that, that'll be useful.
Sure. So in the UAE, we have multiple government agencies with regards to health. But the ones we deal with mostly in Dubai is called the DHA, the Dubai Health Authority. And fortunately for us, they're rather progressive when it comes to the thinking about digital health and where it needs to go. Obviously, there's a give and take with any kind of government entity and what their goals are and what ours are. The nice thing about how they support us is they keep a very kind of, I won't call it informal, but very close relationship with its government providers as well as its private market providers, which is where we come into play. And they actually bring us into conversations before they implement some new standard or set of standards to say, hey, how will this affect you? Is this going in the right direction? Is this fair from a competitive landscape standpoint? How will this increase accessibility? Do we have too much or too little capacity in this area? And so those are, when a government is willing to have those kind of conversations on a fairly frequent basis, that's good for the entire landscape of healthcare. So for example, what they've done is they've set up some tech standards with regards to digital health. They haven't been prescriptive on exactly which applications you must use or which protocols you must use, but they've said they must be up to these kinds of standards, and that's the way we're going to run the country. That kind of pre-planning is super helpful for a guy like me as the CEO of Digital Health, because then we can plan out what we need to shoot for and how we build out everything from what you would think of easy things like teleconsultation, but where when you dive under the cover in some countries that becomes difficult because there's only one particular provider of an SDK inside your app who can actually provide that service or something like that. But when you have the government support to actually move that forward where it's a kind of a level playing field, that's super helpful. They also have goals with which they want to meet over the next 5 and 10 years with regards to their both native and expat population and the availability of our pieces of healthcare, which is, again, is also something for us to So I don't have many complaints, frankly. I think we're pretty blessed to be in the area that we are. And those dialogues are frankly what's most helpful, so we can not only do the planning, but to get the implementation in play. I will also say it goes the other way, because as a private healthcare provider, as you would assume, we're a little bit more progressive than frankly any government likely is. And so we actually bring things to the table for them, show them exactly kind of what we're doing. It's not a secret, guys, right? We can go through our entire apps and our websites and how we're thinking about it. Our entire roadmap is on display. And then they partner with us to say, well, can you help us and teach us and integrate with us, those kinds of things. So that's the kind of support we get. Not perfect, but frankly, a pretty darn good model that hopefully other countries take advantage of as well.
Openness to experiment, being consultative, working hand in hand. And I think that's key, and not being prescriptive. I think that's, themes which kind of work well when we try to collaborate between public and private. Maybe I'll ask the question of all three of you, and maybe Prashant, we can start with you. Like, as you think about, the digital health scene and the adoption and, driving it forward, where do you see the role of government, the ABDM, and, how can they help to kind of take this forward?
I'm sorry, Prashant. Let's keep it short because we are running out of time. So a short answer would be appreciated. Thanks.
Sure, Dr. Harsha. Dr. Harsha knows me from 16 years now. And he knows that, he's got to give me a heads up before I start answering. I'm going to keep it crisp. I think what Sharma ji essentially called out earlier in this session, I think it's fascinating. What the government's doing now is through ABDM giving a level playing field for every single aspiring digital health operator in the country, healthcare operator in this country, online to offline, offline to online notwithstanding, and saying there is no first mover advantage, which I think is extremely powerful, right? And I think if we just continue down the path of, on the evolution on ABDM to just make sure that as we think of preventive care, proactive care, personalized care, how does all of the interplay between 250 million lives so far and 175,000 healthcare providers and another 100,000 doctors and professionals that are already on the platform and growing, or network rather, and growing, will I think only aid the ability of many of us to be able to do meaningful work as we touch lives. Just one more thing, he called out saying we're the cheapest in telecom. It'll be lovely, in a couple of years or maybe more, or whenever we come back, saying the healthiest on the planet with the lowest number of, chronic care patients or chronic care or lifestyle patients in the world, happens to be India. Not just the cheapest in telecom, but also healthiest on the planet. That's my take. Thank you.
Thanks, Prashant. Maybe Vaibhav, I can ask you the same question.
Yeah. So I think, like Brandon said, everything is out in open as well. But at the same time, we've been reaching out to all our stakeholders, to our regulators, to government as well, about, telling them about the work which we are doing, how we are, sort of thinking as a force of good, where we are trying to improve the quality of life for every patient. So one is that, and of course, I think as we interact more with the government and our stakeholders, the idea is just to consider these new age healthcare service providers, into mainstream, and then integrate in their internal, current scheme of things, whether it is Ayushman Bharat, whether it is, direct empanelment with insurance companies, right? Because, I'll give you a small example there. Just for example, if it's a 15-bedded hospital, right, they are eligible to get empaneled with insurance companies because they have a physical infrastructure in place, and that hospital actually might just be doing 10 surgeries a month, right? We do a decently large number of surgeries, a year, or every month, but since we don't own any asset, we don't fall into that category where they can have direct empanelment with us. So I think certain proactively when we reach out to them, certain amendments there, would really sort of, help in sort of, just expanding this market altogether more.
Very, very helpful. And maybe Khushbu, your thoughts?
Sure. Just 2 points. I think Mr. Shankar already mentioned that The government is working towards enabling reimbursements for providers or hospitals basis the outcomes or quality of care they show. I think that will go a long way if we can scale it across the country. That will really ensure that people are getting the outcome that they deserve. Secondly, what I would say is that in such a large population, the ability to misappropriate a patient is really high, right? The patient may get misappropriated for a CT scan or an MRI or a surgery that was not required because it's a very massive population. You can't run it on ethics. It's very critical to have a sort of a digital layer which captures your longitudinal data and ensures that there is care provided based on a care plan which was implemented, and any time the patient is going to a physical infrastructure, it is governed by those protocols and a digital trail that is auditable. So I think that's what we are trying to drive, and we would love to do it with the government as well, where I understand the data on the user, I intervene in a holistic way digitally through my platform, and then if they need to go outside, it's through a protocol.
Correct. So I think we just about at time, not bad. So thank you so much. I think it was a very exciting panel, and just what I'm hearing is we're basically there are themes around seamless journeys, partnerships, basically working on just not the patient but the family, creating unique solutions for India, like in the less than 100-bed hospitals. I think an openness from the government, being more consultative and being more open to new age models which are emerging is very important as we think about policy. And finally, to Prashant's theme on in a few years, healthiest on the planet, and the lowest chronic disease, and lots to do, and we're at the inflection point. So that's it. Thank you so much, everyone.
Thank you so much.
So thank you, Dhruv. Thank you, Harsha, for having an excellent panel. And I think, Prashant, that might become the tagline. For all you know, if PM Modi hears this, made in India, healed by India can become healthiest in India or something like that. But we are at the end of our 2.5-day conference. Very successful in terms of the attendance we saw, the kind of deliberations we had. We started on Monday with 2 master classes, and some of you attended that. One was on design in healthcare. The other one was on AI in healthcare. And all of you obviously know what we are talking about in AI in healthcare, but I can guarantee you, many of us in the audience had no clue. We all knew that there is AI, but what is AI, we didn't know. So now we are a little bit better educated. Then yesterday, our inaugural session, we had the honor of getting the Vice President of India. So he spoke about that, and he spoke about the Nirogi Kaya followed by Maya. So that was his. Dr. Paul from Niti Aayog. Then we had Dr. Sunil Kumar from Johns Hopkins. Then and we had a very good award ceremony last night, and we had excellent people who have done very well in the country winning awards. And today's celebrations, today's discussions were also very, very good with Mr. Agnani. Yesterday, Ms. Roli Singh was also there, and now with Mr. Arish Sharma from the government. So we've had a lot of support from the government, Niti Aayog, and Ministry of Health and Family Welfare. In fact, we've got the logo support from them, and that's why you can see the government symbol. But I would also like to take this opportunity to acknowledge the organizing committee for this FICCI HEAL and the awards program, and the session conveners. So the conveners, Honorary Brigadier Dr. Arvind Lal, Dr. Narottam Puri, Dr. Alok Roy, Mr. Ashok Kakkar, Mr. Raj Gore, Dr. Atul Kochar, Dr. Harsha Rajaram, Ms. Tulika Puri Katyal, Dr. Vidur Mahajan, the organizing committee chair, Dr. YP Bhatia, Dr. Ravi Gaur, and our knowledge partners have been Srimai Chakrabarti, partner in healthcare for EY Business Consulting, Lalit Mistry, partner and co-head for healthcare sector in KPMG. So we released 2 knowledge papers yesterday, and one was on OncoCare, for which we had a discussion today, and the other one was on resourcing healthcare resources. Again, there was a discussion early morning. And I would also like to take this opportunity to thank the people who paid the money, the sponsors, Intuitive, Dr. Lal Path Labs, Manipal Hospitals, Siemens Healthineers, Wipro GE, Paras Healthcare, PD Hinduja Hospital, Medica Super Speciality Hospital, Xyla Health, Yashoda Super Speciality Hospital, and knowledge partners I mentioned, ENY, KPMG, and of course Bain and Company. So Bain and Company felicitated the session yesterday with Mr. Oli Singh. Quality partners NABH and QCI. Our batch sponsors were Aster, and other sponsors were Apollo, BPL, Kokila Bain, and Medtronic and Pristine. And also I want to thank all the speakers and participants who came, and we met after a long time, 2.5 years. But I'm very happy to meet some of you we've met after a long time. And lastly, the people in the FICCI Secretariat, led by Mr. Praveen Mittal, Sarita ji, Shilpa, and there are many others who are outside whose names I don't know, but I think without their help, it would not be possible. And also I have to say one more thing. We never thank them, but please thank the people who do the housekeeping and who provide the food, because they've been providing tea, coffee and snacks for everybody. But thank you everyone, and hopefully we will have a session next year, September 23. He is already announced. Thank you and all the best.